I'm just
Sure.
handing over the mic to Dr. Ashish to take the proceeding forward.
Thank you, Ashish. Dr. Vivek, on behalf of Advanced Institute of Liver and Biliary Sciences, welcome all the eminent faculty and delegates to our third International Advanced Institute of Liver and Biliary Sciences Conference. I hope and pray for the health of everybody, because last 2 years have been toll taking for everybody because of COVID-19 pandemic. The theme of today's conference is outcomes of liver transplant, present and future, and the format would be mainly panel discussions, because we thought that panel discussions is a way of discussion, because whenever we go for only lectures, we are left with a very short time for discussion. So this time we are giving much more time to discussion than lectures, although there will be few lectures by eminent pioneers of liver transplantation, 4 or 5 lectures. So without further ado, I will ask Dr. Ashish to give a welcome note, and then we can kickstart our first session. Thank you so much.
Distinguished faculty, delegates, colleagues, dear friends and gentlemen. Before I welcome you all, I want to have a moment of silence for a very good friend and a transplant surgeon the transplant community has just lost, Dr. Paolo M.I.C.E, who was the chief of transplant at University of Milan, Italy. He had just passed away 2 days ago because of a medical illness. He was a pioneer in disease donor transplant, living donor transplant, and has excelled the DCD liver transplantation in Europe. I just want to have a minute of silence in regard to him. Thank you. On behalf of the organizing committee, it's a great honor and pleasure for me to welcome you all to the third AILBS International Conference. The theme for this year is Outcomes of Liver Transplantation, Present and Future. This time, the meeting objectives are to discuss and debate over a wide range of risk factors, indication, clinical scenarios, and technical challenges affecting the outcomes during and after the liver transplantation. And we will try to discuss about the ways to avoid, mitigate, and manage them. We will also discuss the new technologies, technical innovations, and therapies which have a role in the present and the future. The meeting will be graced by key opinion leaders presenting the updated scientific literature along with their personal viewpoint. I'm delighted to say that we are getting around 52 faculty from within the India and abroad. And we also have got around 240 registrations, including the trainees in different part of the world, including our own country. At the end, I'm confident that with this meeting will be a success and we'll meet in real world soon. Thank you. Now, I would like to invite Dr. Dharmesh Kapoor for the first session. Dr. Dharmesh Kapoor doesn't need any introduction. He's a senior consultant hepatologist at the Department of Liver Disease and Transplant Surgery at Yashoda Hospital, Hyderabad. Dr. Dharmesh Kapoor will be moderating a panel discussion on the preoperative factors affecting 30-day mortality after liver transplantation. With him, I would like to invite the esteemed panelist, Gokhan Kabakam. Gokhan Kabakam is a good friend and he's a professor in medicine at the Yüksek University School of Medicine, Ankara, Turkey. Gökhan is also a member of the AILBS committee. I would like to also invite Dr. Kaushal Madan, who is a principal director and head of clinical hepatology at M.I.C.E Hospital, Saket. I believe Dr. Prem Kumar is not able to join the meeting, so I would ask my colleague, Dr. Kausar Makki, to be available for this session. Thank you.
Good afternoon, everyone. And thanks, Dr. Singhal, for that introduction. At the outset, again, a mark of respect to Dr. Paolo, who was an esteemed colleague and with whom we had an opportunity to work in Hyderabad for a bit. And without much ado, we'll kickstart this first session. And this session is actually a panel discussion. As has been outlined, this is going to be on the pre-operative factors which affect 30-day mortality after liver transplant. So some housekeeping rules. We will be talking only of adult transplants, the primary transplants, so no retransplants, no acute liver failures, and no contentious indications for transplantation like for colorectal metastasis, cholangiocarcinomas, and the likes. So it is chronic liver disease patients who are the garden variety of patients whom we manage in our day-to-day practice. And to set the ball rolling, I would first request my dear colleague, Dr. Kaushal Madan. We all have learned that he's a very astute clinician and a hepatologist working at M.I.C.E Hospital in New Delhi. So, Dr. Kaushal, the brief given to you is, as a hepatologist, how would you consider the risk that a waitlisted patient has of an early adverse outcome after transplantation? So what is your perspective on this? And maybe you could talk on lines of the liver disease severity scores, organ failure scores, nutritional scores, functional status, frailty, or any other thing that you factor in when you give a nod for a patient to undergo transplant.
Thank you, Dr. Dharmesh. I'll just take a moment to share my slides. Sorry, can you see my slides now? Are my slides visible?
Could you just move them?
I'm moving them.
No, it's not visible, at least not to me.
Okay. Let me, sorry about this. Is it fine now?
Yep, it
Yes,
is.
fine, sir.
Yeah, thank you. Sorry about this. So we'll be talking about pre-op recipient factors affecting short-term post-transplant outcomes. And as Dr. Dharmesh outlined, I think these are the classical factors which have been considered earlier as relative or absolute contraindication in their individual capacity. For example, advanced age, high MELD score, high BMI, presence of diabetes, and a patient on dialysis. However, over last many years and decades, the surgeons as well as physicians have realized that these may actually be relative contraindications in their individual respect. But when combined together, if you have more than one factor, then it's likely that the outcomes are going to be poor. So this is a recent study published in 2021, which calculated a score based on all these 5 parameters from 48,000 patients with a range of the score ranging from 0 to 9, 9 being the maximum. And then they divided the patients into 3 groups: the low risk, 0 to 1 point, intermediate risk, and high risk. And as you can see that the short-term mortality at day 30 as well as 1 year was being driven by presence of more and more of these risk factors. So as the in patients who had high risk group who had more than equal to 4 points, the standardized mortality ratio was significantly higher. So at 1 day, at 30 day, as well as 1 year, these were the patients who were likely to have poorer outcomes. So this is something akin to a metro ticket concept when you are providing transplant for HCC patients. So more number of risk factors added, poorer are the outcomes. You also talked about the organ failure scores, and when we talk about organ failure, I think the best condition to understand that is acute and chronic liver failure. So this was a study by Sundaram et al. More than 3,000 ACLF patients who had grade 3 at listing of these patients, grade 3 ACLF, that means more than equal to 3 organ failures. Now, 2733 of them remained in grade 3 at the time of transplant, and 892 were downstage to ACLF grade 0 to 2. That means their organ failures improved. So just concentrate on this broken black line and the red line. So as you can see that in these two groups, there was a significant difference in both the short-term as well as long-term mortality. So the organ failures, more the number of organ failures, higher are the chances of short-term mortality. And if you are able to stabilize these patients just before transplant, the outcomes are better. And they found that patients who recovered from brain failure, circulatory failure, and mechanical ventilation were the ones who benefited the most from recovery of organ failures. People also talk about patients being in renal failure due to HRS-AKI. This was a study from our center in which 87 patients were treated with a standard medical therapy of HRS. 56 responded, 31 did not respond. But when they were transplanted, you can see there was no difference in terms of short-term survival, 1 month survival between responders and non-responders. So people, especially physicians, they talk a lot about reversal of HRS before subjecting these patients to transplant. But I feel that what will help them, what will make them recover from HRS is transplant and not the standard medical therapy. Ultimately, their long-term survival depends on undergoing a transplant. And we also talked about nutrition. A lot has been said about sarcopenia and frailty these days. Although sarcopenia does affect waitlist mortality and a lot of complications, no study has been able to show that sarcopenia affects post-transplant short-term mortality, although it may have effect on other parameters. For example, this study showed that sarcopenia was an independent predictor of post-operative sepsis as compared to non-sarcopenic patients, and a meta-analysis which suggested that sarcopenia and frailty were associated with longer ICU stay, higher respiratory complications, but again, no effect on short-term mortality. And finally, respiratory failure. This is a study of database from 2006 to 2020 of hepatopulmonary syndrome, that patients in pre-op, if their PO2 was less than 54, they had a higher mortality. And for each 1 millimeter rise in PO2, there was a reduction in mortality. So we've seen that although individually these risk factors may have a effect on immediate post-transplant outcomes, especially mortality, but together, if you have more number of these factors, more number of organ failures, more number of adverse events, adverse factors, together they are able to reduce the short-term mortality. Thank you. Dr. Dharmesh, over to you.
That was very concise, Dr. Kaushal. So what is your take on transplanting patients who present with hepatorenal syndrome or acute kidney injury? So when you talk about response to medical management, are we talking about the International Ascites Club definition? That means you're able to get their creatinine to within 0.3 of their baseline value, or is it just a decline to a value of less than 1.5?
So definition-wise, yes, it should be complete responders are defined as those who have a creatinine value less than 1.5. But if you are just trying to stabilize these patients for transplant, then I think achieving a significant urine output and stabilizing of creatinine should be enough. I think you don't need to wait for the creatinine to come down to 1.5 and then subject them to transplant. I think you'll be wasting a lot of crucial time in that.
Right, because in the current context, we also know from the confirmed trial that the results have shown that patients who are treated with albumin and vasoconstrictors, there is a very high risk of inducing pulmonary complications in them, and that for someone who's waitlisted for transplant might tilt the balance to the other side. So I think that's a very good point that you make, that rather than trying to go to a predefined creatinine value, it might be more useful clinically to have a good urine output in these patients, but at the same time not have any adverse effects developing due to the albumin vasoconstrictor therapy. Dr. Kausa, what's your take when the patients come with acute kidney injury and they are waitlisted for transplant? So what would be the surgeon's perspective? Would the surgeon want the complete normalcy of renal function, or would you be happy to have a patient go from, say, an oliguric acute kidney injury to a non-oliguric acute kidney injury?
Yeah, as long as the patient is producing an urine output, we don't have a problem with the creatinine values. Pre-operatively, we would like them to be on a declining trend, but it's not hard and fast, because not all patients are going to wait and be stable. And of course, a transplant is going to help them.
And supposing we try this cocktail, which is very commonplace, and the patient is not getting better, that the creatinine is creeping up. So what would be your take? So would we wait for transplanting this patient, say in the context of acute on chronic liver failure? So would you want the creatinine to come back to normal, or would you say that I'll bite the bullet and I'll just go ahead and transplant the patient?
So it will depend on why the creatinine is persistently up. If the patient is septic, or once you rule out the factors which are obviously going to be a problem, like sepsis, if those things are ruled out, then we can straight away go for transplant.
Dr. Kavacham, what would be your take on a patient like this? So someone who's not septic, the surveillance cultures are negative, and you treated them adequately with the albumin and vasoconstrictor therapy, but the creatinine refuses to budge, and the creatinine keeps climbing, and so much so that the patient starts to develop acid-base disturbance or hyperkalemia or features of volume overload. So would you subject this patient to a renal replacement therapy, or would you hasten the transplant?
In this patient, if we wait too much and try to stabilize the patient, we can lose very too much time, and we must not be, we may not be successful at all. We know that most of the patients, if they find a donation, a live donation, for example, and if it's quick, this renal function turns back to normal after the transplantation. We should be careful on the patient is not in sepsis, of course. So if the patient is not in sepsis, the infection is under control, that causes the decompensation here, ACLF situation, then I would go for a transplant without waiting too much. And also we know that rather than hemodialysis, if we have the possibility, it would be preferable to choose the hemofiltration, ultrafiltration, rather than hemodialysis, to disturb the hemodynamics of the patient.
Any views on plasma exchange in your part of the world?
Yeah, as a bridge to the transplantation, we frequently use the plasma exchange. If the patient is under a high metabolic demand, the bilirubin level is too high. Even in sometimes sepsis patients, we sometimes use it if there is no live donor transplantation ready. And also in our country, in Turkey, the cadaveric donation is very low. So even though the patient can be an ALF and in status A, we may still choose the live donation if available, of course. So in that bridge time, in a few days, we use plasma exchange.
And may I ask you if it's a standard volume plasma exchange or a large volume plasma exchange?
We use large volume plasma exchange in these patients. Of course,
Right.
the ICU guys, manage these patients. We ask them and we manage them together.
Dr. Dharmesh, just to let you know, Dr. Albert Chan has
Yeah, I
joined.
just saw his question, so I was pleasantly surprised. Yeah, Dr. Albert Chan, please go ahead with your comment and your question.
Hi, nice to see everyone. I'm Albert Chen from Hong Kong. I have a comment and a question. I think the first one is, as a surgeon, I think we always get asked questions when the patient's in hepatorenal syndrome, how far should we go? I mean, obviously the mild type of HRS, when they respond to telepressin and they produce urine, certainly we would go for the liver transplantation. In my center, sometimes these patients run into renal failure and they require renal dialysis. So my question is, if the patient needs to be put on renal dialysis, would these patients still go for transplantations? Because in our center, if the patient is otherwise stable, we will still go ahead, and preferably we would give them a wash before the operation and then go for the operation, and after that we'll put them back on the renal dialysis.
Yes, so I think the message is loud and clear that if a patient is a non-responder to acute kidney injury, someone who's been evaluated and waitlisted for liver transplant, you should not have the patient lingering on a renal support, and these patients should be transplanted sooner than later. So potentially, because when somebody is on an extracorporeal treatment, the risk of infection is very high, whether it's a CVVH or CVVHDF or plasma exchange. And secondly, longer the interval between initiating such a therapy to the time of transplant, worse the outcomes with liver transplant alone. So in the interest of organ stewardship, and if you want to go ahead and just transplant these patients with the liver transplant alone, it probably makes better sense to transplant these patients sooner than later. Dr. Kaushal, what are the potential pitfalls of having patients who are on renal replacement therapy with respect to their early post-operative course?
The electrolyte imbalances and their hemodynamics, I think it becomes difficult to control in the perioperative period. So there have been some centers who've been using intraoperative CRRT to maintain these patients. However, I think the study I talked about, which we published from here, the intraoperative CRRT was not used. Like Dr. Chan said, that they were first stabilized if required with a preoperative dialysis or CRRT, go through the intraoperative period, and if required, then support them postoperatively. So if they do have electrolyte imbalances and instability, that can be managed in the postoperative time. And yes, they will definitely have some stormy postoperative course, but their survival is almost similar to those patients who have responded.
Dr. Chan, your preferences with respect to the choice of renal replacement therapy. So are you going to commit to a particular kind of renal replacement therapy, or would you be fine with anything?
Yeah, well, I think certainly that's in the territory for the intensivists. So normally when our patients come to this stage, they will be in the ICU, but their choice would be the CVVH. That should be the primary mode of renal replacement therapy. But for us, to be honest, as long as this patient is stabilized, the acidosis is corrected by the renal replacement therapy, I don't have much kind of preference one or the other.
Dr. Kabacham, your views on this question?
Yeah, we don't prefer hemodialysis either, and we know that, and we will speak soon about the infectious complications after transplantation, and hemodialysis not only causes metabolic imbalance in some patients, but also the infectious complications are higher in these patients. So I would prefer CVVH as well.
Right. So our center preference is also a gentle kind of an ultrafiltration. So we go with CVVHDF. We try as far as possible to avoid intraoperative renal replacement therapy, but at times one has to go in for it, especially if the patient is not terribly stable and you are expecting that there is bad portal hypertension and the requirement for blood or blood products might be high intraoperatively. So in those situations, one errs on the side of going in for an intraoperative RRT. I think the biggest challenge of using RRT in the post-operative period is coagulopathy, especially when we are doing living donor transplants. The coagulopathy, because the filter clots, the filter lives are terribly short in these patients, and the anticoagulation that one might want to use in this situation might be a little different when we talk of anticoagulation or CVVHDF in the context of acute liver failure. All right. So coming back to the slides which Dr. Kaushal presented, any takers for the liver transplant risk score, Dr. Chan, between you and Dr. Kavacham, and then I'll come to the our Indian panelist. Do you believe in a scoring system to say that yes?
Well, I think let's the yes and no. My answer is I think yes in a way that definitely the scoring system reflect the number of organs in failure, and certainly that would predict the mortality after liver transplantation. So certainly when you talk about 2 or 3 organs simultaneously in failure, certainly the risk is higher. But on the other hand, when you talk about organ failure, there's also a degree of severity as well. Just like what you said about renal failure. I mean, there's a spectrum from just dependent on terlipressin to the spectrum of renal failure and dialysis. So that is quite a wide kind of variation in terms of severity. So just to put it in simple terms, if you just say 1 or 2 organs failure and then you just exclude the patients, maybe too simplifying the situation. And that's why I would look into the kind of severity of the organ failure as well. But to get a quick, on the other hand, if you want to have a kind of an idea how bad the situation is, then certainly the score is a very simplistic way for communication between surgeons and physicians.
Right, and I think Dr. Kaushal Madan emphasized this, and it probably needs to be reiterated that the cerebral function and the respiratory function probably are the keys. So if you have someone who's been ventilated not for protection of airway, but for a higher grade of HE, and this patient also has got iffy oxygenation in spite of being on ventilation, probably that would be a no, at least in our program, for going ahead with the transplant. And one can probably work around the other organ failures.
Yeah, I think that's a very good point you just brought up. I think for the respiratory function, that's quite straightforward to assess the severity. But over the years, the problem that I had is those with hepatic coma, the severity of cerebral edema, how to use that as kind of a decisive factors, whether you would go ahead, because at the end of the day, you want to predict whether this patient can wake up after transplantation. So it's hard to kind of define just simply by imaging. We saw that radiologically could be quite bad cerebral edema, but there were incidents that these patients sometimes they wake up after transplantation and vice versa. So I think the key for discussion is in terms of the neurological point of view, what is the kind of more objective benchmark that when the patients have their kind of abnormality, then you would say no to a transplantation. I think that is more in real practice, that is more relevant in this situation.
Dr. Kavacham, your views on what Dr. Chan just mentioned?
As physicians and surgeons, we and pragmatically speaking, we have to save this patient. And the risk factors, brings about a thin red line that we do not need to cross because we also use the donor for the surgery. We have to take this into consideration. But to save the patient, we in the actual daily practice, we don't usually take these risk factors into account. We go for it. We, if the patient is not in coma, and if he is not an ALF patient, in which there is more pronounced cerebral edema, most of the times stage 3 or even stage 4 encephalopathy comes back to normal after the transplant. It takes some time, more ICU, but we save the patient in the end of the day.
Dr.
So
Kausar, a
the
quick
risk
comment.
factors.
Yeah, please go on, sir. Please complete your sentence. Yeah.
No, yeah. What I want to say is sometimes the risk factors. It comes to me that the risk factors are more for the research basis, not for the daily life. In when we try to save this difficult patient.
Right. Dr. Kausar, a quick comment from your side. So when will you be unhappy to have a patient shifted to the OR when he's been ventilated for, say, a grade 3 or grade 4 HE?
Grade 3, grade 4 HE is not much of a concern because we've very frequently seen patients revert back from HE. More concerning would be probably respiratory. For HE, we do a tracheostomy to tide over the patient till they recover. It's generally the extubation which is delayed, unless they have some irreversible intracerebral problem. As long as we rule out intracerebral bleeding or irrecoverable damage, HE is not a problem.
Right. So I think in the interest of time, we've got just 10 minutes to go. We'll quickly shift gears, and I would now request Dr. Kabacham to dwell on the points which were given to him. So this is to transplant a wait-listed patient after an episode of an infection. So whether it's a spontaneous bacterial peritonitis, urosepsis, skin soft tissue infections, bloodstream infections, or catheter-related infections, or a lower respiratory tract infection with special reference to COVID-19 pneumonitis, because we've seen a lot of that in the last few months. Dr. Kabacham,
Okay,
please.
thank you. Thank you, Dr. Kapoor. You see my slides, right?
Yes, we do. Please go ahead, sir.
Okay. Okay, so my topic here will be to cover about the infections in these patients. And the principles here, we know that infections occur in most of the patients in the early post-transplant period, and the major cause of death in these patients. And signs and symptoms can be attenuated, and it may be difficult to diagnose. And sometimes we see non-infectious causes may mimic the infection, like causing fever, like allograft rejection, medications. And the variety of possible pathogens is quite broad, but it's influenced by the timing of infection. We all know this. Drug interactions are other concern in the antimicrobial treatment, and infection, when it happens, can be more severe and progress more rapidly. So what are the risk factors in these patients? The patient-related and procedure-related risk factors: antibiotic use in the last 4 months, albumin, low albumin, high bili and high melts, ascites, obesity, diabetes, underlying hemochromatosis, malnutrition, sarcopenia, ALF, prolonged hospital stay, ICU stay, and catheterizations are patient-related risk factors. And the procedure-related risk factors are previous surgeries, previous transplantations, anastomotic leaks, bleeding patients, contamination due to GI tract entry, anastomosis, and prolonged surgery. So we know that in the early post-transplant period, the donor-derived and recipient-derived etiologies can be seen in the patient. And as you can see here, there are more antimicrobial resistant species like MRSA, VRE, and carbapenem-resistant Enterobacteriaceae and other infections, including Clostridium difficile. and also some uncommon factors and institution derived factors like aspergillus. And the primary source of early post-transplant infection is abdominal infection and lungs. And all of them are associated with bacteremia. And abdominal abscesses and infections of the peritoneum can result from operative complications, as we know, like biliary leaks, hematomas, and enteric organisms predominate here. Intrahepatic abscesses may manifest as a result of hepatic artery thrombosis or biliary ischemia, or cholangitis may occur after stenosis, biliary tract, and wound infections are common in these patients. So what are the effects of the pre-transplant infections on post-transplant prognosis? We know the main determinant here is the MELD score. The worse the patient's situation, you see more patients with pre-transplant infection, more ICU stay, more dialysis, compared with the patients without pre-transplant infection. And in these patients with or without pre-transplant infection, in the post-transplant period, we see if the patient has pre-transplant infection, post-transplant infections, bacteremia, ICU stays longer. But still, manageable pre-transplant infections would not be an absolute contraindication for liver transplantation. But we have to be alert for the increased risk of post-transplant infection, and prompt, effective antimicrobial coverage are the cornerstones in survival here. Any active infection should be treated before transplant. This is for sure. We have to prevent sepsis because the patient would be obviously immunosuppressive in the post-transplant period. LDLT is advantages in here because we can program it. We can defer it after we treat the patient. We can plan to do it. It's better than DDLT. And very important thing here is center flora and country flora, antibiotic resistance profile, which directly affects the management. There is no certain golden rule or antibiotic that covers all the patients, covers all the different infection sources. Adequately treated pre-transplant infection does not pose a risk for fatality in the post-transplant period as well. You can see here, there's no absolute survival risk. The risk of infection in recipients depend on both the microbial exposure related with the factors that I've already mentioned and the net state of immunosuppression in the patient. If the patient is an ELF or autoimmune hepatitis coming from an immunosuppressive state, even from the pre-transplant time, you can see more infections in these patients. And we know that the mortality depends on the MELD score, the bleeding, the post-transplant infection, but not the pre-transplant infection in many of the studies. SPP here is one of the most common infections we see in the waiting list, and the patients with pre-transplant SPP were more likely to have worse status, and hemodialysis, mechanical ventilation is seen more in these people. And also some infections like UTI, SPP can be related with different, like pneumonia are more frequent in these patients after the transplant. So we have to be careful in the management. So the core points: identification of treatment prior to transplant, latent infections are important, prophylactic strategies to prevent reactivation are important, and drug-resistant organisms are important problem. So selective decontamination is controversial, as we all know. It can provoke antibiotic resistance. Vaccinations are commonly overlooked, so we have to vaccinate these people, including with COVID-19 vaccines. And the recommendations coming from the infectious disease guidelines are piperacillin, tazobactam, or cefotaxime, ampicillin, like broad-spectrum antibiotics. And we give the treatment like for 24 hours or less. For the antifungal, only we give the treatment prophylaxis in the high-risk patients, including in our units. In the recent IRTS ERA's consensus statement, it's also underlined that universal prophylaxis is important, not to exceed 24 hours, both for CMV, antifungal, PGP, is strongly recommended in these patients depending on the center prevalence and flora. Coming to the COVID shortly, the donors recipients require careful assessment for SARS-CoV-2. We know immunosuppression is associated with more severe infection, and in the setting of steroid therapy, bacterial and fungal infections can be seen. Rejection can be related with COVID-19. There is some evidence on this. And we screen all the donors and the recipients by both PCR and radiologic investigations before the transplantation, speaking about the LDLT. And all candidates for transplantation should be vaccinated against the COVID prior to transplantation. We know that the efficacy is low, but still we have to go for it. And the next vaccination should be at least 1 month after the transplantation. If the patient has active respiratory illness, it should be, we defer them for a few weeks after transplantation. But asymptomatic individuals recovered from infection, we go for the transplantation. And we know in some centers, quantitative PCR with cycle threshold testing are used for respiratory evaluation of the COVID for the transplantability. And for the immunosuppression, most of us, I believe, do stop the mycophenolate, and after the infection resolves, we reintroduce the patient. And by this, I would like to remember the good times here, and I would like to say rest in peace, Paulo. Thank you.
Thanks, Dr. Gukhan. That was very lucid. Dr. Kaushal, I think we've already overshot the time for this session. So could you kindly ask your questions directly?
One question was, I mean, I know of some people who believe that for at least some category of patients, a difficult to treat infection, the only treatment may be to give that patient a new liver. So how many of us believe in that? I mean, would you, in some cases, transplant a patient whom you feel is having active sepsis? So that's open to all panelists.
Dr. Kabechan, would you like to take that?
It's a very difficult question. You know, as the pragmatic speaking point of view, we have to save the patient, but the sepsis is the worst scenario to have the transplant and just lose the patient right after the transplantation. So I would first treat the patient, to try to treat the sepsis, then do the transplantation.
Dr. Kaushal, what are your views? When would you say that, okay, I am okay to take this patient to the OR, even though he might have had a microbiologically proven infection, say 3 to 5 days prior to the scheduled date of surgery?
If he is not septic.
All right. So, and how do we define that?
His vitals are well maintained, not deteriorating, and of course, responding to antibiotics.
Dr. Chan, your comments, please.
Yeah, I think in some situations, I do agree that the liver is the source of the sepsis, especially in those with biliary cirrhosis secondary to intrahepatic strictures. We had encountered these situations before, and once with a new liver, the sepsis resolved. It's because of the multiple biliary strictures causing cholangitis, and despite antibiotics, patient was still a bit septic, so we proceed. As long as the blood culture is negative, then I think it's in this situation, I think it's okay to go ahead.
So if someone had a bloodstream infection, how long would you wait before you would say that this patient is okay to be transplanted?
Well, then they need a couple of days of intravenous antibiotics, and strictly speaking, we need to repeat the blood culture after about 3 days of antibiotics, and if that's clear, then we'll go ahead.
Right. So I think the most important takeaway from Dr. Kabacham's talk was that the living donor transplants are programmable. So if your patient is not terribly unwell, you can obviously schedule the timing of your transplant. But having said that, one should factor in the concept of second infections, which are extremely common in patients who are high acuity or ICU bound. So that is something to bear in mind. And second is that if you have an infection, vis-a-vis if you have sepsis, so white cell count, what it does to the hemodynamics, to oxygenation, to renal function. So even though your creatinine might be 0.6, but if it has gone up to 0.9, which is quite within the normal range, or the lactate, which was less than 2, has gone up to say 2.5. So this is a patient whom one should probably refrain from transplanting. So you have to have a mind map as to what is an infection and what is sepsis. So if it is leading to far-reaching consequences, then probably that is a patient one would not want to take to the theater. Of course, this challenge is much greater in deceased donor transplants because you know that you have a serious chance of losing a shot at the organ. What is the group's take on, just last comment.
Yeah,
so what is the group's take on SBP? Because this is a very frequently asked question, and oftentimes you get night calls from other centers saying that somebody had an SPP and there is an organ call available. There is an organ available. So Dr. Kabacham, what is your take? Transplanting patients with SBP who have been on antimicrobial therapy. So what would be your guidance for such a patient?
The condition is very important. If the patient is still septic, she has fever, hypotension, I would not go for the transplantation.
Right. And would you again opt for a negative culture, or would the cell count decline be enough to say that yes, it's okay to go, and this was a sensitive bug? And if the cell count has dropped, the polys have dropped by more than 25%, I would be okay to take this patient to theater, provided there are no other far-reaching effects that we've already discussed.
This is a very nice question. It's very difficult to answer, though. We see the patients, despite having the numbers going down, the patient's condition worsen. So the general situation, the condition is very more important than the numbers here, I think.
Right. Thank you so much, Dr. Kausar. My apologies. We couldn't direct the questions that were meant for you, but I think in the interest of time, we just need to pass it back to the organizers. And again, my gratitude for this opportunity. Thank all the panelists for their active participation, and was pleasantly surprised by Dr. Chan's presence. Thank you so much.
Thank you, Doctor. Thank you very much for the fantastic session, and thank you, the panelists. And now I'll invite Kausar to proceed for the next session.
For the next session, we have difficult recipient hepatectomy, technical challenges and troubleshooting. For this, I would like to invite Dr. Subhash Gupta, Chairman M.I.C.E Center of Liver and Biliary Sciences, New Delhi. I would also like to invite the chairpersons for the session, Dr. Alan Contreras, Surgical Director of Liver Transplant Program at Salt Lake City, Dr. Thiago Bedushi, Chief of Division of Transplant and Hepatobiliary Surgery at Florida, Dr. Vinendra Pamecha, Professor and Head of Transplant at AILBS, and Dr. Vivek, heading the AILBS.
I welcome Professor Subhash Gupta for this talk. When I thought about difficult recipient hepatectomy, I think Professor Gupta came into my mind because he's such an excellent surgeon and a human being, and we all learned from him. Sir, it would be our honor to listen to you about difficult recipient hepatectomy. Waiting eagerly.
Thank you so much. I hope you can hear me, and it's so nice to be part of this meeting. Though perhaps I have one complaint to make. I thought it would be a physical meeting now that the COVID is over. We could have loved to interact with you guys once again, particularly Kausar, whom I remember so fondly. Anyway, I'll begin my screen share. If that is possible, let me see. Yeah, no. Where's this? Okay. Yeah, can you see my? No, not yet. Okay. So can you see my screen? I can't hear anyone.
Yes, we can see your screen, sir.
Yeah. Oh, thank you. So we'll, I think we're running a bit late, so I don't want to add to the cumulative delay. So I'll be quick and efficient. So this is a very important topic because I think the recipient hepatectomy sets the ball rolling for what is going to happen subsequently to the patient. So when I was thinking about this, a number of situations came to my mind, which I thought were sort of where there could be difficult recipient hepatectomy. One could be a simple reason that getting into the abdomen is difficult, something like a cocoon or previous surgery or a huge liver like in polycystic liver. And sometimes we're seeing that the liver is sort of densely adherent to the spleen and you cannot separate it. There is hepatic or portal venous thrombosis, and the special situations such as ACLF livers. I was interested in the previous discussion where the people said that if there's infection, you can't do transplant. That means most of ACLF, which is at least in the Western EASL and the sort of American consortium, all ACLF is from infection. And therefore, none of them would qualify for transplantation. Anyway, so these are plus recipients with renal impairment, retransplantation, and salvage transplantation. And I think salvage transplantation is perhaps the most difficult of all than any of the sort of situations that we have. So between LD-LT and DD-LT, there are differences. And these differences, I think to this audience, they're well known. But just to highlight that they're not the same operation because, the IVC can be removed with R block in DDLT. Bile duct can be divided low, whereas you need to divide high and sometimes have multiple ducts. Similarly, with portal vein, hepatic arteries, quite often, particularly if you're doing pediatric transplants, you need to have 2-3 arteries. And bypass is may be needed in DDLT, but rarely needed in LDLT. And reperfusion injury, of which there's so much discussion in the DDLT literature, is absent in LDLT. So, as I said at the introduction, recipient hepatectomy sets the tone for what is going to happen later on. But what is interesting is that although the recipient surgery may be accompanied with a lot of blood loss, but interestingly, this will not translate into respiratory changes post-operatively. I mean, for example, if somebody had a Whipple's operation, lost 20 units of blood during the procedure, there's no way that the person will not have major respiratory issues post-transplantation, whereas this does not happen in liver transplantation. And the only reason I can think of is because the new liver which comes in has not been exposed to the blood loss. Now, we were taught that big surgeons should give big incisions, but actually in the context of liver transplantation, this is probably not right. And perhaps we should restrict to only as much as anterior axillary line. We all remember that how we have suffered with necrotizing fasciitis when the incision extends far too laterally. This often means that you may have a difficult to access the undersurface of the liver, but the good thing is that the liver, even if it gets damaged, is going to get thrown into the bin, so it doesn't really matter. So once you have, so when you have difficult access from previous abdominal surgery, one is the liver is big and nowadays made life difficult for ourselves by having smaller and smaller incisions. Then you have a situation where there is previous abdominal surgery. And here it's important that after you made the initial incision, the plane to be entered is the plane between the liver and parietes. You do not go towards the sort of infracolic side at all. So you approach sort of the undersurface of the liver is approached from top to bottom, and the hilum is approached from right to left rather than from anterior to posterior. John Buckles, who was like taught me most of the things that I know today, used to call this the extraperitoneal approach. And when you have a situation like this where you have multiple dense adhesions, then it's important that the bile duct must be preserved, because roux limbs are going to be next to impossible to create. And while sort of anticipating such a situation, a graft with a single duct may be helpful, because you may not be able to have multiple openings. You may not have access. So there's one situation here where you have a huge liver, and this liver we took out from a 57-year-old lady who had both combined liver and kidney transplant, a huge polycystic liver. And this liver weighed 10 kgs, and it was a nightmare just taking this liver out. Or you have situations where the liver is draped over the spleen, and there is a kind of portosystemic connection. And here it may be better to sort of leave a sliver of the liver onto the spleen by using harmonic scalpel in dividing the liver. You have an abdominal cocoon, and as I said, if you have a situation like this, then you don't try and enter not get into the cocoon side at all, minimal infracolic dissection, and preserve the bile duct. Now, one interesting thing that we've learned over the years, sometimes we encounter TB, and we often sort of wondered and discussed with our physician colleagues what to do. Sometimes you sort of abandon the surgery. But generally, what we've learned is that if you abandon, then these patients die. And we find it easier to treat active tuberculosis after a successful surgery. And we have actually quite a few cases like this now. Now we come on to another situation where we have a difficult hepatectomy, which is Budd-Chiari syndrome, and particularly LDLT, where the grafts are a little bit difficult to obtain. And Dr. Wedge and others sort of published that they could attach the liver to the right atrium. But we published, last year, we published this in Experimental Clinical Transplantation. We did 36 cases of Budd-Chiari syndrome, and whom we divided into 4 categories: those with stenosed hepatic vein, type 2 with hepatic vein stenosis, caval stenosis, type 3 was obliterated cava above the level of renal vein, and then you had another type where it was the narrowing extended below the renal vein. And these were sort of, majority were of course type 1 and type 2, but we had a few of the other types as well. And for type 1, where only the hepatic veins are, then obviously it's relatively easy. In type 2, the cava is opened by a long cavotomy, thrombectomy done, and the loss of caval diameter is replaced with a vein patch, a PTFE graft. And type 3 with the IVC replacement was done with autologous graft for anastomos suprahepatic cava. And type 4 patients underwent combined surgery followed by interventional radiology. So the Budd-Chiari could be another difficult situation. Then you have bleeding, which can be sort of make hepatectomy very difficult. And for a long time, we realized that liver surgery and bleeding often go hand in hand, and higher the sort of blood rate, higher the infective issues. And even if you have malignancies, then short-term survival. So then numerous maneuvers have been described where you can reduce bleeding. You have the Pringle maneuver, we all are very familiar with it, and doesn't alarm the anesthetist too much. Sometimes, of course, in the DDLT era, this was quite popular. We put a clamp across the free edge of the gastrohepatic momentum, you clamp below and top, and then you took everything out while the patient was on bypass, and then you repaired everything, and then sort of released the clamp. So, or did a cavostomy. So this was quite popular, total vascular exclusion, but it's not something that one would want to do because there are major hemodynamic changes. Occasionally, we end up doing this because there may be some rent in the cava and air embolism needs to be avoided. So low CVP is important in sort of donor surgery, it's equally important in recipient surgery. And nowadays, many of our sort of anesthetists are very comfortable by maintaining the blood pressure with inotropes rather than with fluid. And there's one situation where you don't have a very friendly anesthetist who will not keep the CVP low, then you can just clamp the cava below, which automatically reduces the CVP, and you can then reduce the blood loss and proceed with safe surgery. Or there have been sort of situations where we had to resort to a TIPS shunt 2 weeks prior to the planned surgery because there have been multiple previous surgeries, and we did this in 2 different cases, and interestingly, we did not lose any blood. Of course, the patient must be stable enough to wait 2 weeks for the transplant, which sometimes nowadays is so difficult because the kind of patients that we are doing are sicker and sicker varieties. So what about cell saver bleeding? We have not used it much, but of course, in situations where there's going to be enormous blood loss and the blood bank officer is going to be difficult with you, then this may be important. But we've seen increased infective episodes. And then I'm told that there's a sort of a lipid filter which the cardiothoracic people use, but we don't have access to it. So you can have fat embolism and neurological complications, and certainly cannot be used in HCC or those with previous HCC. So there's one situation where neat dissection, the cava has been mobilized, what we call the phrenocaval dissection, and you can then do side clamps and anastomosis. Well, one of the most difficult situations I find is when somebody has portal vein thrombosis, there's porosystemic shunting, and you have to dissect out these collaterals and tie them, because if you don't, then post-operatively they'll end up with portal vein thrombosis. And so this I find one of the very difficult situations. In the past, we would just sort of ligate the left renal vein, but we found that that was not a good thing to do. Many of them had renal dysfunction post-operatively, and therefore we've now actually tend to isolate the shunt and ligate it. Then, of course, during recipient hepatectomy, you have well-preserved bile duct, helps in preventing late sort of biliary complication. What about portacable shunts in a difficult hepatectomy? I said in a difficult hepatectomy, you put clamps across the free edge of gastrohepatic omentum, bottom and top clamps, remove the liver out, and then make a sort of shunt, and then you can release the clamps afterwards. So portacable shunt, therefore, in a difficult hepatectomy definitely has a role, but we as a group do it routinely because we once the liver comes out, we take the portal vein graft out from there and do some back wedge one. So that's usually about 1 to 2 hours. We have situations where you have a difficult hepatectomy and suddenly a big cavity and a small graft. So this is a situation we often face. So we tend to plicate the diaphragm and reconstruct inferior hepatic veins. And we published this again last year, showing that reconstruction of inferior hepatic veins, even if they were thrombosed, helped improve the outcome because it aligned the graft in the right position. Portal vein thrombosis, this is again will often lead to a difficult thrombectomy. And long time ago with Dr. Vij and Manav and others, we published one case where we did this was the first reported case of living donor liver transplantation for portal biliopathy, for complete portal vein thrombosis. And subsequently, we published again on absent portal vein malformation. There is a portal vein with complete thrombosis, and something that I would like to share, something that we've developed over the years. One is eccentric thrombosis, a bigger concern than complete thrombosis, thrombi, because obviously eccentric thrombosis can crack and the vein can tear. So if the portal vein is densely adherent, what we tend to do is we clamp the porta, divide high up, introduce a sucker into the portal vein down into the SMV, and then turn that sucker towards the splenic vein. And then we put an extension graft to the common cuff of divided right and left portal vein, and then create a shunt. And this technique seems to work well in patients who have complete portal vein thrombosis. And there's a variety of procedures where we have used in where the recipient has had portal vein thrombosis. So we had 16 patients of complete portal vein thrombosis. We lost one case from HAT, and as the hepatic artery is distended, because it carries much more hepatic blood, it tends to be thin and tends to dissect easily. And in follow-up, we lost one patient and 15 are still alive and well. Salvage transplantation is one of the most difficult situations to do, because there's dense adhesions. The family, you already known them for years, and suddenly, if you lose them at surgery, it's not so good. So you're always under pressure, and there is the planes are lost. So I tend to say that the gallbladder should not be removed if you're going to be thinking of salvage transplantation later on. So what about TACE, SBRT in hepatic artery? This is one situation where you can end up with hepatic artery dissection. So be careful. And we have a situation here where you can see that what was thought to be a lymph node post-TACE was actually a pseudoaneurysm. And occasionally, if you will encounter a situation where you have a huge spleen, that you'll find that the flow to the liver is reduced, and you may have to do splenic artery embolization. Which brings me to the end of my talk, and I would thank the organizers, particularly Dr. Vej and Kausar, for giving me this opportunity and to talk about difficult hepatectomy, which quite often is there. I will not deal about special situations which we encounter nowadays, ACLF and patients with renal failure, because there the problem is not so much technical, but more physiological. Thank you very much for your attention.
Thank you very much, Dr. Gupta. It was amazing, and you actually took us through the experience of years in few slides. It was really awesome. So my small question to you, as a pioneer surgeon, there are two types of surgeons, I think. Number one, surgeons, when they start dissecting for the difficult recipient, they allow the bleeding to happen and then proceed fast. And there are certain people who try to control the bleeding and then proceed. So what is your strategy, and what do you think is the best strategy?
A very interesting question. It depends really on the anesthetist. Sometimes the anesthetists are able to catch up with your losses and blood products. But if you continue losing too much blood, then and your anesthetist hasn't caught up, then you can be in big trouble, because you then get into a even after you've done the procedure, the peritoneum will continue to ooze. But if you have an anesthetist who catches up on the blood loss and blood products, and then obviously if you do it quickly, then he'll have a better chance in reaching hemostasis. But we've lost some patients where we've tried to do fast thinking, but by that time you've ended up in a difficult, what we call the red ink syndrome. Instead of blood, there's ink flowing, and you cannot do anything about it. But in some situations, there is no other way except a fast hepatectomy. And those situations are where you have, say, a portal vein thrombosis, or where you have something like, you just have to put clamps, take it out, and hope for the best. There are situations like that. I
think the worst situation is when you're letting the bleeding happen and not proceeding with the surgery. Yeah. I think that is the worst situation. Yeah, if you're able to proceed, then you should control the bleeding and let the bleeding happen and finish it off. But if you're not able to proceed, bleeding will continue happening, and that, of course, ink sign will be there. Professor Pamecha, any comments on this? Not able to hear you. No.
You can type, I think.
I think some technical issue.
So a question from me, sir. So nice to hear from you after such a long time.
Hi, Kausar. Hi.
Hi, sir. Sir, so for portal cavernoma, any strategies?
Yes, that by itself is a. I think we published this, wrote in some article somewhere. I think there's no true thing as a complete portal vein thrombosis. Why I say that? Because a person is eating, drinking, and doesn't have intestinal angina. So blood is going into the intestine. It has to drain out through some collateral. It cannot drain out through capillaries. Now, the modern day CT angiogram helped us a lot in identifying these collaterals. And the numerous reports now of, transplanting with to cavernoma, either to a graft. I mean, I have a huge number of cases. Perhaps if you guys give us an opportunity next year, then we can share you what we do with portal cavern. You can always find a graftable sort of collateral which is thick enough, and over a period of time, we've had one or two situations later on. These patients have had refractory ascites, so we went on to do a splenic artery embolization at that stage, and that solved it. But I think portal cavernoma should not be contraindication for transplantation anymore. In fact, we did one last week as well, where we had complete sort of cavernoma, but we found a collateral and we were able to do it.
Thank you so much, sir. We are open to questions.
Yes, Dr. Pamecha. I think you are muted. Can you?
Yeah, he's muted.
Yeah. Are you using headphone, Dr. Pamecha? Earphones? Can you? Not able to hear you. Yeah. In between. Anyways, I think he will rejoin. Regarding your question, Dr. Kosser, I'll also like to share my view about collaterals and portal cavernomas. I think we also did many cases. Sir, we wanted to ask you about your experience about if there is no major collateral and we don't find any portal vein. So in few cases, what we have done is close the bile duct and pericholedochal collaterals. We have drained it into a big vein, and then it also works really well. Initially, it looks like that collaterals are small, but when we drain them, they actually swell up with the flow.
Yeah. What we've tended to do in this situation with the one I described last time was that we made a Y graft. So we sort of, where the portal vein should be, we would join one end of it and augmented the supply from the choledochal varix. So that later on, the interventional radiologist could, theoretically open up this portal vein as well, rather than trying to do it pre-operative. Some groups have favored pre-operative sort of opening of portal vein, but I find that difficult.
Right. And very interestingly, you mentioned about pre-transplant tips just to ease the surgery. I think it's a very innovative way to. I never thought of that. And any suggestions?
I think the first one we did when you were in Apollo, I remember that, I think you were there. That was a lady who had multiple sort of surgeries, hepaticojejunostomies. And I, in fact, had to persuade Dr. Rastogi to do the tips. I was most reluctant. I said, this person's scheduled for transplantation. And we did that surgery, I remember, without a single unit blood loss.
Right, so I think Dr. Pamecha is here. We should be able to hear him now.
Okay. Vivek, can you hear me now?
I can hear you.
You can hear me. Okay. Vivek, can you?
Yes.
Okay. Yeah. Thanks, Vivek, for inviting. And excellent talk, Professor Gupta. Really enjoyed it. So just one question. What's your thought about doing an early shunt? Just when you go in, you anticipate that it's going to be a bit difficult, especially retroperitoneal dissection, and to just do the hilum first and do an early shunt rather than do the mobilization first and then go in.
Yeah, that could be a good solution, provided that the portal vein can be accessed easily. Sometimes I find that it's not so easy to access. Then, in which case, you have to do. If you can access it easily, then obviously a shunt would help us in reducing the. But what we learned from our TIPS experience was that if you did the TIPS and did the operation 2-3 days later, then it didn't help. You need to perhaps wait 2 weeks for the portal hypertension sort of collaterals to decrease in size and become like in a normal person. But so, for example, you did a TIPS and did a sort of surgery next day, then it perhaps I feel it will not help. Whereas if you wait 2 weeks, then the portal hypertension would obviously be gone. But so sort of extending that analogy to what you're saying, I'm not sure how much it would help if you did it sort of on table and expected portal hypertension to come down immediately. But yes, if the portal vein can be accessible. What we've done in situations, sometimes when we operate for people with complete portal vein thrombosis, we don't start the donor surgery, but we try and make a sort of extend, we dissect the collateral, make a sort of a join a vein to it, see how much is the flow through it, only then proceed with the rest of the sort of, then we start the donor operation rest of the. So we found that situation to be very helpful because, then you haven't harmed either the donor or the recipient if you've not been able to proceed. So we've done that on at least 3-4 occasions where we sort of identified a collateral, made a join to it and seen the flow on it.
Yeah, that's one thing. Just one more query I wanted to ask you, and your comment on that. That in patients with extensive portal vein thrombosis, many times occasionally it happens that you remove most of it, but still you can feel part of it below the junction, the SMV and splenic vein junction, and there is always a lot of temptation to try and take it out. So I just wanted your comment. What's your thought about it? You should be tempted to take it out?
You should not be tempted to take it out. I think you'll cause disaster. If you get a flow at that time, you just do it and leave the interventional radiologists to deal with it later. They can do much better job of us than, I think one should not be tempted at all. I mean, one should just leave it. As long as you get a good flow, we should just leave it at that.
So in some cases, just to respond, Professor Pamicha, in about 3 cases, what we did was, because the thrombus was extended to SMV and splenic vein, we did retropancreatic tunneling, took the portal vein out on the infrapancreatic compartment, looped the splenic vein and then completely did the thrombectomy and then pushed the portal vein. Because portal vein is thrombosed, it's easy to make tunnel. It's not difficult at all. It's easy to pull it out from the under the pancreas to the supracholic compartment. So that's sometimes we do that.
Yeah, that's a good technique. And but I think the specific question Dr. Pamicha is asking, that should you remove all the clots inside? I think
no. That's not.
That is
You're right. I agree with you.
That's the message. Actually, I just wanted that you should not be tempted to take it out. And I would be very skeptical in dissecting retropancreatic, and then you can actually land up with more problem.
Yeah.
So as long as you can get a good flow, you should be okay. Rather than cleaning up everything.
Yeah. Professor Gupta, Ashish this side.
Yes.
I just want to have a question. In the case of complete portal vein thrombosis, was there any scenario that you couldn't have the thrombectomy done? Any scenario experience with portal vein arterialization?
I know a lot of people talk about portal vein arterialization, but I think portal vein arterialization does not solve your problem. There is portal vein thrombosis, as I said, that if there is no such thing as portal vein thrombosis because a person doesn't have intestinal symptoms, it doesn't have angina, then all the intestinal blood, and which is quite a lot of it, cannot drain out of the intestine from capillaries. There has to be collateral, somewhere decent large enough collateral for blood to flow. Otherwise, it's impossible to imagine that the intestinal blood is going into the intestine, person able to have a meal, and his blood is draining out through capillaries. It's not possible. It has to drain through some collateral somewhere, and we need to identify the collateral on CT. So your specific question was, what happens if there's complete portal vein thrombosis? What are the alternatives? There are alternatives, of course, portal transposition, arterialization, cavoportal transposition. But I think attempts should be made to somehow get some portal vein flow going. Because subsequently, the interventional radiologists nowadays are very good. They can open up very, very densely adherent portal veins. If you have a patient with a sort of working liver who's otherwise well, they can. The only problem these people have is ascites, and they can quite easily open up these veins later on, which is the strategy we've tended to adopt.
All right. Thank you.
So thank you, Ashish. Thank you, Professor Gupta. In interest of time, I think we'll proceed to the next session.
Thank you so much.
It was wonderful to listen to you once again. Thank you, Professor Pamecha, for your insightful inputs. So now we will proceed to the next session, which is a panel discussion on vascular issues during liver transplantation. Moderator would be my friend Ravi Mohanka, with the panelists of Abhinav Humar, Professor Humar. Professor Humar is here.
He's the Chief Division of Abdominal Transplant Surgery, and Thomas Starzl, Professor in Transplant Surgery at University of Pittsburgh Medical Center, States. We have Dr. Metu Srinivas Reddy, who's a Director of Department of Liver Transplant and HPB Surgery at Gleneagles Global Health Hospital at Chennai. Eduardo Fernandez, who's a Professor of Surgery at Rio de Janeiro Federal University and Chief of Abdominal Surgical Oncology and Transplantation. And he's a transplant surgeon at São Lucas Hospital, Copacabana, Brazil. And unfortunately, Dr. Sanjay Goja won't be able to join because of some family emergency. I think I welcome you all, and this is over to now, Dr. Ravi Mohanka.
Thank you. Thanks a lot. So, very glad to have participation from such eminent panelists. And we'll start off right away with the discussion. So the discussion for today is vascular issues in liver transplantation. We're restricting our discussion to intraoperative vascular issues, because there's such a large gamut of things that we could discuss, and some of it has been discussed very well in the previous talk by Dr. Gupta. So first, hepatic arterial issues, and we will discuss two issues, the dissection and poor flow in the artery. So this is one of the most dreaded things that any transplant surgeons would like to see during the transplant is a dissection, the characteristic look and feel of it. And we are all familiar with what the causes are. I would like all of the panelists to sort of elaborate on what are these some of the causes that they have encountered, and any comments about these. Starting with Dr. Humar, please. Or Dr. Fernandez?
Yes. Oh, hello, guys. Can you hear me?
Yes, yes.
Well, first of all, it's a great pleasure to be here. My friend Ashish and many other friends around India and around the globe. It's a great honor. And indeed, Dr. Ravi, you made it easy for us to organizing this discussion. And obviously, in this slide, we can see pretty much all the aspects of some intimal dissection problems. And you highlighted maybe pretty much all the issues. And I want to highlight, just to be pretty quick, we don't have too much time, but I think the interventional radiology procedures on the arteries, that is a major issue. Some centers are doing too much stasis sometimes, and once we get into the case, the arteries are completely damaged by the hemembolization. So we should think about doing hemembolization in cases in transplantable patients, because we have arteries, especially on living donor liver transplants. For example, in Brazil, the majority of cases that we do living donors here is different from India, because we have a lot of donors, cadaveric donors right now. So we do living donors for patients with beyond HCC Milan criteria cases, so because they are not able to get the cadaveric graft. So if we have a potential case for living donor, there is no reason to do too much stasis, because we're going to damage the artery. So that's my comment on this. And related to the vascular clamp is also issue. We have to be careful in insertion clamps in difficult arteries, because as you mentioned here, we can traumatize the arteries and cause intimal dissection. So that's a very good things that you point out, Dr. Ravi.
Sure. Dr. Srinivas Reddy, anything to add to this? Unmute, please.
Thanks, Ravi. I think all these cases, all these causes will contribute to increasing the risk. I think, but the most important thing is handling during dissection, during the highlight dissection. I think you need to be very careful, and especially when we tie these arteries or ligate these arteries at the hilum. I think we need to be very careful. So we always put a bulldog clamp proximal to where we tie, so the artery is completely collapsed when we tie it. And I know that some centers don't even tie it; they just put bulldogs and divide it. I think that's also a good technique. I know you clamp the hilum early on, which is I think a very safe thing to do. Even I've started doing that when the hilum is a bit sticky, then get to the base of the artery, put a bulldog there so that the artery is slowed down. Then we can safely dissect. I think handling the arteries is the key to avoiding dissection.
So one of the things that we've started doing recently in the last few years is to isolate the portal vein and keep the rest of the porta en masse, and then just dissect it after the clamping. So it's mostly like cold dissection on the artery rather than any warm dissection. So we go to the next point. So what are your tips to avoid dissection? What is the type of clamp do you use for the hepatic arteries? Just bulldog, or do you use something else? And secondly, do you flush the graft artery on the bench to avoid any dissection on the donor side, on the graft side? Do you flush the graft artery on the bench? So these two address to all three panelists, starting with Dr. Humar again.
Hi, Ravi. Thanks.
Hi.
So I just want to reiterate some of what Srinivas has already pointed out, that I think, you don't want to be in the situation where you have hepatic artery dissection. I think that's the prevention is still the best way, and that it's generally a technical thing of how you handle the artery. These things often the start point are at where you shear a branch off, and often these small little branches that get sheared off as you're dissecting the artery are the lead points for the intimal dissection. So your point of clamping the artery proximally before you do all of that dissection, that's a very good point. And we often do that we'll dissect out the artery very proximal, just put a little bulldog on it, and then do the hilar dissection, and it's without that pressure in there, it's safe. And as Srinivas mentioned, the tying off of the artery you have to be careful for. And again, we just put a little bulldog on them. And in terms of the type of clamp, we never use those big clamps where you're having to clamp down on it. We just use those little disposable type plastic bulldogs that are very soft. They have little felt liners on the inside, and they're often they're almost always good enough to hold that artery. If they're not, you just put two of them together, and they'll hold the artery. So I think those are much softer and much more gentle on the artery. In terms of flushing the graft artery, I think that is a point where you have to be careful because you're right, putting things inside that artery can lead to trauma, and all you need is a little tear in the intima up higher that you don't recognize, and that'll serve as the point for when you reperfuse for getting an intimal dissection after reperfusion. So I think you have to be very careful if you're going to flush that graft artery. We do flush it, but we use a very small, soft angiocath and flush with a very small amount of fluid, not under pressure, just very gently flush a very small amount. And I don't really know if you need to or not. You probably don't need to. So that is a valid point.
So Dr. Fernandez?
Yes, I think all the comments were perfect, but I think we should divide the discussion because the artery dissection is different when you use a living donor liver transplant and cadaveric transplant. It's a completely different operation.
Absolutely.
So at least in my perspective, the strategy is completely different. So in living donor, I think we all know that we should dissect as minimum as possible. We don't want to dearterialize the bile duct, so the artery dissection is very different from the cadaveric transplant. So on cadaveric transplant, I do dissect. I ligate the GDA routinely, so I go further down. I usually do the anastomosis below the GDA, or sometimes using the Cahel patch on the GDA. So the dissection is a little bit widely than the living donor case. And we do flush on the bench on cadaveric for sure, because we have ischemia time. And on living donor, it's not a big deal, but basically we also flush a little bit, very gentle, as Dr. Hamad just said. And but we do flush, and I think it's important to flush the arteries and also the ducts.
Yeah. Dr. Srinivas Reddy?
Thanks. I think flushing in the LDLT graft, I mean, personally, I think it's better to flush it because, to clear out the small, because we don't routinely give heparin at the time of cross-clamping in most centers. So, there might be small clots. There is a technique, what Professor always used to do. So, I mean, that's what we used to do for a long time, which is retrograde flushing. So we close the hepatic veins and flush to the portal veins. So there's back flush from the artery. So that clears the artery quite well. The other way is we carefully cannulate the artery itself. So you have to do it. I mean, the senior most person has to do it. Cannulate the artery and just keep it in place. Soft catheter, keep in place and run instead of. I've seen people using syringes, 20 ml syringes, and repeatedly flushing the artery. Problem is, every time you pass the catheter into the artery and take it out, there's a risk of injury. So gently pass the catheter in, hold it in place, and then run some fluid into it, and that should be enough.
So, and if we do land up with a dissection, despite all the handling precautions and everything we do, if we do land up in this situation, in what order will you try to salvage these patients? So obviously there are several options to do that. What is your preference so we discussed how to avoid a dissection, and all these points we did discuss, and retrograde flushing just discussed. So let's go to how will you address, or how will you come out of the situation where an artery has been dissected? So there's a little outline here for discussion. We'll start with Dr. Humargan.
So I think you've outlined it very well. You want to find the artery that's not dissected, essentially. Where the intima and adventitia are essentially opposed, and often the dissection will travel to the first major branch point. So if it starts quite distal, sometimes it'll end right at the GDA takeoff. And if you just go beyond that, the artery is okay. So as a first, I would just mobilize the artery to just proximal from there. Now, when you're mobilizing, you have to be careful, because if you've got a distal dissection, as you mobilize it further, that intimal dissection will just keep traveling further proximally. So again, that's very important that you put a little bulldog as far proximal as you can in that type of situation to try to minimize the risk of that. And if you can actually see where the dissection goes to, if you just put a clip just proximal to that, you can prevent the dissection from traveling further. So if you can get to a point where the artery is normal looking, then yes, I think that's the best thing, and you can go there. But in many times, once the dissection starts, it'll go all the way proximal right to sort of the to the celiac axis, in fact, and in which case then our preference then is to dissect out the celiac axis. And again, I prefer to put like a hemoclip right at the origin of the common hepatic, because I'm always worried that it's going to travel further proximal and affect the splenic artery, which you want to preserve, because we often use the splenic artery then in that situation as the inflow, mobilize the splenic artery and then just flip it over and utilize that as one of the possibilities for extra anatomic flow. But there's lots of other options for extra anatomic outflow, including the gastroepicloic and various other arteries. Or as a last resort, I would use a conduit from the aorta. But again, if you need to do it, you can. The trick on those is to taper the graft and make sure it's an appropriate size thing is eventually when you're going to sew it to your hepatic artery. That I think is a key thing.
Mm-hmm. So if we, so this is a interesting paper regarding the dissection by Dr. Subhash Gupta's group, where they've classified them into 4 types and also laid out different strategies for each type. So Dr. Fernandez, any comments on this classification?
Yeah, first of all, again, we have to divide the discussion of living donor transplant and cadaveric transplant, because arteries, the strategies are different, and living donor, we have a discrepancy. Usually, we are dealing with left lobe or right lobe. The arteries are tiny in comparing to cadaveric transplants. And I don't know in India, but in Brazil, and I think in the United States, the most common indication for transplant in our setting is NASH today. And those patients have a very nasty artery. And this discussion is still even stronger because we are dealing with patients with, metabolic disease. The arteries are quite bad. And so we know that those arteries are very damaged. So if you're dealing with a young patient and if the artery is good, you're not going to have a problem with the artery, unless you're going to maybe bovie the artery or something like this. But in that classification, and recently my friend Henrik Petrovic, he just presented us the same idea. I think that Dr. Humer was saying that he preferred to put a bulldog clamp on the artery and then start the dissection. So this is a good tip. And this classification is quite interesting because on the type 4, for example, you have an intimal dissection all the way down to the celiac. And then you will have problems. And I think all of us have faced this type 4. And this is a big problem. So you need to go for another option. And sometimes if you have a living donor transplant in a type 4, if you need to put a jump graft on the aorta, for example, you have at the distal part, the discrepancy for tiny arteries. So this is a major problem. We should avoid the type 4.
Sure. And Srinivas Reddy, so what if you have an intimal dissection on the graft side? So there are 2 papers to address this, and one of them is, gives it by the degree of dissection and, suggests a different strategy for that. What would you think? What would you say about this one and the next slide where the intimal dissection is by Dr. Subhash Gupta's team?
So this is so this is on the graft artery.
Graft side, yes.
during the donor hepatectomy, or is it
No, I discovered at any stage, generally on the bench or at the donor hepatectomy stage. Yeah.
Okay. I mean, if it's a small dissection, usually where the artery is cut, you might have a little bit of dissection. Then it's best is to trim back. Personally, I've never had to do the intimal fixation for the donor artery. If there is a little bit of dissection, just cut back to where there is it's a bit more healthy.
This is the other technique that has been suggested to fix the dissection. You know, so start with a 12 o'clock stitch, go to a 6 o'clock, and then 3 and 9. So basically 4 stitches to fix the dissection. Now, regarding extra anatomic arterial inflow, what is your preference? You have written a paper on this, and you know, it will be next. But what is your preference?
This is actually a technique described by Professor Rela actually. So it's his technique, and it's very useful. I think when we published it, I think a couple of years ago, a series of 10 patients. So what we use is the retrograde GDA inflow. So normally, like you said, the artery dissects down. Like Dr. Kumar said, that usually the GDA is preserved, but the artery dissects down to the celiac axis. So in that case, we mobilize the GDA without dividing too many of the branches, and we cut it onto the stitches. So you get the GDA is usually never dissected, and then we use that as an inflow. I know when we wrote this paper, there were some comments about, you know, the flow is not sufficient, but the flow is always sufficient, and we never had any problems actually with low flow after this kind of anastomosis. And we use this technique, I mean, again, it's described by Professor Rela, where we use this as an arterial inflow for the right lobe auxiliary transplant, or, you know, use that as an inflow for a right lobe when we do a left lobe auxiliary. So it works quite well. And this is what our preference is. And it usually comes to the graft. If we mobilize the cochlear duodenum a bit, it usually comes to the graft.
So next is, you know, as just a description of what kinds of interposition grafts are typically used by most people, and most of us prefer to use an intrarenal graft just for completion's sake. So next important topic, and a quick one, will be about low hepatic arterial flow with because of a median arcuate ligament. So if you do find this before the transplant or during the transplant, and find low hepatic artery flow during the transplant, what would be your preference? How would you try to fix it? Dr. Umar, please.
Well, often you can just dissect that out. If medial arcuate is from the you know, from the ligament there, you can dissect that ligament out and divide it, and essentially eliminate the stenosis and fix it. That's I think probably the best way to do it.
Would everybody agree, or sometimes you have had to do something different?
Well, myself, I don't like much that idea, because we have done this already many times. And because you can imagine that somebody was born with this condition, and then you're going to transplant this person 40, 50, 6 years later, and there's fibrosis already. So I think it's risky to just, you know, take down the ligament, and because, you know, that the liver is completely dependent on the arterial flow. So you should do something more permanent in treating the ligament, I guess.
Can I make a comment?
We try to move to another option.
Yeah. And Vivek wants, sorry, Dr. Vivek wants to make a comment here.
Yeah. In an arcuate ligament syndrome, as we know that it's a congenital kind of thing, we have never divided it, but the only precaution we take is we never ligate GDA in these cases, because there's an alternative flow from GDA, and usually we find that flow picks up after we anastomose. So we should not be too judgmental about low flow of artery in these scenarios. And I think most of the cases it picks up very nicely later on.
So we should be able to accept a slightly lower flow in this situation if we know that this patient has a median artery. Is that okay?
That's our preference. Other people might differ in their opinion because of their experience.
Sure. Srinivas,
No, I think I agree with what Dr. Vivek says. I mean, the fact that patient has been surviving with that means there'll be good collateralization. So never divide the GDA, and I think flow will improve once after the anastomosis, even though it's a bit slow. We never had to divide the arcuate ligament.
Great. So we go to the portal vein issues now, and the portal vein thrombosis issue has been actually discussed by Dr. Subhash Gupta in the previous talk, so we'll cover it quickly. But we will look at some other issues of low portal flow. So we are familiar with the extent of portal vein thrombosis and a thrombectomy being a solution to this. What would you do in a situation like this, where the portal vein thrombosis is also associated with calcification? Would it be something where you would like to try to remove the thrombus, or what would be your preference? So we'll start with Dr. Humar again.
Sorry, you cut out there, Ravi. I couldn't quite hear the question.
Sorry, so in a calcified chronic thrombus, would you try to remove the thrombus, because there is a very high risk of bleeding into the mesentery here?
No, I would not try to remove that. I think if you have decent flow already, I think Subhash mentioned this in his lecture, that if you can get adequate flow, just go with it, and then and the interventional radiologist can fiddle with it afterwards.
Later, yeah. Now this is one case so similar, because there was a very atretic portal vein, and there was almost like a cocoon of the abdomen. We had to take a inflow from the SMV and not touch the portal vein at all, because dealing with that would have led to, we feared that it would lead to a lot of mesenteric bleeding potentially. Sometimes you would end up using a jump graft from the left renal vein, provided there is a big splenorenal collateral. And any tips or tricks about such a jump graft, or in this situation when the portal vein is completely thrombosed and we are unable to remove the thrombus? Dr. Fernandez.
Yes, we are now talking about the most challenging situation. This is this difficult thrombosis. And on the calcified thrombosis, it will be a major mistake if you try to remove the thrombus, because you're going to damage the vein, bleeding, and this is a completely mess. So we need to figure out another patent vessel around, maybe the SMV, as you just showed beautifully the previous slide, and the renal graft, the renal vein. You need to make sure that there is a shunt, otherwise it doesn't work. So if you have a perfect and a huge renal shunt, and then you can create the renal portal transposition, or you can create the shunt like we did twice. You do a splenorenal shunt, and then you do the renal portal reconstruction. So it's a matter of trying to understand how the flow is going, but we have several options. I don't like much the idea to give to put in the interventional radiology guys the decision, or if you do a transplant and later they will fix it because it never worked. I think we should make it work during the transplant. Otherwise, we're not gonna solve the patient's problem.
So the next point, this is something that Dr. Srinivas Reddy's case, which is also discussed by the previous speaker, that you could use a collateral. So any comments on this case, Srinivas?
I think just to add to what Dr. Humar had said, I think planning is most important. Preoperatively, we should go in with a plan. On-site, deciding to do a renal portal shunt is actually quite tricky after you've done the part of the operation. So we look at the CT plan and go in, and then, so for this case, for example, as a child, there was not much of collaterals. There are a lot of small collaterals everywhere, and there were good collateral veins that we could see around the bile duct. So when we went in, we dissected the hilum and we could find this nice collateral. We put a short interposition graft so that there's no direct traction on the collateral, and we had very good flow actually. So I think the key is preoperatively identifying the problem, having a plan and maybe a backup plan, and then going in so that there are not too much surprises.
Wonderful. So, this is a little algorithm of how to manage a portal vein thrombus, but you can't do a transplant using algorithms. So you always have to improvise and change the plan as you go along. The other problem that we face is low portal flow. So often there are large collaterals which divert steal blood away from the portal vein. And, as we are familiar, if we identify these collaterals before the transplant, then we can potentially ligate them to increase the portal flow, and which all of us do at some point. But if would you consider ligating, instead of ligating, embolizing any of these collaterals pre-transplant if they may be difficult to reach? Would you do that, or how often would you do that? Let's start with Dr. Humar again.
We haven't. I haven't done that before. Embolize them prior. Usually, again, try to do it intra-op and fix the problem intra-op. You can often find them, and then as a last resort, if you can't, ligating the left renal is a good alternative then in that scenario.
So how easy would it be to reach the splenorenal collateral or shunt during the transplant? Dr. Fernandez?
Well, I don't like the idea to deal with the collaterals itself. So ligating the left renal vein will be the most easiest thing and most safest thing to do, because it's going to be risky if you're going to jump your hands on this tiny and very port of hypertension area around the collaterals itself. So we ligate the renal vein quite often here. So it's a very easy. You go and when you remove the liver, you do a test. You release the portal clamp without clamping the left renal vein, and then you clamp again and you seal the flow. If the flow improves after clamping, you just go ahead and ligate the renal vein. That's quite easy decision, I think.
Great. And yeah, please.
I think we're discussing all these things. Actually, I wanted to just give a clinical scenario that I had. So doing a DDLT, portal vein was thrombosed with calcification, just like you showed. So we did a thrombectomy. Thrombectomy was not complete. The calcium bit was still left, but there was reasonable flow. He had a large splenorenal collateral and a huge renal vein. So we clamped the renal vein, immediately the flow improved. So we went ahead, we reperfused, we did the artery, and then we tied the renal vein for the improving the flow. Then we did the artery. The flow was looking good, but after we did the artery, when we looked in, we found that the whole bowel was congested. So what had happened was, even though the blood was being pushed in through the portal vein, partially thrombectomized portal vein into the liver, the ligation of this large collateral immediately caused bowel congestion, and you could actually see the whole bowel getting congested. So we removed the tie on the renal vein, the bowel decompressed again. So in that case, obviously there's nothing else you could do. So we had to actually then change our plan, mobilize the renal vein completely, and then we did a renoport. Luckily the artery was already on, so the liver was getting flow. So I think this is just to say that it can be quite tricky sometimes. When we tie the renal vein, we have to make sure that there is good thrombectomy done, so that there is good flow into the liver through the portal vein. Otherwise, you will just cause bowel congestion.
Interesting. So we are actually at the end of our portal vein issues, and the time is up. If we have a minute, then we can just discuss the last scenario, which is the Budd-Chiari syndrome with a very difficult TIPS placement. It will take us about a minute. That's it.
Yes, Ravi, go ahead.
So Dr. Humar, all three panelists, starting with Dr. Humar, Dr. Fernandez, and Dr. Reddy, quick 15-second comments. How would you deal with this TIPS placement? How would you offer a transplant to this patient? This TIPS placement is almost into the splenic vein.
Yeah, I think often the TIPS procedure can be down too low. We would certainly offer it. You can. If it's a fresh tip, sometimes it'll just pull out at the time when you do it. But if it's not, you have the option still of doing a jump graft.
Yeah, Dr. Fernandez.
Yes, I agree. If it's a fresh tips, it's easily you take this off but you have options to do jump grafts and replace the cava. Sometimes these patients have to replace the cava. If it's a living donor case, you can use a dacron graft, or if you cadaveric, you do conventional transplant and replace the cava. So those cases are very funny cases. I like those.
Srinivas.
I'm just as a question. Suppose the stent is patent. Can you just cut it at the level of your anastomosis and do the anastomosis to that?
So at least I've had some really okay and some really bad experiences doing that, and I would prefer not to. But I've been able to manage in one case actually. So, but in one case, you know, the sutures just kept cutting through the portal vein because the stent kept the portal vein stretched. So the sutures won't hold. So that's what my two bits. Anyway, so we're just up with time, and I'm going to ask everybody for a little brief one sentence, if any tips. Otherwise, we'll close the session. Thank you very much for this opportunity, and thanks for the great panel.
Dr. Ravi, there are a few questions in the chat box also.
Sure. So I'll just quickly ask. So a query from Dr. Tyagarajan, sometimes a splenic stele can be associated with median arcuate ligament, resulting in persistent low flow state. What are the options intra-op? So there is splenic stele, and
we tie the splenic artery.
Tie the splenic.
Yeah, we could do that. And from Ashish, in what situation will you do a splenectomy during hepatectomy? Does graft weight versus splenic volume determine perioperatively leads to splenectomy in all cases? Would you do a splenectomy during a hepatectomy if the graft weight versus splenic volume is in a certain ratio?
No.
Okay. All right. Those are the only two questions from the audience. And so any last comments from any of the panelists? Otherwise, we are good.
All right. Thanks, everyone.
Thank you. Thank you very much.
Thank you.
Thanks.
Thanks.
I think I'll have last comment.
Please.
No, it looks very simple on the screen, but when these things happen in operation theater, they're altogether a different ball game. You know, then you have algorithms in mind playing what to do. You know, so but anyway, nothing replaces experience of an experienced surgeon. So that's what it is. That's what the training is for.
Great.
Thank you so much, all the panelists, Professor Abhinav, Fernandez, Srinivas. Thank you so much for your insightful inputs into difficult vascular issues during transplantation.
Thank you.
Good to see you all.
Thank you, guys.
See you
soon. Yeah.
So next panel discussion is on liver transplantation for hepatic malignancy. And I will invite Dr. Prashant Bangui to moderate this session. Dr. Prashant Bangui is a senior consultant, liver transplant and hepatobiliary surgery, Medanta Institute of Liver Transplantation and Regenerative Medicine, Medanta Medicity, Gurgaon. And this panel discussion will be joined by the panelists, eminent panelists, Dr. Paul Jagland. He is a professor of surgery, head of Department of Transplantation Medicine, Oslo University Hospital, Norway. And Dr. Tyagarajan, he is a director, Institute of Liver Disease Transplant and HPV Surgery, MGM Healthcare, Chennai. And Dr. Balachandran Menon, he is a director, liver transplant and hepatobiliary surgery, AIG Hospitals, Hyderabad, India. So Dr. Prashant Bangui, over to you. Thank you.
Thank you so much, Dr. Piyush. And thanks to the scientific committee for having us here. I think we have a very broad topic to deal with, and we are going to try to do our best in the next 30 minutes or so to deal with these particular issues in liver transplantation. So we are speaking on liver transplantation for hepatic malignancies. And I think we have Pal, we have Tyagarajan, Dr. Bala, I'm not sure if he's there, and Dr. Paulo Martins. Dr. Piyush, Do you have any idea if we have the other panelists with us, Dr. Bala and Dr. Paulo?
Dr. Paulo is unfortunately he is not joining. He has some personal commitment. And Dr. Bala, I have been informed that he is joining. So even I can't see him. I'm asking the event guys to check on him.
Sure.
Yeah.
Okay, so we'll get started because we're already running late. And welcome, Pal and Tyagarajan, first of all. We are going to try to deal with these three topics probably when we talk about transplantation for liver tumors. And I was asked by the scientific committee to handle topics which are not the general conventional criteria for liver transplantation. So while there are certain conventional criteria which are there for transplant, which are well established and followed all around the world, there are some which are beyond the conventional criteria, and that's what we are going to try and address today in this particular session. So number one, I would come to beyond conventional criteria.
Dr. Prashant, Dr. Bala has joined, so he's a part of this discussion. Yeah.
Sure, great. So we'll go to beyond conventional criteria HCC, that is locally advanced HCC. And this is the first case that I'd like to put forth. A 46-year-old male, child C cirrhosis, CTP10 MELD of 16. He has a multifocal HCC. There are at least 5 lesions, each 2 to 5 centimeters in size. There is no vascular invasion. There is no extrahepatic disease. Alpha fetoprotein is 250. We did not have a PIVKA2 in this particular patient. So if we're to go by the BCLC staging and treatment strategy that we've been using now for the last 2 decades with some modifications, you would still put this patient into an intermediate stage multinodular performance state 0 child SPEW. Here it is child SPEW C. But still, the only options that would be there available for this particular patient is either a TACE or sorafenib. And this is what has been projected to give a 3-year survival of somewhere around 10 to 40%. So resection and liver transplantation are completely out in this particular scenario. So Dr. Balachandran, what is your thought process here? What would you say about this particular case? How would you take up this particular case for further handling? Dr. Bala? Okay, we don't seem to have him. So Dr. Tyagarajan, may I ask you, what would you do in this particular case? 46-year-old male and with the features that I have told you, what is your way going forward?
What I would think is if the AFP is less than 500, generally if AFP is more than 500, I would not even consider. But if the AFP is less than 500, I would consider. But I would also look forward what is the biological activity of this tumor. So if I will have a short waiting period, at least 3-month period. So if it is going out of stage, then I would not. But if it stays not much progressing and the AFP is not progressing beyond 500 in a 3-month period, then I would consider for a transplant.
Okay,
but
so basically the key
have a short waiting period.
Sure. So the key for you is to watch the tumor biology before you go ahead. Dr. Pal, that line, what do you think? How would you go ahead?
Yeah, I agree that this patient is beyond criteria, but if he has a biological phenotype that is not very aggressive, I think the best treatment would be to transplant him. So my approach would be to try to establish the nature of the tumor biology by observing him. Possibly the best would be to challenge the tumor to get some kind of a biological answer. So if he were to tolerate taste, a limited taste, that would be one way to do it. But that would be my approach.
Okay, Dr. Bala, can you join us? Can you unmute? Okay, so I don't think we have him. So this is just an example. We have so many people who've developed algorithms, who've gone ahead and transplanted these people. This is just an example. This is our own series which we published. And what we found is that you basically look at tumor biology, looking at your prognostic markers. So we found alpha fetoprotein of 100 beyond UCSF criteria and FDG18 PET avidity to be the markers. So our usual criteria is no extrahepatic disease, no vascular invasion, irrespective of tumor size and number. But based upon a risk, we then upfront do an LDLT. With a moderate risk, we would downstage if it's feasible, like Dr. Pal said, try taste, limited taste, even if it is possible, given the liver function. And if they are high risk based on this, that means all three are the bad prognostic factors, we definitely would not go for an LDLT. We would do downstaging, bring them down to a low risk, and then go ahead. And I think attempts from many people around the globe trying to look for options in these patients with locally advanced disease has now led to this in the BCLC. Many of them will not be aware, but now this is the latest published BCLC guidelines. Now in this intermediate stage, we have the extended liver transplant criteria where you can transplant. And this was published in the Journal of Hepatology in 2021. We had done an ILTS consensus conference just before this, and this was one of the papers that was quoted there with Professor Mazzafer, who was also with us in that conference. And now there is more increasing recognition of the fact that tumor biology is important. It's not just the size and numbers. So I think that is changing. I'll go to the second case. This is a 53-year-old male, child B cirrhosis, CTP8, mind you. He had signs of portal hypertension. There is a single tumor, 4.6 by 7.1 by 5.6 centimeters. SUV max of 7.37 on FDG18 PET scan. There is a portal vein tumor thrombosis in segment 5 tributary of the right anterior portal vein with a focal FDG uptake there as well, with SUV max which is similar to that in the tumor. The alpha fetoprotein is 8,400. The PIVKA2 is 2,765. So both are quite raised. There is no extrahepatic disease. So again, if you were to go by the BCLC staging, and even with the new modification, it would still go into advanced stage, and you would just do sorafenib and TACE in this particular patient. I don't think we have Paolo with us. Dr. Bala, are you able to join us? Are you able to unmute? Yes, Dr. Bala is here. So what are your thoughts over here?
Yeah, this is an advanced tumor because AFP and PIVKA, they are pretty high. I mean, when you combine them together, the value is quite high. I agree that it is just VP2 PVTT, but still I would like to, because the AFP and PIVKA values are high, I would like to downstage the tumor and wait for about 3 months to see what is the status of, how the tumor has responded before going in for transplant.
Absolutely. So again, going to tumor biology, I'll just show you the images of this particular patient. So this was the pre-treatment. So we also decided to downstage this patient, and I'll tell you about the downstaging a little later. But this was the arterial phase of the pre-treatment CT. So you see the tumor here. It was a large infiltrative type of lesion. It is showing enhancement on the arterial phase. There's a washout here on the hepatic venous phase. If you look at the CT scan, it is actually a VP1. So you see the right anterior portal vein. This is the segment 5 branch, and you see that there is attenuation here of this branch, and the infiltrative lesion is actually infiltrating into this particular branch, segment 5 branch of the right anterior. So we also decided to do a TACE for the primary tumor and followed by SBRT to the segment 5 portal vein tumor thrombosis. So it was a combination of TACE and SBRT, which was done over a period of 4 months. Initially TACE to the tumor, followed by SBRT, because on repeated imaging, there was still a tumor thrombus which was active in the segment 5 branch that could be seen, which is sometimes rare because VP1 is something that you don't really spot on a pre-treatment CT scan many a times. What you see is VP2 onwards, but here it was VP1 because it was only in the segment 5 territory. This is also the FDG18 PET that you see. This was the tumor which was enhancing, and this was the tumor thrombus here. And then you see that this is post-TACE after the treatment has been done. And in fact, after 2 months, after completing the 4 months, that means this is a total waiting period of about 6 months. We had an alpha fetoprotein was 240, PIVKA2 was down to 540, and no new lesions, no extrahepatic disease on repeat PET scan. He underwent an LDLT. It's 1 year now post, and there is no recurrence, and he is doing well. So there are these selected patients in whom you look at tumor biology, see if the tumor biology is good. You have a waiting period, treat them, downstage them, and then you can get some good results. I'll quickly go on to the next topic, and that's on colorectal liver metastasis. And I think it's an honor for us to have Pal Dagline here, who's been a part of this right from the beginning till now with the Oslo criteria. So a 35-year-old gentleman, non-resectable synchronous colorectal liver metastasis, liver-only metastatic disease. The primary is still in C2. It is sigmoid. It's non-obstructing, no history of bleeding, so it's not really symptomatic. You have a KRAS wild type. You have a BRAF mutation negative. There's an excellent response to chemo 6 months after detection of this synchronous metastasis. So let me go to Paldagline first. What is your thought process here? And I would also take this opportunity to ask you to go get us through your selection criteria, how it has evolved over the years, and where we are at present with transplant for colorectal liver metastasis.
Yes. So in this particular individual, he has the from the sheer facts here, he is a potential candidate for transplant if he in the end fulfills the criteria. We are still a bit early out because we would like to observe the disease for a year. But I would highly recommend that this patient have his primary tumor removed, although it's asymptomatic. And then the chemotherapy treatment should be aimed at keeping him stable. He already has an excellent response, so all chemotherapy should be aimed at disease stability, avoid progression. And then
could I ask you, Dr. Pal, when is that decision important in terms of removal of the primary? At what stage do you see the initial response to the chemo and then go ahead and remove it and then further see the response to the chemotherapy or continuation of chemotherapy and stable disease? How is the decision on the primary taken?
So we typically do it at this stage where you see that you have a non-resectable disease. The facts that are outlined here are compatible with transplantation, and you have an excellent response. So if you want to keep this patient in the pipeline, you should have the primary out, and that's much earlier than many centers do, but we tend to do it quite early.
Okay. Let's go to the evolution. Maybe you could run us through this.
Yeah, so the first study was, as you all know, it was a pilot trial, and the inclusion criteria were exceptionally wide, just focusing on adenocarcinoma of the colon or rectum, and the requirements for chemo was only 6 weeks. We avoided patients with general cancer symptoms, meaning weight loss or bad condition, and high age and high BMI. And you see from the exclusion was that are related to extrahepatic disease or the primary tumor not resected, not having enough chemo. But essentially, this pilot trial, SICA-1, contains a lot of patients that we currently wouldn't have considered. So going over to the SICA-2 trial, where we have learned some of the lessons. So this is a rather very busy slide, but I would, to make it very short, this is focused on ensuring that you have an adequate chemo response, and that means that we have to have at least 10%. And the 10% resist is founded on the fact or how the resist criteria are defined. So if you say just stable disease, you would, per definition, include patients with slight progression. So that's why at least 10%. Most patients have more. Secondly, we try to avoid patients that have extremely large tumors, because this is associated with inferior survival. So before start of chemotherapy, no lesion should be larger than 10. And the actual number is not that important. And lastly, we require a time of at least 12 months from diagnosis. So that's the main change from SICA-1 to SICA-2. And then if we look at the more contemporary selection, we require patients to have an Oslo score of 0 to 2. If you advance once more, maybe the table comes. Yeah. So the Oslo score is focused on maximal tumor diameter, CEA, progression on chemotherapy, and time interval. So essentially, you have to have an Oslo score of 0 to 2, as low as possible. And then extremely important is pre-transplant PET investigation with estimation of metabolic tumor volume, and that should be below 70 cc's. And then we try to avoid the following criteria, the following characteristica. N2 status of the primary is a bad sign. ERAF mutation is a no-go in our program. And we try to avoid patients with undifferentiated primary tumors or signature ring cell differentiation. And we try to avoid right-sided primary tumors because they are associated with much worse outcome. If you include N2 status patients, the only way I think to reliably handle those is to add more observation time. So that's basically, and then I should have included the algorithm from the IHPBA guidelines that summarizes it quite good, but I didn't have time to that. But these guidelines don't contain anything about MTV, which I think is crucial.
Okay. Dr. Bala, what would you like to say? What we have noticed and what we have observed here in India, we've been trying for almost a decade now to include even one patient with CRLM who is this stable, like Paul has shown us, or this particular example, to actually have a transplant. What has been your experience?
Yeah, I totally agree with you. Over all these years, I have never been able to do a single transplant for any patient with colorectal met, for the simple reason that they barely, last with you for so long. Means you have to first go remove the primary, keep them on chemo, and wait for a considerable amount of time and to keep looking at the disease stability. So it's very rare to really have a patient tagging on to you for so long. But neither have I been able to yet see a patient who was treated somewhere else and who came to me for transplant. These criteria are good. The positive predictive factors, which he has actually mentioned just now, they are excellent. And I expect a very good result, which he had published. But unfortunately, I have not been able to see a single patient.
Yeah. Dr. Tyagarajan, you want to make a comment?
Yeah, exactly. So, couple of years before, I've seen a patient whom they had 7-8 lesions and they were resected, and the patient is still alive, CRLM. The primary is synchronously removed and without any lesion in the PET. So, however, transplant has been proposed. I don't know. We have to see in the light of AILBS, and we have to see in the light of suitability of these patients in our state country. I don't know how practical this is, even though the results are good. And one thing I want to add is even this CCAR2 trial D-arm, when they extended the criteria of pulmonary meds or a response to the disease-free survival was only 4 months. So I think it only forms a very narrow part of CRLMs. And also, I think they have the advantage of having the organs in probably freely available. Then we have to weigh in the light of organ shortage also, whether we are justified to offer these to our patients, even though a lot of trials have been happening. They're very interesting.
Right. So I
Can I
again would
add a point?
now. Yeah, sure. Go ahead.
Yeah. So most of the patients who were offered transplant were actually received extended criteria grafts. So what we practice is living down a transplant. So it will be a little difficult to extend those sort of livers or those sort of criteria to living down a transplants. Probably that's why we don't get so many patients for transplant. Resection, yes, we do get quite a few.
Right. So those are the logistic issues. Dr. Pal, I want to ask you to briefly tell us about your experience with the rapid procedure for colorectal liver metastasis. That is something that you've taken over now as an extension probably of what we would call the AILBS procedure. But your experience and what do you think the future holds for the rapid procedure?
Yes, so the rapid procedure is essentially an auxiliary or apport procedure where you deportalize the liver remnant under pressure guidance to the graft to avoid both small for size problems, but ensuring a high portal flow to stimulate regeneration. So we have collected the experience around in Europe. There is a paper submitted on this. Hopefully it will be accepted. So the experience is quite good in terms of technical success rate with very good regeneration. And one can, in almost every case, do the second stage hepatectomy 14 to 21 days after the transplant. The first patient in the world that we operated in this manner was on third-line chemotherapy with lesions in every segment. He is now in the summer. He is in June. He will be 8 years after transplant. He received 300 grams of liver, and he is completely free of disease. So I think the intriguing part of this is that it might enable. It's a way to do living donation with possibly slightly lower donor risk, or shifting the risk more towards the recipient. So I think this has the future, and we will certainly, we are working to implement this in Oslo.
Okay, thank you so much. And I think the next 7-8 minutes I'm going to use on this third topic, that's on neuroendocrine tumor metastasis to the liver. So this is case number 4, a non-resectable, that is 6 segments are involved, NET match to the liver. Dotanov PET, obviously avid. The serum chromogranin was around 940. After an assessment for the primary, there was a small rectal nodule, submucosal in situ, avid on Dotanov PET. And these were liver-only metastases. There's nothing outside the liver other than the rectal lesion that is there. So, Dr. Tyagarajan, what do you want to say about selection criteria of these patients, whether it is DDLT, LDLT? What is your take on these particular selection criteria, and whether they should have a transplant in the first place? And more specifically, which are those which should not have a transplant, or which are those which should have a transplant?
I think that's an interesting case. So the best results have happened with Milan's criteria, the NET if we take. So generally the most important point is grade of differentiation and the K67. K67 more than 10% is generally a poor prognosis. They have the second thing, portal drainage. Even though portal drainage is in Milan's, but not everybody agrees on the portal drainage. But the most important thing is pre-transplant curative resection of all the extrahepatic lesions, and the primary tumor has to be resected. The waiting period is again debatable, at least 3 to 6 months. The disease should be stable. And the tumor burden is a common thing in Milan's criteria, less than 50% of the liver involvement. Again, in very highly selected cases, this estimation is often subjective, and you can extend a little bit if the biological behavior is not that good. There is no consensus on this 50% criteria. And additionally, I would want PET scan on these tumors. So R0 resection is very important. When we cannot offer R0 resection to these tumors, I don't think we should be attempting a transplant. And when we look at DDLT versus LDLT, and next slide, next slide, next slide, next. When we look at DDLT versus LDLT, I don't think we should differentiate between the DDLT and the LDLT in the criteria. And most important, a lot of medical and interventional procedures have been happening to test the biological behavior. And I would wait whether the tumor shrinks or a stable disease for at least 6 months. Even with this, we have an excellent survival, 5-year overall survival, whether it's for DDLT or DDLT. In the Milan, it's more than 80%. In the other trials, it's from 47 to 70%. The one thing caveat is the recurrence rates are reported to be quite high when you little relax the selection criteria. So that would be my take on this.
Okay, Dr. Bala, you want to make a comment?
No, I think I agree with what Dr. Tyagarajan has said.
So I think also that the 50% cutoff that is there in terms of tumor volume of the liver, that is something that most of the times has actually kept us away from doing transplants in these patients. Dr. Pal, do you think that that is that important, the 50% tumor volume of the entire liver? Because in that case, if you were to have less than 50% or 50%, most of these patients actually would be resectable if they are not, involving all the segments of the liver. Why we are thinking of transplant in these patients are because of the non-resectability. So what's your view on that?
Yeah. I think one should take into account that the 50% is only we consider that after we have done treatment. We have tried different treatments against the tumor, because we will usually do that with patients with heavy tumor load. So we might consider patients entering the pipeline with much more than 50%. So if they respond, we will tend to be positive towards transplant.
And would you differentiate between organs? As in the primary.
The
primary, yes.
Yeah.
Primary.
Well, we only do transplants in patients that have portal venous drainage, and then we are a bit more skeptical about the pancreas as a primary as opposed to the small intestine.
Yeah. And any idea on the waiting period after resection of the primary towards and then transplant later? I want to try to get your analogy from the colorectal liver metastasis. Have you learned something, or do you think that that's important?
We really don't know, but we usually apply about 6 months.
Okay, so you would wait for 6 months.
I have a question. So what does this serum chromogranin, in everybody's opinion, has a role in the prognosis or the timelines or the response? I don't know. Is anybody aware?
Dr. Bala, you want to take that? I think we use it more for diagnosis. I don't think that we use it for any response. As of now, at least there is no evidence published or no one has studied this. But I think that beyond that, it's the response on the Dotanov PET after you have given, say, PRRT and then treated these tumors and then actually come down to stable disease.
Yes.
It is the grade of the tumor which is important. So that is what ultimately determines the result.
Yeah,
absolutely.
So we have one question. I think this is from Dr. Ashish George. It's a child C patient. So this was the HCC patient that I showed you. Would TACE be possible? So Dr. Ashish, I think that's the reason why we put it in our algorithm also, that in a patient who is child C who needs the transplant, and you think that is not too bad in terms of the tumor biology, even if there is a slightly higher recurrence rate, you would still go ahead, because most of these patients would actually not tolerate a TACE. So if it's a bad child C in terms of bilirubin especially, then I think you would avoid a TACE. So I think we've run out of time. We had 30 minutes. We've just finished in time. I think I would like to sum it up by saying that today we are dealing with an era of transplant oncology, where we need to decide what is best for each individual rather than making generalized statements, and whether it is in person with the oncologist, with the surgeon, pathologist, hepatologist, radiologist, or even nowadays that we are restricted to online. I think before taking a decision or making a decision in these particular patients, we need to consult and have a multidisciplinary tumor board. And I think that can help us to get to a personal therapy to obtain optimal outcome. And we are definitely not only approaching, but we are now in a new era of personalized surgery rather than making one blanket rule for everyone. So thank you so much, Dr. Pal, Dr. Bala, Dr. Tyagarajan, for being on this panel. And it was a pleasure to be speaking to all of you. I'll hand it over back to Dr. Piyush.
Thank you, Dr. Prashant and Dr. Vivek.
Thank you.
Thanks, Dr. Prashant, Dr. Pal, Dr. Bala, and Dr. Tyagarajan for the wonderful panel discussion. We'll move ahead with the next session. Next session is a lecture on newer therapies for HCC. The speaker for which would be Dr. Parisa Tabrizian. She is an assistant professor surgery at the Mount Sinai Hospital, New York, USA, with specializations in HPB and liver transplantation, and special research interests in HCC and newer therapies for HCC, including immunotherapy. The chairpersons for this session would be Dr. Pankaj Puri, who is the Director of Gastroenterology and Hepatology at Fortis Escorts Liver and Digestive Disease Institute at New Delhi. Dr. Ashok Chaudhary, Senior Consultant and Head, Department of Hepatology and Liver Transplantation at the NH Institute of Liver Sciences, Gurugram. Dr. Ankur Bahel, who is the Senior Director, Medical Oncology at the FMRI, Gurugram. And Dr. Ajay Bhalla, who is the Director, Gastroenterology and Hepatobiliary Sciences at the Fortis Hospital, Noida. Dr. Parisa, you could start.
Hi, good afternoon. Thank you. Do you see my slides?
Yes, we can see your slides.
Yes, we can.
Okay, very good. Thank you. It's really an honor to have been invited, and I thank the society and the chairs. My topic is quite interesting, is on newer therapies for HCC. So I was asked to discuss things that happened over the past years, particularly discuss downstaging, which was alluded to on the previous talk. So I will keep it brief, and then discuss neoadjuvant treatments in resection, and then focus on immunotherapy for resection and transplantation. There's no question, and this was alluded to on the previous talk, that either Milan or either criteria that we use that definitely increase oncologic outcomes in patients with HCC. But over the years, we've noticed that there's a lot of criticism that happens. The criteria are too restrictive, and particularly in patients in the intermediate stage, there have been a lot of changes that happen over the past years. And we learned that one size does not fit all, and particularly with using local regional therapies and having excellent results as bridge to transplantation and observing tumor biology, things have changed over the past few years. We have refined candidate selection. There are a lot of criteria that have been used in the past that went beyond Milan and that showed excellent results. However, these criteria are based on morphometric criteria. They lack tumor biology, and certainly do not risk stratify this patient accurately. Even Mazzaferro himself, who had published the MetroTicket 2 study, added the MetroTicket 2.0, where he added alpha-fetoprotein into the criteria, and this model now outperforms Milan or UCSF. The French group as well created and demonstrated that with worsening of alpha-fetoprotein, if your alpha-fetoprotein is above 1,000 here, the survival and recurrence definitely worsens. The survival here was 39% versus 67%, and they added this alpha-fetoprotein into their model in addition to size and number, and they've shown that actually you can increase the pool of patients by 20% by using this model, and this model has been replaced Milan in the allocation system in France. Unfortunately, all these studies really were based on static AFPs, and a few years ago we established this 3 large center study including 1,500 patients, and we actually looked at the dynamic changes of AFP throughout the local regional therapy, and we've shown that if you incorporate it and you just not statically look at one AFP, but you looked at the differences between the maximum AFP and the final AFP at transplantation, that makes more sense. For example, looking at this graph, and this was published, and we named the scoring the NICA scoring. We showed that, for example, patients who had an alpha-fetoprotein over 1,000 but were able to reduce the alpha-fetoprotein by over 50% had similar outcomes than patients who were hovering between 200 and 1,000. So I think the dynamic changes on what happens during the local regional therapy is definitely key. And when we did the scoring, we actually found that over 85% of the patients that were initially outside Milan would have been actually recategorized into low risk and acceptable risk and still achieve a overall survival of over 70%. So I think understanding tumor biology and including alpha-fetoprotein into our system is definitely key. And this paper was validated by a multi-international center, and this is what we've been using now in the US. Downstaging, which was discussed, over time has been accepted in the US. We're using the UNOS downstaging system, and this is this was established by the UCSF group. Essentially, this is any lesion that's less than 8 centimeter or multiple lesions where the sum does not go over 8 centimeter with no vascular invasion can be considered for transplantation. The importance of this for diseased donor particularly is that the minimal observation period of 3 months is necessary in order to make sure that we're not capturing bad tumor biology. And when they compared these patients that were downstage to those that were always within Milan, the survivals were comparable. But this is based on a small retrospective study. So what we did a few years ago, we essentially validated this national policy based on 2,500 patients in the US. And what we've shown here in the red line is that you can still achieve meaningful outcomes in patients that were successfully downstage 2 within Milan. And here we had a 10-year survival of 52% in these patients that would have probably not been offered transplantation to begin with. And recurrence was also very acceptable. It was 20% compared to 14%. And those who failed downstaging had a terrible outcome of 47%. So we've been using this, and here this is the validation of UNOS downstaging and patients who were always within Milan, and we showed comparable results. The patient that we found failed downstaging were those who had over 3 lesions, had a large initial tumor of over 7 centimeter, and those who did not have a response of alpha-fetoprotein, at least of 25% during the treatments prior to transplantation. And patients who had a poor recurrence-free survival overall in the downstaging group were those who had a neutrophil to lymphocyte ratio of over 5 at transplantation, where alpha-fetoprotein was over 20 at transplantation, and where the explant still showed a viable tumor of over 5 centimeter. So we took this and published last year the first prospective study, including 209 patients from 7 centers, where we looked at patients who met downstaging criteria and saw what happened to them. So interestingly, around 83% of these patients were downstage 2 within Milan at a median of 2.6 months. And of those, 30% were ultimately transplanted with a recurrence of 8%. So the probability of getting to transplant at 3 years from the first downstaging treatment was 46%. On explant, not surprising, 43% had exceeded Milan, but the overall survival at 2 years was 95% and recurrence at 8%. So this is the first prospectively study that was published that showed excellent results in those who met downstaging. And then I know there's a lot of controversy about TACE versus Y90, but here this is a nice, our data again prospectively showed that if you use TACE or radioembolization initially at the downstaging, there was no difference in M-RECIST response, probability of time or time of successful downstaging or waitlist dropout. So can we push the envelope a little bit further? Can we transplant all comers? And this is a paper that was done also published 2 years ago, where they looked at all comers, so beyond the UCSF downstaging criteria, where they included 74 patients retrospectively. They were able to downstage 48 out of the 74 patients and ultimately transplanted 10 patients. What they found is that there was a significantly lower probability of transplanting patients who were in the all-comer group. So the 1-year dropout was 54% versus 25%, and the outcome was also worse. The 5-year survival was 21% in the all-comers group compared to the downstage group. And the major risk factor was essentially the number of lesions and the largest tumor diameter. So the probability of downstage staging at 1 year, if you had a sum of 8, was around 68%. And if the size increased up to 14, the probability of downstaging and to transplantation significantly worsened and decreased down to 34%. So what we did is we looked at this prospectively. Now that local regional therapy has improved, can we really push the envelope beyond the UNOS downstaging criteria? And this is the protocol that we used. These are patients that have any tumor number, any tumor size, any total tumor number. But here we gave it an observation period of 6 months. So we didn't rush to transplantation. They had to have stability prior to transplantation up to 6 months, which was important compared to the 3 months in the downstaging group. And this is still unpublished and under review, but this is the first prospective all-comer study where 82 patients were included. 64% were downstage to Milan, and out of those, 24% were ultimately transplanted, and the recurrence rate was 5%. Again, this is a select group, but just to show you that there was still excellent outcomes that were published in this all-comers group. So the probability of successful downstaging was slightly higher for the all-comers group, 67% versus 83%. However, the 3-year survival was not terrible. It was 58% for the all-comers group and 69% in the UNOS downstaging group. So I think there's still room for pushing the envelope and selecting patients and providing excellent outcome even beyond the downstaging criteria. So what about macrovascular invasion? I think we had discussed this on the prior talk. I think we can still select. There are a few cases, and we are listing patients who have macrovascular invasion. Again, this is a small subgroup. I don't think this is a true absolute contraindication. And this is a study that we performed, a multi-international study, where we looked at 30 patients who had a diagnosis of macrovascular invasion. And I know it's a small group because this is just well-selected patients, but we did find that the overall survival was still acceptable. It was 60% at 5 years. And these are patients that were treated with local regional therapy and had excellent tumor biology prior to transplantation. And again, alpha-fetoprotein of 10 here was significant and diminished recurrence only to 11% in these patients at 5 years. So I think there's still room for improvement, and I wouldn't necessarily say that this is a true absolute contraindication. As I said, there's a lot of controversy about using TACE versus using Y90. We're a large center, and we really, I think the majority of our patients are provided radioembolization prior to transplantation. And this is a nice, largest, I think, paper on TARE from the Northwestern group, a 15-year experience of 207 patients, where they were able to downsize patients that were beyond Milan in 47%. And interestingly, they were able to identify 45% of patients had complete pathologic necrosis on imaging. Interestingly, and not surprisingly, because of the necrosis that they found, the recurrence-free survival was higher in these patients who had complete necrosis or extensive necrosis on pathology. So I think definitely something to use, and we should see in the future TACE being competing with radioembolization on the BCLC guidelines. we also learned over the years, again, that pathologic response is key. And this is a nice paper from one of my colleagues, Dr. Dinorcia, that showed that patients who had complete necrosis had a better survival and a lower recurrence rate compared to patients who had partial or incomplete tumor necrosis on pathology. The other thing that we learned is that wait time influences and predicts outcome as well. So we shouldn't fast track these patients. So we usually wait between 6 to 18 months. I think this is a nice paper from the UCSF team that says that if you transplant patient in less than 6 months, you may actually capture bad biology, particularly now that we're like pushing the envelope and we're transplanting patients beyond Milan. And if you wait too long, if you wait over 18 months, you may actually convert a patient from a good to bad biology. So I think wait time is definitely important. And then one of the most robust papers on downstaging was from Mazzaferro himself. This is an open label, multi-center randomized control study where they randomized 23 patients who underwent transplantation for downstaging versus 22 patients in the control group. And again, this is the most robust study that we have to date that showed that there is a significant improvement in patients who underwent downstaging. There was a 77% 5-year survival compared to 31% in the control group. So this is a lot of changes in downstaging and transplantation. When we talk about living donor, there's a push of and use of using living donation for downstaging. And this is a nice paper from the Toronto group that essentially showed that if you have a living donor, you benefit and your outcome improves. The overall survival was 68% versus 57% if you did not have a living donor. And again, this is one and many have been published in Asian centers where living donation was done for patients who were beyond Milan criteria, but within UCSF, still showing acceptable overall survival of 60 to 70%. So I think definitely an option in patients who cannot wait for disease donation. So moving forward to another topic that we've been a big center that advocated for this is the use of neoadjuvant therapy in patients who have resection. Unfortunately, despite all efforts, even post-resection, recurrence remains 70%, and survival really depends on tumor treatment and progression of tumor disease. So we know that resecting patients who have portal hypertension or BCLC-BC definitely worsens the outcome. We also know that patients who present with multifocal tumors or gross vascular invasion also have a worse prognosis with resection compared to other treatments. But the questions that we had is that in these borderline cases, is there a role in treating these patients with neoadjuvant therapy like we do for transplantation and converting these cases to resection? And we're actually looking into this in a multi-international center. So hopefully we should have our results within a year. But these are the conditions that we placed in order to treat this patient with neoadjuvant therapy. And these are all conditions that are, for patients who have those aggressive features. So for example, and this is what we do as well at our center, we treat this patient pre-surgery, either with radioembolization, with TACE or radiation or immunotherapy, if they have one of these following conditions, such as AFP over 400, infiltrative tumor, macrovascular invasion, multifocal disease, presence of satellite lesions, and hopefully we'll be able to, improve the outcome long-term rather than, offering them surgery up front. And this is, for example, a scenario that I'm bringing up on a patient who has hepatitis C, who has a single lesion. However, his AFP is around 6,000, suggestive of a vascular invasion. So we treated this patient pre-surgery with radioembolization. We treated the hepatitis C. The AFP nicely dropped to 79 at surgery, and we offered this patient resection. This patient had complete radiographic response and complete pathologic response, and now is 8 years out without any recurrence. So definitely radioembolization is an option. For example, we've looked at our resection and Y90 experience, where we're able to downstage those borderline cases in 9% of the time. And important is, and I think this will determine survival long-term, is that not only we found 60% of complete response on imaging, but we also found over 60% over 50% necrosis on pathology. So and we've shown many times that pathologic response is key in outcome. And this is the first prospective trial that was just published on radioembolization, and we were able to transplant these patients and had 100% histopathologic necrosis in those small HCC. So we are pushing for radioembolization at our institution. What is the role of immunotherapy? I think this is a major topic over the past few years, and we've been a big center advocating for immunotherapy. We started the treatment over 5 years ago. And we've been really pushing the envelope. I think there is certainly a role, and this is a case, for example, that I'm presenting, that a 66-year-old, this was one of our first cases, had a large 10-centimeter tumor. AFP is around 86,000, so definitely concerning for an aggressive feature. So we decided, instead of like treating this patient with other neoadjuvant therapies or with resection up front, we treated this patient with immunotherapy. So we gave this patient 2 doses of nivolumab with very minimal side effects. The AFP nicely dropped to 31,000 prior to resection. We had excellent imaging response and over 50% shrinkage of the tumor. And we ultimately offered this patient resection and had a complete necrosis on pathology just with immunotherapy alone. And the patient is now 3 years out with no recurrence and normal alpha-fetoprotein. So I think that a lot has changed in the world of systemic therapies, particularly in the advanced stage. This is the SHARP trial that followed by decades of negative trials until lenvatinib finally competed with sorafenib. And then the IMbrave 150 trial, which we're all familiar with, was a combination of atezo, bevacizumab compared, essentially showed excellent outcome and became the new standard line treatment in advanced HCC with median survival of over 17 months. So following that, immune checkpoint inhibitors, either as an anti-PD-1, anti-PD-L1, or CTLA-4 inhibitors, started, showing excellent results and encouraging results, not only in HCC but in other cancer treatments as well, with objective response rate of 15 to 50%. And what happened is that a lot of centers started to think, should we incorporate this not only in advanced stage but in early stages? Okay, and they've shown excellent outcomes in other disease processes such as melanoma. And one of the rationale behind this is that we could improve surgical outcome, we could treat early micrometastases, but one of the downside was that we needed histologic confirmation. The patient's primary treatment would have been deferred, and maybe there's a risk of toxicity and would have delayed overall treatment. So these were the issues that we were dealing with when immunotherapies came on. But we started our initial experience at Sinai prior to resection, and we gave patients nivolumab prior to resection and found excellent pathologic outcome. And we started using this more and more, and finally, and performed like extensive immunophenotyping. And finally, we just published last year 21 patients that we enrolled in a trial. And these are patients that could have received upfront surgery. And these are early stage tumors that we treated with a combination of neoadjuvant and adjuvant cemiplimab, and then offered resection. These are, for example, a few cases where the patient had an MRI at diagnosis and then had an MRI after treatment. And then we, on explant, a lot of extensive workup was done, as well as looking for patients who develop resistance, patients who developed, who are responders. And interestingly, around 20% of the patients had over 70% necrosis with this immunotherapy alone, and 15% had complete tumor necrosis on pathology. So these are excellent results, and hopefully we should see improved oncologic outcome as well. And we amended our data and now adding SBRT radiation with immunotherapy prior to surgery, and we're up to 10 patients right now, and we're trying to gather 21 patients before we publish our data. So also there's a lot of concern of adding local regional therapy with immunotherapy. Actually, the treatment, there's a synergetic treatment of both enhances the microenvironment of the tumor. So this has shown excellent results of combining both. So we've started actually in the transplant, in our transplant patients to treat patients with immunotherapy and listing them as well, along with local regional therapy with really minimal side effects on the wait list. So can we push the envelope a little bit more and use this concept for bridge therapy in transplantation? We are probably the largest center who have used immunotherapy in transplantation. Again, this is a very controversial topic, and I don't think we have enough robust data to make a generalized comment, but I just wanted to share what we know. Certainly after transplantation, I think there's a major dilemma. I don't think we have good options. There's immunotherapy post-transplantation causes 45% graft loss and acute rejection, and we have had terrible outcomes as well. I don't think there's much option. But pre-transplantation, there's a lot of controversies. This is one case report that showed a fatal disease. There was a complete necrosis of the graft, and the patient died at 10 days after who had immunotherapy pre-transplantation. Subsequently, this is another paper that was published a few months after that showed excellent outcome with immunotherapy in patients who were downstage for transplantation. So I think definitely controversial. We personally transplanted around 15 patients so far with immunotherapy. And this is a paper that we published 2 years ago on 10 patients where we gave the patient nivolumab pre-transplantation. Induced therapy was corticosteroids at transplantation, and we kept the patient on maintenance therapy. And what we've shown is that, again, important is the selection of these patients. So our patients were mostly Hep B or Hep C patients, low MELD. Half of them were outside Milan within UCSF. The other patients that were within Milan had very aggressive features with high AFP level. And what we found is that a lot of them were salvage transplants. A lot of them had local regional therapy in addition to immunotherapy. And most importantly here, most of them had immunotherapy within 4 weeks from transplantation. One of our patients had immunotherapy the day before of transplantation. And we did find that really no major complication or any rejection related to immunotherapy. So that was key, and we have performed 15 patients so far, again, proving the same outcomes. And recurrence, none as of this published series. So I think we need to really think and gather and do a trial or a large, at least prospective study to see which patient we should select for immunotherapy, what should the washout period be, what observation period do we ideally want, and should we use living donor transplantation for these patients? And then quickly, as a conclusion, I think a lot has involved in the treatment of HCC and liver transplantation. We moved past the Milan and just size and number alone. We understand that biologic behavior plays a major in decision making. We need to do ongoing research on to develop better biomarkers. Neoadjuvant therapy in resection is definitely key in those aggressive HCCs. And then I think there is a role, but we need to understand the safety of it as bridge therapy, and we need to conduct controlled clinical trial. Thank you.
Thank you, Dr. Parisa. I'm Dr. Ajay Bhalla. Can I ask a question? First of all, an excellent talk. Really, it's an eye-opener to see that transplant can be offered after a wait period after downstaging the disease. You have said that downstaging improved outcomes, and you waited for 6 months when you were using local regional therapy. But when you've been using immunotherapy, there doesn't seem to be any period that you have waited. You said within 4 weeks also you have been able to do. Why the difference between the two? Why would you want a difference between the two? Why didn't you not wait for that long the way you did for the others? Also, I wanted to know, when you were doing resection, did you have a wait period there too? Or resection was offered immediately?
Okay, that's very good questions. So for our downstaging, we need to make sure that they are downstage within Milan so that we can transplant them. Once they reach Milan, we, and this is nationally, we wait in the downstaging group, we wait at least 3 months to transplantation. In the all-comers group, so those who are beyond the UNOS downstaging, we wait a minimum of 6 months. So in the patients that we treated with immunotherapy, we had a period of 3 to 6 months before we transplanted them. So there was a period of 3 or 6 months where they were within Milan, and then we transplanted them. But we were giving these patients immunotherapy up to transplantation, which is a very controversial talk, because there's always a concern that once transplant is done and we don't have the immunotherapy, if they have any progression of disease off the treatment. But we had a 3 to 6 months period after Milan was achieved. In resection cases, no, there are patients who received immunotherapy 2 or 3 days prior in the trial, and we offer them resection up front. We do not wait for these patients, but these are patients that were included in the trial. So these are patients who did not necessarily have high-risk features. I do think that if we're including patients who are borderline, we should wait at least 3 months or 6 months to see what the biology of the tumor looks.
Thank you. Thank you.
Yeah, Parisa, that is a very nice and interesting talk, and also quite scintillating that we are thinking of giving ICI also very soon. So my concern is that have you addressed circulating tumor cells? Because why in any study they are not showing why the chance of recurrence is high, and we know that by tests or any local therapy there is an outburst of the tumor cells. They are getting systemic flare also. Not controversial area that. So can it be a area of research that circulated tumor cells in any way to predict the recurrence or the biological behavior wise?
Yeah, that's a very good question. I mean, our group has done a lot on liquid biopsies and looking at those tumor cells in the blood work. In the trial, we have sampled blood tests, and I think that's definitely something that we're looking into prospectively. I think the liquid biopsy will be one of the determinant factors to see who recurs, and also understanding, looking at the molecular findings on the explant to see who will respond to immunotherapy and who won't, also based on blood tests, will be key in the future.
Dr. Pankaj,
Dr. Puri, you are
an outstanding talk, Dr. Parisa. I think if we had given you an hour, we would have enjoyed it a lot more. There was so much information you've packed in. It's a wonderful talk. I think we are running a little late, and we should probably hand the mic back to the organizers. There's no question in the chat box.
Parisa, excellent talk. Ashish, this side. Just to want to have a question, a surgical standpoint. Patients with child C cirrhotic, many times we found that there's a lesion, there's no extrahepatic disease. We don't see any major vascular invasion, and AFP is in like thousands. In those scenarios, I don't think those patients are candidates for any downstaging therapy in terms of TACE or tear because of their high bilirubin. What's your take on, are they candidates for any immunotherapy, or many times we land up in situation that can we offer them LDLT because we don't find any lesion outside the liver or any vascular invasion?
Yeah, that's a good question. I mean, in the all-comers group, prospectively, the patients who were that sick and were in child C, child 2 score C, did the worst. I mean, in terms of they were not able to tolerate downstaging, they were not be able to downstage appropriately. We certainly are not allowed to transplant patients who have that elevated AFP. We have to have an AFP that goes below 500, but living donor is an option. I think we still showed acceptable outcomes in these patients in the all-comer group. You're right, local regional therapy is not an option in these cases, but we have used selectively immunotherapy actually in these cases, not necessarily the atezo-bev combination based on their varices, but we have used other PD-L1 agents that were tolerated, and we have seen the alpha-fetoprotein dropped prior to transplantation. But this is a very, very challenging group of patients for sure.
Another question, is there any data on if we can use any immunotherapy in these patients post-transplant elective empirically, like any data on that on immunotherapy?
So post-transplantation, the adjuvant therapies have shown terrible results, and these are and again, the graft loss is over 45%. We have cases, unfortunately, where patients come in with recurrence post-transplantation, and we exhaust all options, and then we offer them immunotherapy with the understanding that after a multidisciplinary meeting, understanding that they may die. So I don't think we have enough options, and the data is only based on small series so far.
Thank you. Thank you so much.
Thank you.
Now we can move to the next session, and thank you so much, all the panelists and Parisa.
Thank you so much.
The next session is a panel discussion on perioperative fluid management in liver transplantation, shifting paradigm. And we have as faculty, the speaker or moderator for this session is Dr. Anil Agarwal, who is a senior liver transplant anesthetist at the Division of Transplant and Hepatobiliary Surgery at Fortis Group of Hospitals, Delhi NCR. As the panelists, we have Dr. Ashish Malik, who is a senior consultant, Department of Anesthesiology and Critical Care, Apollo Hospital, New Delhi. Dr. Akila Rajkumar, she's a senior consultant at Department of Anesthesiology Critical Care at Dr. Rela Institute of Medical Sciences, Chennai. Dr. Selva Kumar, he's a head of department at Liver Anesthesia and Critical Care at Gleneagles Global Hospital, Chennai. And Dr. Lakshmi Kumar, she is the head of department at Department of Anesthesiology and Critical Care at Amrita Institute of Medical Sciences, Kochi. Welcome all. Dr. Anil Agarwal.
Hello, speaker. Good evening, everyone. At the outset, I would welcome all. I would welcome all the eminent panelists and all those attending to the next panel discussion on perioperative fluid management in liver transplantation, shifting paradigms. As we can all appreciate that fluid management in liver transplantation has evolved immensely from just restrictive versus liberal debate to a more patient-centered and goal-directed fluid therapy, which has implications not only on the hemodynamic stability during the procedure, but also on the acid base and the electrolyte balance during the surgery, the transfusion management, and has widespread implications on renal outcomes, cardiopulmonary outcomes, as well as the graft outcomes post-transplant. Keeping this perspective in mind, let's now proceed with the panel discussion. I would initiate with a case done recently at our institute. He was a 46-year-old male weighing 116 kgs and a BMI of 41. He was admitted with complaints of shortness of breath, abdominal distension, and loss of appetite, and on evaluation was diagnosed to have NASH-related CLD with decompensation in the form of hepatic encephalopathy, HRS, ascites, and hyponatremia. He didn't have any history of SBP or a GI bleed. He had a history of CAD, required angioplasty in 2008, was on dual antiplatelets, which were stopped 2 years back when he was diagnosed with CLD. He didn't have any history of hypertension, diabetes, asthma, or tuberculosis, and no drug allergies were there. He didn't have any significant personal or family history. On admission to the ICU, the lab investigations revealed a hemoglobin of 9.3, total leukocyte count of 14,000, and he had coagulopathy in the form of platelet counts 47,000, a raised INR of 2.9, and fibrinogen concentration was low, it was 96. He had AKI on presentation with creatinine of 1.62 and severe hyponatremia in the form of sodium 108 milliequivalents per liter and potassium 4.1. To initiate the discussion, Dr. Akila, you would encounter such patients in your ICU for pre-op optimization. So your opinion on optimizing this candidate on ICU admission with respect to his severe hyponatremia and AKI. Dr. Akila, please.
Good evening, everybody. Thanks for having me here. As you presented, it's a very sick recipient that you would not want to anesthetize all the time. So a 46-year-old, very obese, has most probably a metabolic syndrome, PTCA in 2008, meaning at a very young age, I presume. Is presenting with high creatinine and hyponatremia. Now, before we go on to optimizing the patient, I would like to have some information about the reasons for hyponatremia about this patient. We would first see what the sodium level was at some point before all this happened. Has it been normal at some point? Find out the reasons for the hyponatremia. Usually in patients with cirrhosis, it's usually a hypotonic hyponatremia. Can it be hypovolemic or a hypervolemic or a euvolemic hyponatremia? Needs to be assessed before we jump on to do the management of this patient. So if it is a hypovolemic hyponatremia, which can happen sometimes, it can be due to either a renal loss or an extra renal loss. You'll have to measure the serum urinary sodium to understand what's happened. If it's diuretic induced, then you stop the diuretic. There are occasions where they are hypovolemic as well. A bit about the history, a detailed history taking will help. Because of all the drugs that these patients are on, they are bound to have vomiting and diarrhea as well, like all other patients. Do not always think they are hypervolemic hyponatremia. So history, just to rule out vomiting or diarrhea for extrarenal losses of sodium, again, will help in handling these patients. But the most common presentation is hypervolemic hyponatremia, which is dilution hyponatremia, which only gets better with volume restriction. So we need those information before we go on to optimize the patient. Dr. Anil?
Yeah, this patient was most likely a hypervolemic hyponatremia. Plus, this patient was also on preoperative diuretics, as was under treatment with some hepatologist at some other hospital.
Sure.
So
Okay.
most likely these are the two precipitating factors.
Sure. The first thing you do in such patients is to stop the diuretic, assess the patient, are they symptomatic with a hyponatremia, and how rapidly has the sodium levels dropped. If they're not symptomatic, you'll aim for a gradual sodium correction in these patients. The first thing I would do is put them on albumin infusion and fluid restriction to keep it to below 1 to 1.2 liters per day intake and assess them. And aim for a gradual improvement. Once the diuretics are stopped and the volume is restored, the creatinine also should come down, unless there are other reasons for the raise in creatinine. Meanwhile, you'll also do a septic screen in these patients, look for UTI or any culture positivity, blood culture positivity, or a SBP. Other thing that you do, if we are assured that it is euvolemic or a hypervolemic, is you can consider starting them on tolvaptans, which can achieve a gradual rise in sodium. If at all they are symptomatic with the hyponatremia with more drowsiness or impending seizures, that is the only indication where we'll try and give hypertonic saline, 3% saline.
Okay. So on similar lines, in this patient, we started him on albumin, and based on his creatinine, also started him on terlipressin. His diuretics were stopped on admission, and ascitic tapping was done under ultrasound guidance, and he was started on antibiotics. Meanwhile, the septic screens were sent in the form of urine cultures and the blood cultures. With this conservative management, his sodium improved to 118 without any use of hypertonic saline, as he was not symptomatic hyponatremia. But meanwhile, the creatinine had increased to 2.6 over these 3 days. And his urine output was also low in the range of 10 to 20 ml per hour. And he was decided to start on CRRT. Dr. Lakshmi, do you agree with the initial, with the starting the CRRT in this patient? And in your opinion, what's the role of CRRT in pre-op optimization in such patients?
Right. To be very honest, I haven't had too much of experience dealing with these patients. I think at the outset, if I saw a sodium of 108, I would be terribly concerned. I agree that the correction of sodium should be gradual. And if you're not reaching the right values and you at the same time you have a setting of acute kidney injury, there is a role of CRRT. But specifically, I think here that more emphasis is to be placed on the profile of the patient, how much volume, and in particularly the concentration of the dialysate is supposed to have a lower sodium instead of the standard one, so that in the process of CRRT, you don't overcorrect the sodium, which in turn can cause an osmotic demyelination. So I think we are dealing with a precarious situation. You had a patient, 108 is a frightening number. Now you've tried to put a concept of hypovolemic hyponatremia, and then you're dealing with tolvaptans and you're correcting. Fine, you've reached 118, and 118 is still bad in the context of a creatinine of 2.3. CRRT can be indicated for the correction of the creatinine, but at the same time, you need to be cautious about correction of sodium and not overcorrect for osmotic demyelination. I hope you're happy with that answer.
Yeah, thank you, ma'am. Those are actually the concerns when we start CRRT for correction of for AKI in such patients with severe hyponatremia. But CRRT also has a role in correction of hyponatremia if we keep in mind the concerns of avoiding rapid correction and avoiding coagulopathy as well. Dr. Ashish, keeping in mind that the unique concerns of CLD patients when they are put on CRRT, would you like a transplant anesthetist to lead the CRRT prescription, or would you leave it to your nephrology colleague in your ICU for such patients?
Good evening, Anil, and thank you so much, and good evening to everybody. I always have the idea of being more proactive. So I give you an analogy that why are we now bent upon using T in, as anesthesiologist intraoperatively and later also, is because we want to know more about the cardiac status. So similarly, we are in a position to actually, we are dealing with them in and out, and we are like a perioperative physician these days, and we follow them from pre-op to the post-op, and we are in a position that we can actually make out where CRRT can be started much early. And if it is started much early, the results are much better. And I definitely feel that the anesthesiologist should have an active role, and we should just not leave it to the nephrology people or guys, because we day to day, we always lose time. It's maybe a pun intended on that, but we keep on losing time in managing these patients because we are good in lines, we know the setup, we know the basics and the mechanics. So I feel strongly that we should have a role in it. Thank you.
Thanks, Dr. Ashish. That's exactly what we also practice in our ICUs. Dr. Silva, what's the scenario like in your ICUs where CRRT is required preoperatively? And do you believe that it will impact outcomes perioperatively?
Yeah, thanks, Anil. So again, as Dr. Ashish was saying, we have a sort of hybrid approach. Of course, the rapid changes in the patients and the overall larger picture seen by the intensivist cannot be, replaced by a nephrology input. And CRRT being a continuous, management has to be managed by intensivists whose presence is continuous. So that's a basic thing there. But if you look at it, when we have a plan to initiate CRRT, it's usually a combined decision we propose and the nephrologists agree. But the prescriptions and the running of CRRT, the day-to-day adjustments is completely by the intensivist. And the cessation of the CRRT is again a combined approach. So I agree that we need to take initiatives in the CRRT, but there is a significant input which can be given by the nephrology colleagues also in this. So I would say it's a combined hybrid approach.
And are there any differences in the CRRT prescription in these patients vis-a-vis other medical ICU patients? Like those we need to point out to the nephrologists here.
Yeah, so generally we always go with CVV HDF because, of course, there are the options of having a role and the different modes, CVVH or CVHD. The reason is that we can switch over to the other modes easily, and most of our patients need removal of both dialysate dependent smaller molecules like urea, creatinine, lactate, ammonia, and the higher molecules like cytokines, which get removed by ultrafiltrates. So generally the dosage is almost the same. It's about the effluent dose would be about 35 ml per kg per hour. The difference, other practical difference is the anticoagulation which is being used. We have had a good experience and good safety with regional citrate anticoagulation. It is even in a patient with acute liver failure, even though there is a theoretical concern that the citrate will not be metabolized by the liver, but there are literatures which are supporting it. ACLF patients routinely get RCAs, immediate post-ops even get RCAs. So that is probably something which we push in the liver patients.
And Dr. Selva, one more concern regarding the rapid correction of sodium during CRRT. So what are the strategies you employ in your transplant ICU during CRRT in such patients?
Yeah, so basically this rapid correction of sodium is always a concern because the change in sodium basically depends upon the patient's serum sodium and the dialysate sodium. Dialysate sodium is 140, which is the standard for most of, for the plasma bags especially. So it all depends upon the dialysate, the patient's sodium. So if you don't correct anything and just run the CRRT as it is, the usual trend is by 6 hours, you will reach the midpoint. So if you start at 120, by 6 hours, you are going to reach 130, which will be a rapid change. So there are two options which we usually follow. Initially, we used to dilute the dialysate, take out 500 ml of dialysate and add 500 ml of D5 or something. So if you remove 500 ml dialysate and add D5 into the bag, it makes sodium about 129, and then similarly you can reduce it proportionately. But what we are currently following is basically we replace the replacement component of the CRRT with the either RNS or D5, thereby reducing the overall sodium change. So there are literatures supporting both methods, but we feel the adjusting or substituting the replacement fluid instead of prismosol using D5 or RNS is a easier way of doing this.
Okay, Dr. Akila, are there any alternate strategies being followed in your ICU for the same purpose? Or
I agree with Selva. I mean, just need to make one comment about the previous question, if I may.
Yeah.
Talking about leadership role in CRRT prescription in the liver ICU, I think we need to carefully consider that depends on a high volume center. Like Dr. Ashish was talking about the role of TE in liver transplants. It all depends on the volume of patients that you handle. It is, having said that, it is quite a resourceful thing. A lot of resources are required. If you run CRRTs regularly, you can take a leadership role in that. Otherwise, it is better we take one step back and we are involved, but it should not be just us. As Selva said, maybe a hybrid responsibility usually seems to work because the dialysis technicians are usually coming from the nephrologists. They do not report to the intensivist unless yours is a very, very high volume center where the intensivist can handle the technicians full time under their care, and the nurses are also equally trained. If your center is not a high volume center, it's better to go hand in hand with a nephrologist because you need a consistent number of cases to be well familiar. Like any anesthetist should be doing say for example, if it's a pediatric anesthetic, should be doing specific number of pediatric cases per year to be consistent, to be well versed and be comfortable handling those patients. So if it's not a high volume center, it's better to take one step back and let the nephrologist handle it. But if you're very familiar and running them continuously and comfortably, then you can go hand in hand, but let the dialysis team also get involved in this. Now, handling a rapid inadvertent rise in sodium during CRRT in a patient with renal dysfunction and hyponatremia. As Selva said, the thing that works for us is running D5 in the post-dilution CVVH, running it as a replacement fluid rather than meddling with the bag. The bag is what we have. It has a fixed sodium concentration. So leave that alone and add a separate replacement fluid. And the rate of that can be calculated based on what sodium rise you want for that patient. So rate of infusion of replacement fluid should be calculated based on that. The other thing which you can do is to decrease the dialysate flow rate. It can be as low as 300 to 400 mL an hour. That will also produce a less rise in serum sodium, but you'll have to take it with a pinch of salt. If it's just the sodium and the fluid overload that you're worried about, then you can do it. But if you want other solute clearance as well, then this decreasing the dialysate flow rate will not work. It is a little complicated, not for all centers to use, is what I would like to say. It is better to get the nephrologist involved because it involves kinetic modeling as well. You'll have to have the equation in hand to calculate the dialysate flow rate to achieve a desired sodium rise in the next 4 hours or so. So it is quite complicated, but adding D5 in the post-dilution in addition to the replacement fluid seems to do the trick in most of the instances. And regular sodium monitoring is also required.
Thank you, Dr. Kilo. Indeed, changing or modifying the dialysate fluid would require a lot of support from the pharmacy as well and requires a lot of logistic issues. So post-filter D5 is indeed the strategy we also use. Yeah.
There are a lot of centers which can make up their own dialysate fluid, high volume centers in the US, but they can do it. But we are, unless you're a large volume center where you make up your own thing, everything is customized to the patient, then I think it works. Otherwise, it's better not to meddle with the bag.
Going ahead with this patient, after 48 hours of CRRT, he remained hemodynamically stable. The hemoglobin was 8.2, the platelets 39,000. The creat had improved to 1.8 and the sodium had improved over 2 days to 127 from 118. And the cultures sent pre-op were sterile. Meanwhile, the donor workup was also being done as he was being planned for an LDLT and 2D echo was normal. To summarize, he was a NAS-related CLD with ascites, hyponatremia, HRS on CRRT and coagulopathy. Post-PTCA, CAD and a morbidly obese recipient planned for LDLT. The donor planned was his wife, 43 years old, ASA1 patient. She was planned for a lap donor hepatectomy with an estimated graft weight of 790 with estimated GRWR being less than 0.7, near to 0.7. Dr. Lakshmi, as you have a good experience of a good volume of robotic hepatectomies at your center, could you opine on the fluid management in minimally invasive donor hepatectomies? Is there any difference from open donor hepatectomies fluid management?
Yeah, there is a lot of difference. I think in open, on an average, I use somewhere between 3.5 liters to 4 liters towards the end of surgery, about a liter before they start transection. Here, when you talk of minimally invasive, it's part of this ERAS pathway. So everything is, they have their carbo load drink. So you really don't need to load them even at induction. So policy that I have is 2 ml per kg per hour. And there's always a kind of a checklist. Is the mean arterial pressure more than 65? And is the urine output, it's not even 0.5. I would like it at 1 ml per kg per hour. And then, of course, you look at lactates. And more importantly, there's always a verbal communication with the surgeon whenever the IVC is visualized. Because unlike an open, even though you say CVP is not predictive of volume status, our literature says keep a low CVP. Now, that doesn't work in a laparoscopic or a robotic. So basically, 2 ml per kg per hour, targeting 3 endpoints: mean arterial pressure, lactate, and urine output, with a low threshold to start a vasopressor if needed, until resection, and a little bit more generous fluid replacement once the resection is over.
Thank you, ma'am.
Regarding the type, is that for me too, the type of fluid?
Yes, ma'am.
So type of fluid, I think a lot of us have spoken. We started by using a mixture of ringer lactate and normal saline 15 years ago. And then Plasma-Lite entered the picture 2010, 2011. And ever since, I think Plasma-Lite has more or less been the main fluid of choice for most of the donor resection. Some people like to use ringer lactate till a point the lactate starts to rise, and then move on to Plasma-Lite. So mostly it's acetate containing balanced salt solution, which is the fluid of choice. And of course, I don't use colloids in my practice. I refrain from using them. And if there is some blood loss and HB is okay, then sometimes we may use albumin towards the end.
Okay. Moving ahead to the recipient OT now, and Dr. Ashish, what kind of a fluid strategy would you recommend in this recipient? Would it be a restrictive fluid or some kind of a goal-directed fluid therapy? And what are your concerns regarding intra-op fluid therapy in this patient?
Thank you, Anil. And so 3 things. First of all, what kind is restrictive, liberal, or goal-directed? So I think the liberal is out of question, and the restrictive, we can't be too restrictive about it. So the concept of goal-directed came up, and then what are the goals which we aim for? That's something about the fluids. So when I started getting trained in liver transplant, there was a lot of use of crystalloids intraoperatively in recipients. And slowly over the period of time, I observed that the colloids are gaining much more importance. So I would say that especially in the dissection phase, I would go in for something like a replacement regime. That means I can't be too restrictive, that the concept of giving low CVP versus high CVP. And it could be more of a clinician-oriented use of these fluids. Then the type fluids, crystalloids or colloids, I personally use a lot of colloids in my practice. And the crystalloids would be now mostly balanced salt solutions. Normal saline was being used, but it's more about the balanced salt solutions. Then colloids, again, I would look at what is the normal colloid, which we use is albumin or the synthetic colloids. So test has gone out. There were a number of studies regarding that it could be a proponent to AKI and all those phenomena. And if you look at what goal-directed, the recent ILTS consensus guidelines in Spain in January, at least delineated one goal of a mean arterial pressure of more than 65. The other goals, which could be a lactate less than 2, which is usually not possible, or CVP between 8, or these are different parameters on which you could. But definitely, if we can, specifically in this patient with obesity and post-CAD, plus has a history of AKI, if we have an intraoperative echo picture, so the fluid could be also be managed according to the echo pictures inside. So that's my take on it, the fluid therapy intraoperatively, and that would be the particular concerns here. I would not be too worried about, definitely hypervolemia is out of question. There are a lot of problems which you can encounter due to hypervolemia, but just to maintain it towards that level where we are just replacing, and I'm talking only about fluids, not the blood products.
Okay.
I hope that.
Yes. Then coming to the next important question in this patient, Dr. Silva, would you go ahead with an intra-op CRRT for this patient? And what would be your fluid electrolyte management if you're going ahead with or without it?
Thanks, Anil. So intra-op CRRT, whenever a patient is on pre-operative CRRT, we definitely continue with intra-op CRRT. Generally, we don't initiate a CRRT unless there is, very significant oliguria and expected major blood loss or transfusions. So definitely, if there is a pre-operative CRRT, we would like to continue the CRRT intra-op. It gives us more flexibility in managing the fluids and electrolytes. So the fluid removals can be, we titrate the fluid removals with regards to the transfusions predominantly. And of course, because there's a lot of, if there is a plasma involved, if there is bicarbs corrections involved, without a CRRT, we might end up with pushing the sodium too much without any, feedback. So definitely CRRT is what we would continue. And then the choice of crystalloids or colloids, again, I think Dr. Ashish spoke about this, but whether the patient is on CRRT or not, our choice has always been crystalloids, and colloids we are gradually, coming off gradually. Synthetic colloids definitely are coming off, and we're using a little bit of, either 20% albumin or 5% albumin. Predominantly off-NS and plasmolate combination is what we use. Of course, if the patient is on CRRT and volume overload, the volume of fluids which we are going to use is going to be obviously very limited. The monitoring, again, as Dr. Ashish was saying, the goals are difficult actually, meaning you can't obviously completely depend on urine output or lactate, because they are influenced by multiple other factors. The BP and the fluid responsiveness to BP is a very basic thing which we can do. SVVs, PPVs again are quite easier to follow. CVP trends can be followed. But of course, we would prefer to have something like a transpulmonary thermodilation method like a PICO, which has been our mainstream of hemodynamic and fluid monitoring management in complicated cases.
Dr. Lakshmi, would you differ in your intraop management? Would you use or do away without CRRT intraoperatively? Dr. Lakshmi, please. And we'll move ahead. Transfusion management will also have a huge implication on our fluid balance. So this was the baseline ROTEM in this patient with a prolonged CT extem as well as CT FIPTEM, and very deranged MCF extem as well as MCF FIPTEM. So Dr. Akila, how would you correct the coagulopathy in this case, and would you use factor concentrates in such subsets with the volume concerns?
Yes, ROTEM looks like he needs all clotting products to be corrected. We don't go with the ROTEM alone. We also look for evidence of bleeding, but in all probability, looking at the background, I think there will be a lot of bleeding concerns in these patients. Our experience with factor concentrates is not too high, I should say. We've used PCCs in patients who've had bleeding issues post-op. Experience with fibrinogen concentrates, it seems to work, but the cost is prohibitively expensive. So that is not something all our patients can afford. I think PCCs are less expensive compared to the fibrinogen concentrate because the dose required for correction seems to be very high and seems to be expensive. So that is regarding our experience with factor concentrates, but it seems to work if you've given them the good dose. Because the patient has coagulopathy, I mean, he has a CRRT which is running, it would still be safe to give blood products and remove the volume with the CRRT. The concern of lung injury with all the blood products is slowly coming down as the center gets more experience in the way the products are prepared and thawed. So I wouldn't be too worried about giving blood products and in this patient, but CRRT as a, it's a great toy to have inside theater. You can adjust anything and everything.
So moving ahead with this patient, surgery lasted for 6 hours. The blood loss was 1.5 liters and the ascitic output was 5.5. There was almost nil urine output throughout the surgery. The patients received 5 units of PRBC and factor concentrates based on the ROTEM. He had a difficult post-op period with issues with weaning, required tracheostomy, required antibiotics to be escalated, post-op inotropes, and CRRT was required for a prolonged period. He had a prolonged ICU and hospital stay, but could be discharged home with a stable renal and liver function after 35 days post-operatively. Dr. Silva, what are the post-op fluid management strategies in your transplant ICU what are the choice of post-op fluids, and do you target any particular daily fluid balance?
Yeah, so fluid balance, fluid choice of fluids in the post-op is similar to what we follow in the intra-op, but slight difference is we prefer a bit of more balanced salt solutions than often. So it's the maintenance fluid is predominantly plasmolate, but not in high doses, say somewhere between 1 to 1.5 ml per kg in the initial day, or maybe a couple of days maybe. This is for a patient who doesn't have volume overload. And then we also run small infusion of 20% albumin or 25% albumin, about 10 ml per hour for the first couple of days, just to moderate the amount of free fluids we end up giving. The other special situations are, again, if there is any hemodynamic instabilities, we challenge with volume and then see the response, and then further on decide about the amount of fluids needed. If there is a lot of drains, there is also a drain replacement which can come in, but if it is more than a liter, then obviously that is when we start correcting. The replacement can be anywhere between 50% to 100% of the daily drain output. Obviously, for this patient, if the patient is already having volume overload and having a CRRT on board, and the monitors are showing that we have good intravascular volume and hemodynamics permitting, we will try to obviously not give a lot of fluids or completely stop the IV fluids. If your patient is going to be ventilated for a couple of days, then even start early enteral fluids and then continue with the fluid removal in the CRRT. The fluid balances, if it is a normal, if it is not a volume overloaded patient, first couple of days we allow a little bit of positive of about maybe 500 to 1000 ml. We would probably prefer having a neutral balance, but it is usually not achievable. But after a couple of days, as the fluid starts coming in, we would try to achieve a neutral balance, and in volume overloaded patients to some extent, bit of a negative balance. The rationale is basically, in addition to the intravascular volume and the day-to-day requirements, we need to consider two reservoirs of fluids the patient is having. One is the interstitial fluid, the edema, which is always there, which provided the graft is good, comes back into the circulation, maybe by POD 3 or 4. So that can be a significant input which can come in. And the second thing is the significant vasoplegia which these patients have starts reversing after a couple of days. And then that will also push the splagnic fluid, the fluid which was pooled, the blood which was pooled in the splagnic circulation. As the resolution of, to some extent, the portal hypertension and the resolution of the vasoplegia, it can come into the system. So we need to watch out for this. Basically, if the graft is picking out well, there is a good return of fluid back into the central circulation, which can be picked up by your changes in the trend of CVP, the hemodynamics, the neuro requirements and everything. So in those situations, we go for aggressive either a diuresis or fluid removal. So in those cases, definitely a big negative balance.
Thank you, Dr. Silva. Just moving to the last question due to shortage of time. Dr. Ashish, in your opinion, what would be the key interventions to improve such outcomes in such high-risk patients? Dr. Ashish first and then Dr. Keela to just wrap up. Yeah.
Thanks, Anil. I think you've done an excellent job in managing such a high-risk patient. Obesity is of a concern. That's one thing, and the CAD, and as highlighted, it could be a metabolic syndrome which is developing. But the other, I think the CRRT was a good option. That's something. Then, because of all these aspects, I would like to, because I'm quite a proponent of TAE, so would be having that kind of an intervention. Otherwise, I don't suggest that any other things, but it was quite a well-managed case with the pre-op AKI. Did you use fibrinogen concentrates and PCC in the patient?
Yes, sir. We used factor concentrates, both PCC and...
So I believe the reason for you to use is the volume as well as the sodium.
Yes, sir. And we didn't use intra-op CRRT, so we were concerned about the volume.
So I have very little experience of using intraoperative CRRTs, even in durations of surgeries lasting for more than 12 hours. So whether the sodium or potassium and the lactate is a concern, I don't think the clearance would be that great, and the volume almost remains the same. So in our center, we don't use fibrinogen concentrates or PCCs at the moment. But I believe that was your thing, and sleeve to keep the volume as well as sodium in check. Otherwise, I think it has been a well-managed case. Thank you.
Thank you, sir. Dr. Akila, would you add any key interventions?
I think it's a well managed case so far as we've discussed. Some only thing which we do a little different would be this is a patient who's obese, already starting off with a high risk with a low GRWR. We'll try to get him as optimal as possible if the situation allows. He doesn't look like a high MEL patient except for the creatinine that we saw. I mean, that might be adding on to the MELD, and no major decompensations except for the kidney issues. Maybe give him some time to optimize before we start him on CRRT and then take him to theater, considering the fact that it was LDLT and is a end-stage liver disease. There's no ALF there. Another thing is use of intra CRRT, because we have already started that in the pre-operative period. It is a very nice toy to have in theater. Believe me, if you start using it, you'll definitely want to use it if you're more familiar with it. Everything can be handled, whatever complications that you're thinking about in terms of metabolic and fluid overload, not everything, but metabolic and fluid overload, volume related issues can be handled. So that's something we can think about. But if you're looking at a low GRWR status, better to get the recipient to the near optimal stage as possible if the patient can wait for a week or so. And use of factor concentrates is a brilliant idea if you have the resources, the finances permit you to do it. Yeah, other than that, I can't think of anything else.
That brings us to the end of this session. Thank you to all the panelists for having such a wonderful discussion. Thank you.
Thank you.
Thank you, Anil. Thank you for the fantastic panel discussion. Now we'll move on to the next session. The next panel discussion is on cardiac assessment before liver transplantation, designing the best algorithm. And I would like to invite Dr. Vijay Vora to moderate this session. Dr. Vijay Vora is a chairman, anesthesia and critical care, Medanta Hospital, Gurgaon. And among the panelists, we have Dr. Dheeraj Gandotra. He is an additional director, cardiac sciences, Fortis Hospital, Noida. Dr. Vinayak Agrawal, director, non-invasive cardiology, Fortis Heart and Vascular Institute, FMRI, Gurgaon. Dr. Shweta Singh, director and head, anesthesia and critical care, CLBS, M.I.C.E Center of Liver and Biliary Sciences, M.I.C.E Super Specialty Hospital, New Delhi. And Dr. Sanjeev Aneja, senior consultant in the Apollo Hospitals, New Delhi. So Dr. Vijay Vora, over to you, please.
Hello, sir. Good evening.
Hi, good evening. I'm just trying to share my screen. If I can.
Actually, I can see you, I can see Piyush, and I can see Dr.
I know. I want to see my screen. Are we there? Yes, can you see the screen now?
Yes.
Yes, we can see, sir. We can see.
Right. Okay. Thank you, guys. Thank you, part of the panel. Dheeraj, Vinayak, Shweta, Sanjeev.
Hi.
Hi. So let's get on. Cardiac assessment before liver transplantation, designing the best algorithm. Why we're talking about it is, you see, cardiovascular issues, if you see over here, are really one of the major issues. After operative mortality and mortality because of infections, the next thing is cardiovascular. You look at it at a 1-day mortality or 1-month mortality. So really, we do need to talk about it. I mean, like any major surgery, you do cardiac assessment. But I think here it's something more than that, because we know they have a lot of patients do have arrhythmias. They have congestive failure, a lot of patients post-op, and that must be contributing to morbidity and mortality. So if we can answer the following questions, I think we are nearly there. Questions are they at greater risk? These guys, patient coming for liver transplant. Is cardiac evaluation challenging? Is it different? Is it like any other patient which we evaluate for cardiac thing? And how do you identify these at-risk patients? Why is it difficult to identify these patients? And if we have got there, I think we can have a pathway. And then we can even, as a corollary, we can even optimize them. So really, we do need to have a pathway for them. We need to design some way how we are going to manage patients coming for liver transplant and evaluating them. So let's get on. Why is cardiac evaluation challenging in this subset? Like for any major surgery, why is it more so? Dheeraj, can we get on with you first? Is Dheeraj there?
Sir, I think Dr. Dheeraj has not joined yet.
Okay,
so,
okay. I think Vinayak will do the honors.
Sure, sir. So I think it's a very important to understand that liver transplant and the cirrhotic patients with chronic liver disease is a special subset to begin with. These patients, normally if a patient comes to us for surgery, we usually order an ECG, in some cases echo. In patients with risk factors, we go for stress echoes, dobutamine stress echoes, or perfusion imaging, SPECT, thallium, etc. But in these patients, because these patients tend to have very low SPR, so they're vasodilated, there is a hyperdynamic circulation. It's very difficult to actually assess the true presence of obstructive coronary artery disease, and there are hidden subsets like the cirrhotic cardiomyopathies, then portopulmonary hypertension or hepatopulmonary syndrome. Nothing which you can really pick up on routine testing. So this is a special subset where you have to have a keen eye on picking up the possible comorbidities, the possible associations, and each of these independently has prognostic implications. The perioperative phase can be tough in these cases. Some of these patients we've had who had valvular diseases like aortic stenosis, a lot of them have diabetes, hypertension, comorbidities, which we know increase the risk of perioperative complications. So I think there is a lot of discussion which needs to happen in these patients.
Yeah, thank you, Vinayak. See, also, these guys are generally older. They are 50 plus. Average age, if you look at any subset, they are 50 plus, and they will have comorbidities. And because they don't move about, they could be even asymptomatic. They must be harboring things in them, but they don't move. And, you don't see any symptoms like they're not huffing and puffing, no poor exercise tolerance. The symptoms, sometimes you say, oh, well, he's got chronic liver disease, he's not moving, maybe it's because of that. So all these things, yes, they do contribute. Cardiovascular issues, I think you won't deny these two things are definitely there. CAD you have to look out for, cardiomyopathy you have to look out for. So let's leave them aside for the moment. Sanjeev, are you there?
Yeah, I'm there. Yes, Vijay.
Okay. Any other issues besides these two? I know Vinayak referred to. You have CAD, you have to definitely, we'll talk about it a bit later. Cardiomyopathy also we'll talk a little bit more in detail. Besides that, what are the other cardiac issues which you have, which you must look out for?
Other issues which probably are common in general population, you are also likely.
I'm talking about liver patients.
You're likely to see in the patients coming for liver transplantation. Simple like arrhythmias. Arrhythmias are very common. You need to find atrial fibrillation, which is quite common. You have to be very careful and then look for what is the cause. You probably valvular disease. You need to look into it, and congenital diseases, valvular diseases. And all these diseases probably, and the pericardial diseases, all these diseases are there in these patients. of coming for liver transplantation. Arrhythmias are more common. Arrhythmias, probably atrial fibrillation, you would find in significant number of patients which have a outcome in the post-operative and perioperative period.
Shweta,
Yes, sir.
are you there?
Yes,
Anything more that you look out for these patients? Can you add something more to this?
I think cardiac arrhythmia is definitely something we really need to screen them for. We take them, we generally have a lot of problems post-operatively. These patients land up with atrial fibrillation. And then it's like, you're trying to find out what was the reason. Was it there beforehand? And in children, like Dr. Neja mentioned, cardiac anomalies, congenital anomalies, and we are seeing so much of situs inversus. Maybe it's related to congenital other syndromes which these children have.
Maybe the kids, yeah. You will have them in kids, yeah. Yeah. So what I was looking at, do you see much of left ventricular tract outflow obstruction, Vinayak? I mean, what's your take? Do you see many of these in our liver patients? Is this a subgroup which is likely to have more of LVOTO?
So I think LVOT obstruction is commonly seen in these patients because they have hyperdynamic circulations. They do tend to have left ventricular hypertrophy as well. And a lot of times when the heart rate is high, you can see a dynamic mid to mid LV or LVOT gradients developing in these patients, especially when you do a dobutamine stress echo and you're pushing dobutamine as well as raising the heart rate up to, whatever the target heart rate is. That's when we pick up the most dynamic gradients. Earlier studies a few years back used to say that if you had an LVOT max or peak gradient of 36 and above, these patients had poor prognosis. But in a mass majority of cases that I've seen over the last 10 years or so, I don't think so that that value is correct. A lot of it is also dependent on the fluid status. The patients are anemic, hyperproteinemic, so there is a high output state which is there, and that can contribute to the LVOT gradients. But I do agree that they should not be ignored. You should optimize the patient. Try and get the LVOT gradients down and optimize before you take them for surgery.
Yeah. Thank you, Vinay. You see, the thing is, LVOT, if it is there, and on top of that, you start stimulating them. You trying to get the cardiac output up in one of these patients. Let's say at reperfusion, it's going to be catastrophic. You need to probably give him that guy probably a beta blocker. So I think if it is there, you have to look out for. And we forgot about Shweta, portopulmonary hypertension. Don't you look out for that?
Yeah, so for that we have this, baseline echo. I think that is the best test because it tells you the right ventricular systolic pressure, and we go by that. If we feel that this patient is highly volume overloaded, we could even kind of get rid of the extra volume by diuresis and then reevaluate and see for the right ventricular systolic pressures. And only then would we actually think of investigating for portopulmonary hypertension.
Sanjeev, do we look for tricuspid regurgitation? Are you worried about tricuspid regurgitation? These guys are generally overloaded. Tricuspid regurgitation, let's say, I'll come back to Vinayak afterwards on that. What's your take on tricuspid regurgitation in these patients?
Tricuspid regurgitation is because you're overloaded. It's quite common, and sometimes it is also combined with a mitral regurgitation. Sometimes you find both regurgitations, and these are quite common, and it leads to a high cardiac output state.
Yeah.
And in fact, if I could say, even a raised JVP, if you see it, is not so significant because it would be a part of this.
So Vinayak, severe tricuspid regurgitation. What do we do? You are on.
One thing which I want to say here is that if you take 100 people from a normal population and do their echo, about 70% of them will have probably mild tricuspid regurgitation, which is physiological in nature. These patients have all the milieu for developing moderate to severe tricuspid regurgitation. They're fluid overloaded. They have high output states. So TR is common, and most of them, if you find a high PA pressures, that's where the conundrum begins, because there are three possibilities in these cases to begin with. One is that it is due to a kind of a heart failure with preserved ejection fraction. If the ejection fraction is normal, the PA pressures are high, so it's a congestive heart failure. If the ejection fraction are low, then we will label it as heart failure with reduced ejection fraction when the EF is less than 40%. The other is the portopulmonary hypertension, because your first step to even start thinking about portopulmonary hypertension is when your PA systolic pressure is more than 50. So the third thing which we should look into is the possibility of hepatopulmonary shunt, because that is also going to raise your, the PA pressures. Now, to distinguish between the two, one simple thing which we do in all patients of CLD when they come for evaluation is to do a bubble saline contrast. And if you find an HPS, then you know that, okay, you're dealing with a hepatopulmonary shunt, which may be leading to high pulmonary pressures. Portopulmonary hypertension is a little difficult subset, and maybe we can discuss it later. But
okay.
Yeah.
Let's move on. Pericardial effusion you might find somehow in some of these patients, and then sometimes you see you also have to look out for hemochromatosis. That's also patients you will see every now and then. But I must say I'm morbidly scared of severe tricuspid regurgitation, because if you do operate on them, the graft is not going to function. It's all backward pressure, and they're not. Look at this study here, TR and outcome. They don't do very well. So I think severe TR is something to watch out for. Now let's come to the coronary artery disease, which we are talking about. CAD. Low cholesterol, not hypertensive, high estrogen, all good things for CAD. Why do they still have CAD? Vinayak, I think you go to start off with this. That's your domain.
So that's a very interesting question, and I think perspective. We know that CLD per se should not have high, incidence or prevalence of coronary artery disease.
Yeah.
And I remember numerous interactions in international conferences with our colleagues, and they just wouldn't believe that the prevalence of coronary artery disease is high in patients of CLD. There are a few reasons. The age of patients presenting with chronic liver disease and cirrhosis is increasing. That's number one. Number two, we have a lot of patients who are diabetics. Now the NASH-related CLD is increasing many folds. You have hypertensive. So about 50% of these patients tend to be diabetics and hypertensive, about 25% each. Then you have, look at India. Indian scenario, to give you a perspective, 1 in 10 individuals today below the age of 50 have coronary artery disease. They present with acute coronary syndrome or MI. So in India, we are a different subset. We have so much more of coronary artery disease subset because of the conglomeration or accumulation of the risk factors that we have. So smoking, hyperlipidemia, all of them contribute to the presence of high coronary artery disease in these patients.
Yeah. So we do have, yeah. Is
actually,
that Shweta?
Yeah. Am I not visible?
No, you're not.
Oh.
I'm going to see your face, Shweta.
I thought I was visible.
You are invisible.
Actually, I was when you started, you brought this question up. That is coronary artery disease more common in patients with cirrhotics? Because 20 years ago, like Dr. Vinayak said, that we used to think that actually it's lower because they don't have hypertension, as you said, they don't have so much of, they have low cholesterol. So would you now say that actually cirrhotics, and I'm not talking about, of course, diabetics, metabolic syndrome, all this is definitely contributing, smoking, but would you say it is more common? Especially it is common in post-transplant scenario. But
like Vinayak has already pointed out, it's more males Diabetes is also quite common with hepatitis C. You got NASH. 23% of NASH, they say, have critical CAD. So, it definitely is. You probably reduce risk from one side, and then it's going up on the other side. I think Vinayak wanted to say something.
So I'm just saying that, see, if you look at 2022 data, okay, 2020 to 2022 data, the documentation of CAD in transplant patients is nearly 16% prevalence of, CAD, which is huge. I mean, this is something which, and remember that we woefully fall short of picking up patients of CAD in these patients because of various reasons, which we will probably discuss in future ahead of in this discussion. But what I'm trying to say is that CAD is very, very prevalent, and it's a misconception if you feel that it is not something which we should be looking for. It is. I'm giving you a 2022 data which was published in liver transplant, that there is a 16% CAD prevalence before transplant, before liver transplant.
Yeah, I think we have also brought out some data, and it's in our subset, it was about 14% who have what you call coronary artery disease, and about, I think, 50% of them have severe coronary artery disease. I think let's move on. We only have very little time left. Role of stress testing. Does it predictably identify CAD patients? Sanjeev, you are very quiet, and you are also not visible.
Yes. The non-invasive tests used to identify coronary artery disease have universally low sensitivity in patients of cirrhotic patients because of hemodynamic status, which is different in the subset of the patients. And invasive, should we do invasive coronary evaluation in all patients? That is a point of discussion. Probably people will be discussing this. But yes, we have a limitation. The non-invasive tests in this subset of patients have low sensitivity. That is the problem in identification.
Is Dheeraj there or not?
No, not yet, sir.
No,
Only
okay.
he has some issue.
So we keep him out, yeah. So that's
Yes,
okay. If he joins in, let us know. So, Vinayak, between the stress echo and stress thallium, what do you have?
So, as Dr. Sanjeev just said, that if you look at last 10 years data about stress testing with dobutamine stress echo or perfusion imaging like adenosine spec imaging, perfusion imaging, MPI as we call them, myocardial perfusion imaging. These have been systematically been shown to be not more than 30 to 40% sensitivity and specificity. There were few papers which said that dobutamine stress echo has a very good negative predictive value, and if the DSC is negative, then the outcome in these patients is generally good. So it has a good correlation with outcome data in liver transplant patients. But I disagree with that also. See, what happens is that when you do a dobutamine stress echo, like if I do about 1,000 stress echoes in a year, in a year, I would probably in a normal subset, I'll pick up about 20-25% patients who are given in a normal population who will be abnormal or positive for reversible myocardial ischemia. But in dobutamine stress echo, when you do it in a liver transplant patients, it will just pick up 1 or 2%. It is woefully short on picking up, CAD in these patients, obstructive CAD. Same as with MPI. So the sensitivity specificity is not more than, in various papers, it will be 30 to 60% sensitivity and about 30 to 60% specificity at max. So we definitely need to add more information in patients who have 2 or more than 2 risk factors for coronary artery disease. And we can elaborate on that later.
Okay, you see, I just want to share this slide with you. In 1998, this guy, David Levick, came out, echocardiography identifies patient at coronary risk. What's happened? Why the slide is not, okay. And, he had then designed an algorithm that, how to go about it. But that time he thought stress echo was the best thing around. Another study, this was a bit later, DSC may not accurately identify underlying CAD, which Vinayak has just said. Another study, Finlay, positive DSC was a poor predictor of myocardial injury, but a negative was strongly predictive, which again, Vinayak is saying probably not true. What about calcium score? Shall we move on there? How's calcium score? Does it help you anyway in identifying these patients? Shweta, do you use calcium score at all? Is it reliable?
We have no experience of using the calcium score. And personally, we have looked it up in literature, and we really have no experience.
Right. Vinayak, you want to come in or?
Yeah, sure. I can actually speak for an hour on this.
You don't have that much time, sorry.
I'm just joking. I'm just saying.
Hey, Sanjeev, let's have
we don't use calcium score actually.
Okay.
We are not using calcium score.
The Vinayak is my friend. You use.
I can listen to him.
Yeah.
So the people who know that I was at Medanta earlier for 10 years and did a lot of work with Dr. Vora. See, calcium score is absolutely, I would strongly advocate coronary CT calcium score as one of the modalities for identifying coronary artery disease subset in these patients of going for liver transplant. And there are many reasons for that. Number one, it is a safe test to do. We know that if the calcium score is, say, if it is 0 or less than 100, the chances of obstructive or occlusive coronary disease are low. If it is more than 400, the chances of significant occlusive disease, which is defined as more than 50% stenosis of the epicardial coronary arteries, is high, but it is not one-to-one correlation. Like you can have a calcium score of 1000, but when you do a coronary angiogram, you may not pick up an occlusive disease. However, you know that these patients have significant atherosclerosis, and hence they may be a reason for developing acute myocardial infarction, ACS, and heart failure, etc. in the next 5 years post-transplant, which is very, very important. So we know that the stress echoes do not show much more than 50% sensitivity specificity. Calcium score comes in those who have 2 or more than 2 risk factors for coronary artery disease, gives us a very important message. Suppose there is a diabetic who has a calcium score of 800 and the DSC, etc. may be negative, but I would still probably go for a coronary CT angiogram in these patients, just to be sure. And if the patient is symptomatic, has had any regional wall motion abnormality on echo, then definitely a coronary angiogram would be required in these cases. So I would, and there is enough data to say that if you have a calcium score, coronary CT calcium score of more than 400, then you should definitely escalate it to a CT angio or a coronary angio, depending on your personal choice or the institutional choice.
What normally CT you do? Do you do the special CTs like thin CTs, gated CTs, or what are CTs done for any other purpose to calculate calcium score?
So we usually do ECG gated studies where we are picking up calcium score, agastatin score is being picked up. And that is something which it takes 5 minutes to do. It has no dye, no injury to the kidneys. There is no fluid overload. It has low radiation as such, and it gives you a plethora of information which is additive.
My problem or my question on the calcium score is that it works similar to like the DSC in majority of the cases. Like the calcium score, if it is more than 400 or the DSC is positive, yes, in the both cases, you can conclusively probably say that the patient needs coronary angiogram to do the coronary vascularization or whatever. If it is less than 100, yes, it is fine. But the problem is if it is in between these two, then it leaves us at the same point where the DSC leaves us.
Sir, I have a comment on this point. Yeah. So actually, in last 6 months, we had 3 patients, those who have a high risk, more than 2 risk factor, and we did stress echo, and they came negative. But those 3 patients developed myocardial infarction after the surgery within 72 hours. those luckily they survived. So after that, we adopted a policy of not doing an DSC in the high-risk group, and we started doing the calcium scoring. And in those high-risk group, we picked up 2 patients where the calcium score was high, and we did the conventional angiography, and we actually found them the critical stenosis. So after that, these incidences, we have actually adopted doing calcium scores in the patients who have more than 2 risk factors and going for the liver transplant. So I think this can be a good tool, as Dr. Vinayak said.
But Piyush, don't you think every patient is having more than 2 risk factors?
2 risk factors plus DSC negative.
Yeah.
Then
exactly,
probably
because
I think we can
coronary angiography.
I think we can carry on this.
The prevalence is so high.
Yeah.
And the risk factors are all there.
We need to find out that whether
maybe we should actually look
those
into
stenosis
calcium
are
scoring.
critical or not. That we need to find out. So if the calcium score is high, so definitely we should go for further working up and finding out whether they have a stenosis and whether they are prone to develop the stenosis, or they are prone to develop some kind of cardiac event after the surgery. So I think it is a good tool. So we found, this is my experience in last 6 months. So
I think probably with the intermediate things, we are still at dark. We do not know how to proceed.
Chances of false negative,
more than 400, we are fine.
Yeah,
DSC
chances of false
positive, we are
negative and
okay.
false positive DSC is pretty high in this subset of group. I think Dr. Vinayak is
False positive, probably false negative. I'm not sure.
So I think let me share some data with you of the calcium scores which we have done. So if you look at it, patient who had low calcium score between 1 to 100, we divided 2.7% of them had critical stenosis, 100 to 400, 17%, and more than 400, 35. See, it's not absolute thing. It's going to give you some hint. Nothing is 100%. Let's be sure. Nothing like conventional angio. That's no comparison. But having said that, I think, like Vinayak has also said and Piyush has also said, it gives you a clue. Look, this is a likely candidate. You will not 100% get it right. But then, yes, very high calcium score, yes. Very low calcium score, definitely less likely. Vinayak, yes.
There is no relation with the obstructive element or the degree of obstruction if it is 50 to 60% and the post-operative outcome. And the calcium score is basically telling us about the obstructive score.
No.
Yeah.
No, it is not.
But Dr. Vinayak, what is the correlation with, like Dr. Neja said, obstructive CAD? Because there is collateralization. You have a patient, there are risk factors. Piyush, you had 3 patients who had post-operative MI. But could you really do anything in the pre-op to revascularize those patients?
I think we are reaching the closing time. So let's get on. Okay, this will never stop. This is a tool, I think, worth investigating. And there is some evidence that it can help you. It's not something absolute. Right. So next 5 to 10 minutes, we have to conclude. Let's talk about cirrhotic cardiomyopathy. Again, how much of a problem is this? Sanjeev, let's start with you.
Probably cirrhotic cardiomyopathy is probably, you would see in quite a few number of patients. If you see the electrophysiology, QT interval, probably it would be prolonged in large number of patients.
Is that a problem normally? Do you get stuck with somebody with cirrhotic cardiomyopathy?
I would say probably gastric dysfunction, which is quite common. It just keeps you that you should be more careful.
Yeah.
You can sometimes get into ejection fraction maintained failure if you have a gastric dysfunction in the preoperative period. And the cirrhotic cardiomyopathy have a large incidence of gastric dysfunction. I do not know means it is a cirrhosis or something.
If you look at the the 2019 cirrhotic cardiomyopathy consortium definition, which the proposed criteria, they look at the LV ejection fraction less than 50% or a GLS, the global longitudinal strain, which we do in our center at Fortis in almost every patient, less than 18%. And then diastolic parameters like E upon E prime more than 15, etc. And then chronotropic incompetence, QTC interval, etc., cardiac enlargement. If you put these criteria, almost I would say 60% of the patients would have cirrhotic cardiomyopathy by definition, maybe more actually. Now, in these patients, if you do troponin I or anti-proBNP, we know that they are prognostic markers. Patients who have high troponins and anti-proBNP or BNP pre-transplant have poor outcomes as compared to those who are normal ones. And we are not saying that they are in heart failure only, but because BNP, etc., can go up because of various reasons. So can the troponins. But if they're high, they are a poor prognostic marker. There's no doubt about that. And I think it should be done in almost all the patients.
Yeah. If you look at this slide, pro-BNP, anti-pro-BNP, if you are very high, definitely have a poor survival rate is poor. 1 year survival, also 30-day mortality. All of them are much poorer. Okay, I think we are nearing the end. Designing an algorithm. A lot of people have said a lot of things, but tell me, I think 10 seconds each, which one of these is most important? Medical history, physical examination, don't take very long. Sanjeev, which is more important out of these?
Medical history, physical examination, basic fabric.
Risk factors, come on.
Risk factor, yes, identify. No risk factor, probably you can even omit the special cardiac investigation. Functional status.
Shweta,
your thought.
Risk factors are important. Functional status is abhi ka kharab hai. They're asymptomatic because they don't exert.
Vinayak, one line.
So I would place risk factors at the top straight away.
Yeah.
And the second for me will be functional status, because we know that both of them will be important for prognostic purposes.
Yeah, okay. Again, you see, you have to either use metabolic equivalence or KPS score. And if you see, does anybody use 6 minutes walk test?
We use chair stand-up test.
Yeah. So again, I think 250 meters or whatever it's a. Does anybody use cardiopulmonary exercise testing?
Yeah, so I have just introduced it at Fortis Gurgaon. We've just got the machine about 1 month back. And just like liver cardiac transplant patients where the VO2, peak VO2 less than 14 is considered a poor prognostic marker for, so can it be for the liver transplant patients. And I think it's a very important modality to be used in these patients. It can give you a lot of information.
It is modality which is not specific for liver transplantation. For any perioperative outcome, it can be used.
Yes.
Yeah, you're right. A lot of our patients may not be able to do it. That's a different thing altogether. Yeah. Okay. Right. Finally, the algorithm. That is what we are talking about. A lot of people have designed this. Just have a quick look, then we'll move on to the factor. Asymptomatic, high risk, low risk, divide whichever way you want to go. No further testing. I'll come back to what we want to do. Again, everybody is dividing high risk, low risk, ecos, yes, coronary angio, how quickly you go on to that. This is another one by Narinder Rawal. Now, I want to come to this, our thing, medical history, physical examination. You have already said, but I think we need to do all of them at the top.
Of course.
Vinayak, history, examination, risk factor.
I think they are all interrelated in the sense when you take medical history, you will be talking about all the other three in any case.
Okay.
So I think that is part of the medical history and a detailed, getting to know the patient.
Yeah.
And that will determine what we, ask for him after this process.
So all your patients, you will do medical, of course you will. Physical examination, of course. Risk factors, you will identify. Functional status. Shweta, out of the second line, second row, ECG, echo, stress echo, CPET, will you do it in all patients?
Actually, we would do an ECG and an echo. But most of the patients who are either on inotropes already or in HE, once they've reached that stage, it's very difficult to do a stress echo.
Yeah.
And CPIT we had introduced a long time ago, more as a learning thing as to how, let's see how, how it works out. We did a study that was, it's not a part of our exercise algorithm, is not a part of our workup. We don't even have the machine anymore.
Yeah.
We used it in ILBS, we procured the machine and we used it. But I can't
Sanjeev?
say 12, 14.
There is no question about these four, but this stress echo, I would like to not to do stress echo in all patients going for liver transplantation. That is probably the liver transplantation society recommendation, but I probably think the stress echo should not be done in a low risk subjects. Like I probably in the hepatology, you must all have read a couple of years, I think it was in 18.
We can see you now, Sanjeev.
And because stress echo, I think probably we can just omit stress echo try to find the patients in which we can omit stress echo because it is not helping.
Yeah, I think we would also, in our heart of hearts, I'll tell you our small data from 17 to 19 plus. So little over 3 years, 850 patients I had a look. 3 patients were DSC positive.
Yeah.
They went on to do their CAG, all normal. So not a single DSC positive patient had anything. So you're right, I agree with you, but I think we still are not able to, shrug it away. We still are doing it. Our practice is still DSC.
I think we should.
Don't know. Yeah.
The more we are working, I think we should
I totally agree. Coming to the
stress.
next line, calcium score, stress thallium, CT angio versus conventional angio. So where do we stand? Calcium score, has Vinayak convinced everybody about calcium score? Sanjeev?
I'm not convinced. I don't think. I just say it is one of the tools.
It's one of the tool. I mean, you are designing something. Okay, look, somebody is high risk. Will you think about
if it is more than 400, if it is the DSC positive, I would follow the coronary angiograph as I'm following in all cases.
Okay. Vinayak?
So see, I'll try to very briefly, look at the algorithm. Tell me like if you have a 25-year-old or a 30-year-old person who presents with, a need for liver transplant. Obviously, I'm not bothered about doing a stress echo and all. Yes. In India, we're getting CAD at less than 40 years in a lot of individuals. So if I take a cutoff of say 40 also, now most of my patients are going to be having more than 2 risk factors. If we include even the age-old 2012, guidelines, which said even left ventricular hypertrophy, enlargement, etc., was a part of risk factors for CAD and these patients. Now, I'll tell you why DSC is important, because we know that it's picking up coronary artery disease is poor, the prevalence through DSC. But you do look at the mitral regurgitation, the PA pressures, the dynamic gradient, you're looking at the cirrhotic cardiomyopathy unmasking, you're looking at HPS also in that same one test, and it gives you a lot of information in a single patient. Now, suppose the patient has 2 or more risk factors, I would definitely do a coronary CT calcium score because it is low, the money is not too much involved, the risk factor is 0. So it gives me an idea about where I stand in these patients. If the calcium score is very high, I can push it for an angio or a CT angio depending on the patient profile. Suppose the creatinine is high, I may not do a CT angio at all. If I may go for a very, check shots in a coronary angio. So I think but I would definitely propose CT calcium score to be part of the algorithm in most patients. And believe me, we have enough experience over the last 10 years that it works.
Yeah.
It actually gives you a third eye to look at these patients. You may be missing out on 90% of the patients with CAD if you don't do a calcium score.
Great, thank you.
Does it? Okay.
Yeah.
Now, does this special CT, does it correlate very well with the other CTs, normal CT score?
Yeah, it does.
If you don't do the gated,
everybody
if you do not
does.
do the gated CT and then...
It doesn't matter. A calcium score can be picked up quite well by most centers.
Great, thank you. I think our time is up. We could continue for a long time. I'm sure Vinayak is all game for it. and so is everybody else. Thank you very much. I hope it helped designing how we go about doing our patients for cardiovascular assessment. Thank you, team. Thanks a lot.
Thank you very much.
Yes, sir.
Thank you.
Thank you, sir. Thank you. Now we'll move on to next session. The next panel discussion is on the topic antimicrobial stewardship in liver transplant. And this session is being moderated by Dr. Neha Rastogi. Dr. Neha Rastogi is a consultant infectious disease in Fortis Hospital, Gurgaon. Among the panelists, Dr. Pooja Badhwa, she is Associate Director, Critical Care Medicine, FMRI, Gurgaon. Dr. Varya Krishar, she is Associate Professor of Surgery, Division of Transplantation, Stanford University, Stanford, USA. Dr. Vaishali Solao, she is Senior Consultant, Anesthesia and Critical Care, Mumbai. And Dr. Dalim, he is Additional Professor, Department of Anesthesiology, Pain Medicine and Critical Care, All India Institute, New Delhi. Dr. Neha Rastogi, over to you.
Hello, everyone. Thank you so much. So without wasting further ado, let's just start the session. So we all know that most of the time, even the last panel discussion, we have seen that, yes, the infections are the major causes of the morbidity and mortality in the post-liver transplant settings, and they complicate the further scenario and leads to a poorer outcome. So the antimicrobial usage, even in the terms of the antibiotics or antifungals or even antivirals, are a very important component of this antimicrobial stewardship. So not to jeopardize the outcome of the patient, and at the same time rationally using the antimicrobials becomes a very important proponent, and that customized from the case-to-case basis. So let's just go through the series of couple of cases, and then we can have a more better discussion on the antimicrobial stewardship. So just share the screen. So is the screen visible to everyone?
Yes, Neha, it is.
It is. Right. So let's just start.
Please, yeah, everything is visible. You can start.
Yeah, but actually it's not scrolling then henceforth. So, all right. Okay. So let's just start with the case right away. So we have a first case of a 57-year-old male patient who is suffering from hepatitis C cirrhosis with the MELD score of more than 20, not a known MRSA carrier. He underwent a LDLT with the CMV of himself and the donor being positive. So the immunosuppression regimen consists of the triple therapy with TAC, MMF, and PRED, and the initial course went uneventful. The labs were showing more or less the HB stabilized at 11.5, TLC mildly neutrophilic leukocytosis, and the platelet of 94,000. With the mildly raised creatinine, rest parameters were all normal. So first question to Dr. Kirshner, considering you are a transplant surgeon, so what kind of antimicrobial prophylaxis you would like to choose for this patient?
Thank you for the question, and thank you for your invitation. So this is a living donor recipient. They're definitely at high risk of bacterial infections as well as the fungal infections. So we usually would start them on the broad spectrum antibiotic covering broad spectrum gram-positive and negatives, although the most common infection that's been shown was bacterial infection in this population would be enterococcal infections. In terms of fungal prophylaxis, usually at least at minimum is the fluconazole for a week. However, our practice has been actually for living donors to do mycofungin as more broader spectrum prophylaxis. Of course, as a transplant patient, something as a CMV prophylaxis is important. Again, depending on the CMV risk of stratification, our practice has been either 3 months or 6 months CMV prophylaxis, and that usually would depend on donor and recipient status. So if the donor was positive and the recipient was negative, it's the highest risk, and we would actually provide Valside for 6 months. Also, in our practice, we do PCP prophylaxis for those patients, usually with Bactrim. Thank you.
Right. So considering this patient as a moderate risk for the CMV reactivation, any discussion, any change in the dosing regimen, 450 or 900, which would you like to choose over one over the other?
Usually we do 450 for the liver transplant recipients. For our renal transplant recipients, we actually do higher. We do full dose, but we also follow their white count in liver transplant patients, because very often they become, their white counts are quite low.
Right. And in fact, the latest trials have shown that the 450 versus 900, they have hardly any differences in terms of the CMV reactivation. So the one is over the better, because it can cause the neutropenia in the longer run, for sure. So moving ahead, so this patient has been started on the antimicrobial prophylaxis, as mentioned, and the patient was started actually on the fluconazole. We also started the Valga and cyclovir, and we started on the ciprofloxacin sulbactam. So the patient was planned for the eventual extubation as a post-operative course was running smooth. And the day 4, while the patient was getting extubated, the endotracheal aspirate was also sent, which showed the vancomycin as well as the linezolid-resistant Enterococcus faecium with the 10⁴ colony-forming units and sensitive to daptomycin and tigecycline. My question to you, Dr. Pooja, what will be the next line of management in this patient? Dr. Pooja?
Yeah. So since the patient is an immunocompromised liver transplant recipient, we would, he's already growing ET secretion of organism, which is resistant to linezolid and vancomycin. But clinically, he was on oxygen, not showing any chest infiltrates, not mounting any fever, not requiring any supplemental oxygen. So he doesn't fit into the category of a VAP. So most likely it was a VAT. Now the recommendation for VAT in terms of colony count doesn't change in an immunocompetent or an immunocompromised patient. Since the colony count is insignificant, which is 10⁴, so it should not be treated at this point of time. Or if you want to treat it, if there is mild leukocytosis and considering that the patient is immunocompromised, we can give him antibiotics in the form of what did you give? It was LRE, it was LRE and VRE.
Yes.
So you can give him daptomycin or tigecycline, but we all know that tigecycline doesn't work in liver, in the lung. So I think better choice would be a daptomycin.
So any other person, thank you, Dr. Pooja. Definitely, first of all, we should not consider this as a pathogen itself, because like you said, that it fits into the criteria of VAT. Per se, the Enterococcus, though they are very important opportunistic pathogens, but they are a very uncommon causes in terms of pneumonia being considered, even in the immunocompromised or an immunocompetent setting. Any other choices from any other panelist I would like to know in terms of, say, for example, if we're going to treat it, considering this patient to be given as a benefit of doubt in terms of transient leukocytosis, and the patient is still going to run for a few days in the post-op in the hospital, any other different choice of antimicrobials, Dr. Vishali?
Probably give ceftaroline for SAMIL. Daptomycin gets inactivated by the pulmonary lining, so it's not really indicated in MRSA pneumonias. So for MRSA pneumonia, since it's also linezolid resistant, the only drug which probably would be indicated here would be ceftaroline for summer.
Right. So ceftaroline is also considered a good drug of choice for VREs and a LRE. However, if that's not available or sometimes it's very difficult to procure because of the cost-related issues, tigecycline can still be a good option to use in the pneumonias. We have all seen that there are beautiful papers coming up of use of tigecycline in the Acinetobacter baumannii pneumonia, but at the dose of 100 mg BD. So we have seen also, and there are a couple of studies which promote the use of tigecycline at the higher dose, 2 or 3 times higher the dose of the M.I.C.E based dosing curve in the tigecycline that can work also in the pneumonias. So you are absolutely right. Daptomycin gets inactivated by the lung surfactant, and hence it does not be used for the pneumonia-like category. So moving ahead with this patient, we didn't use any of the antimicrobials which we have just discussed in this patient because we considered this as to be a colonizer and a VAT. And then the patient went ahead with a similar antimicrobial regimen which he was on initially. Now, with the same continuation, on day 8, the patient became tachypnic with initially the low-grade initial fever spikes and then the rising lactates on the ABGs. And correspondingly, the TLC also started hiking up to 16,000. So with this constant moderate fever spikes and now the respiratory distress regarding the BiPAP support, we escalated antimicrobials to meropenem. But then due to the respiratory failure, the development of encephalopathy, the patient eventually got reintubated on the post-operative day 8 and the antimicrobials were further stepped up and we sent all the febrile workup. The procal was 0.24. So with this continuous fever and the increasing infiltrates, the cholesterol was then eventually added and the patient was switched from teicoplanin to tigecycline because we had a previous culture sensitivity at least for something. Now my next question to Dr. Dalim, that what are the differentials? First, seeing this HRCT chest films, we have a lung section on the left and the soft tissue on the right. What are the differentials coming into your mind? The patient is already on meropenem, now tigecycline with cholesterol. The patient is still not improving. Respiratory distress is still worsening. So what are the other options and what are the other escalation in terms of antimicrobials? Dr. Dalim.
Yeah, thanks. Clearly the patient has gotten hospital-acquired pneumonia or probably a VAP, most likely. And I would not think Enterococcus to be a predominant cause of pneumonia. Given our epidemiological data, I think most likely it can be an MDR organism like any gram-positive bacilli to be considered first. However, we should rule out at this point of time possibility of fungal or pneumocystis pneumonia as well. And at the same time, we must ensure that the antibiotic therapy which is being given, like I think colistin, meropenem, and tigecycline, right? So we must ensure that the dosage and the schedule is proper. Like for example, I will ensure that the meropenem is being given as continuous or extended infusions. Tigecycline dose is at least 100 milligram BD, as you have already mentioned, for the respiratory infection. So with this background, I will send further cultures and diagnostic workups to rule out MDR organisms, fungal and PCP, and wait for maybe around 24 to 48 hours. If the patient doesn't respond, I will empirically upgrade further antibiotics pending culture reports.
Right. So Dr. Kirchner, any other suggestion?
I think I would just go ahead. I agree with Dr. Baidea. Thank you.
Right. So like Dr. Baidia has mentioned, so this shows a clear consolidation with the infiltrates both sides, more prominent on the right lower lobe. Though classically this radiological pictures doesn't fit with the PCP, but yes, in the post-transplant settings, we always have to look for the things which have caused the acute hypoxia. And PCP is one of the differential. And as we mentioned that over the period of 24 to 36 hours on the existing antimicrobials, the X-rays seem to be more worsening and the patient is getting land up into severe ARDS. So after no improvement on the triple duct therapy, we then decide to go ahead with the bronchoscopy and to send a biofire panel. And along with that, we also send the experts and the AFBs, the ball calectomenin, fungal stains, they were all negative. Cultures while being awaited, Looking at the right side, the majority of the DNAs are not detected in the entire panel, which we have just seen. So what are now the differentials? Dr. Vishali?
So, Neha, unfortunately, I can't see the screen properly. You are in a mode where the edges of the screen are not seen. But I'm assuming that all the gram-negative bacteria which are seen on BioFire are negative, right? That's what you're saying.
Yes, yes, yes.
Right. So we'll have to think of, I mean, normally I would have expected in this patient either a Klebsiella or Acinetobacter in my ICU, because that's the commonest cause of a VAP in our ICU. Klebsiella more than Acinetobacter, we practically don't have much of Acinetobacter. But if the BioFire is not showing Klebsiella or Acinetobacter, then I do think of organisms which are not captured in the BioFire. And fungal will definitely be on my cards here. So Bal galactominin has been sent that I can see, but the report will take some time. So I would definitely like to wait for the Bal galactominin, pending which I would initiate this patient on amphotericin actually. Because they don't give you too much time actually. It's always easier to de-escalate rather than to sort of go up once you get the reports. And other organisms like other gram-negative bugs, which you normally do not capture on the BioFire. So I know that it could be Sternotrophomonas, or it could be other Prevotella or other bacteria, which are not on the panel of BioFire.
Absolutely. So Dr. Pooja, any other comments?
No, I think we have covered all the aspects of the microorganisms which can cause infection in this kind of patient, starting from bacteria to the fungus.
So any thoughts on viral etiologies also?
So the
looking at the CT and the X-ray.
HRCT is not very classical of viral actually. Yeah. So I would go more in favor of bacterial followed by fungal. There is this little bit of cavitation that I can see in the right lower lobe. So cavitation indicates, either it's cavitating bacterial pneumonia or a fungal pneumonia, or this is a very acute setting to even start thinking of nocardia or anything. I would put it to bacterial versus fungal.
Absolutely. So we also escalated because there is always has been a doubt, and we always escalate to amphotericin for a better lung penetration. And yes, the Bal galactominin eventually came out to be negative. And as you predicted well, the organisms which were not covered by this BioFire, but can cause similar presentation because the patient has been in hospital on multiple devices, on the circuit of ventilator, on cholesterol. So these bugs have their all escape advantage to now grow up. So the culture grew Stenotrophomonas maltophila, which was sensitive to the, this was a typological error, which was sensitive to the minocycline and intermediate to cephalosporin sulbactam, as well as levofloxacin. So patient was started on minocycline and we stopped tigecycline eventually. And after 7 days of therapy, eventually the weaning started, X-ray improving. However, in the view of prolonged anticipated weaning, the tracheostomy was done. And we also stopped the polymyxin B. So after the end of this particular case, the major points which we really need to highlight is that we not to treat every culture, of course, and the empirical antimicrobial choices, as Dr. Vishali also mentioned regarding the DAPTO and the TG, they precludes the local antibiogram, the PKPD characteristics, and the site penetration of each antimicrobial. And of course, the biofires and the use of the newer rapid diagnostics, they're always to your rescue, with the limitation and interpretation of each test has to be kept in mind. And as far as the hospital and transplant settings are considered, atypical at times do become typical. So any comment on the dose escalation in minocycline? Dr. Dalim. I'll just show again the M.I.C.E curves and the sensitivity pattern for your help. So Dr. Dalim, any change in the dosing pattern would you like to do for the minocycline? This is just a last point for the first case.
Yeah, I think we'll start with 200 milligram only and then give a BD dose of 100 milligram.
Right. Would you like to escalate up to even 200 BD?
Yeah, of course, depending on the response. The
right.
M.I.C.E is, I think, 2, right? Yeah.
Yes.
So depending on the response, we may have to escalate to 200 milligram BD as well.
So this perspective has also arrived in the last couple of years, where we have seen that the M.I.C.E breakpoints actually helps us to decide the dosing regimen. So 2 is just a borderline for a minocycline to be interpreted. So if we see that the patient prolonged weaning is being anticipated and the x-rays are started showing the mild clearing day by day, it's preferred to start up with the 200 BD dosing, and we can tweak the doses based on the clinical response. Right. So moving ahead to the next case. Yeah.
So, we used to give colistin plus minocycline whenever we suspected Acinetobacter. And we found a lot of liver enzymes going up in the post-transplant phase. Minocycline can be hepatotoxic, and SGOT-PTs do get affected by minocycline. So somehow with our experience, we kind of abandoned the use of minocycline much post-transplant. And I'll be very skeptical of giving a higher dose of minocycline post-liver transplant. I couldn't see the M.I.C.E for levofloxacin because that also would have an excellent lung penetration.
Yeah, so yeah, please. So levofloxacin was intermediate. This is the thing, 4.
So it is really a tough situation. Trimethoprim sulfamethoxazole also will be hepatotoxic, and will be minocycline. It's a tough choice to make, but we have seen a lot of transaminitis with minocycline when we used to use it, assuming to treat for Acinetobacter.
So you're absolutely right in saying, but the idea is that if we have such a pneumonia, and if we have a daily follow-up with the liver enzymes, I mean, of course, like we said, that we have to choose the bestest to become the bestest in the outcomes. Yeah, absolutely right. So going ahead with the next case. So there is another 54-year-old patient who was followed up for a year with the diagnosis of CLD. And he has been diagnosed with the diabetes and has the CLD NASH related. With the MELD of 23, the patient has undergone right lobe liver transplantation from the living donor with the appropriate pre-transplant workup. On the first day, the standard immunosuppressive protocols were being given, again, the TAC, MMF, and PRED, with appropriate antimicrobial prophylaxis, which we just discussed. So going ahead, so on day 8, with the smooth post-operative pose, we have a plan to remove all the drains and the CVC axis. Foley's was also removed and drains also got removed in the day 10. But we were skeptical in removing the CVC axis because the patient has a very difficult peripheral axis. So on the 10th day, the patient started developing fever, tachycardia with the borderline BP, the blood pressures, and the worsening lactate acidosis within the first 12 to 24 hours. And if you are not able to see the blood image on the right side, it's clearly showing the compensated metabolic acidosis and the lactates rising up to 7.4. So going ahead, with all the fever workup being sent, the blood analysis also showing the leukocytosis, increased CRP, and the procalcitonin of 4.5. Now, the patient started with the treatment of meropenem, teicoplanin, and the antifungals were also escalated to Anidula fungi. The urine culture showed 10⁴ Klebsiella pneumoniae, which is sensitive to meropenem, so we continued the same. And the blood culture, on the contrary, shows the Candida auris, which is sensitive to the voriconazole and all the other echinocandins and amphotericin B, showing resistance to fluconazole as expected. Now, going ahead, Dr. Vishali, next step, any change in the managements?
Yeah, so before managing this patient, what we follow in our unit is that when there is a difficult access, IV access, and we are at day 4 or day 5 post-transplant, we tend to put in PICC lines and remove the central lines and the sheets which were put intraoperatively. So we tend not to keep those lines longer, and because they do need IV access, and keeping the central line, we have a very aggressive policy for putting in PICC lines. Now, as far as this patient is concerned, it's a bit heartening to see that the M.I.C.E for fluconazole is 8. I would have expected it to be, completely resistant, and we are seeing M.I.C.s in hundreds, for fluconazole, very high resistance. So you are actually lucky that this is relatively, like, voriconazole is sensitive. I can't see the entire report, but I'm assuming that echinocandins and amphotericin is also sensitive. So I completely, we tend to use mica fungin as compared to Anidula fungin, and we tend to use, that may be related to our M.I.C.s, of course. So we tend to use 150 milligrams of mica fungin whenever there is Candida auris. So we use high dose mica fungin. And if we don't find a response in 4 to 5 days in terms of the CRP, hemodynamics, and of course, the repeat blood culture, which still is growing Candida auris, then we tend to add another agent and another antifungal. But yes, the central line needs to come out ASAP. The moment you get the Candida auris report, you need to change the central line. The device has to come out.
Right, absolutely. So is Dr. Kirchner there? Okay, all right. So Dr. Dalim, any differences of change, or what are the practices over at your place regarding the usage and the keeping those lines for more than a week, especially when we know that they are landing up with they have the potential to land up with the line infections? And regarding this particular scenario where we are stuck right now in terms of the antifungals.
No, I think I completely agree with Dr. Vaishali. So just for intravenous access, we may not would like to keep, central line in situ. Rather, PICC line should be inserted in all the patients and remove the central line. And regarding the choice of antifungals, patient is already on annular fungin. We don't have the reports of annular fungin, I guess, in the M.I.C.E. So we would like to give either micafungin or a liposomal amphotericin B in this patient.
Okay, and the latter choice will depends upon?
Sorry?
Yeah. So go ahead.
Yeah, and the other precautions related to Candida auris should be taken in the ICUs, like the infection control policies, the barrier precautions and everything that has to be taken.
Absolutely. So I was asking you about the choice of the latter over prior, as in why liposomal amphotericin B as compared to anidula fungin or say the other echinocandins?
So Candida auris, we presume, will be intrinsically resistant to all the azoles, and even there is significant proportion of cases like 20 or to 40% cases will be resistant to even the echinocandins. So this patient already on anidula fungin for like a few days, I guess, maybe 3-4 days or so. So in that situation, I would have low threshold of starting liposomal amphotericin B. But as Dr. Vaishali mentioned, micafungin is of course a good choice. We can switch over to micafungin and wait and see the response and then take a call.
So Dr. Pooja, one question to yourself. I mean, amongst these three echinocandin, of course, Casco will always remains a little skeptical choices as far as the post-liver transplant patients are considered. And what about the mica versus anidula in terms of the liver toxicity?
See, in our unit, we have seen that although the effect is not doesn't differ much, but mica fungin works better than the anidula fungin, which may be because the other units are also using anidula fungin a lot. Mica fungin is still not being used by a lot of people in the ICUs. So, and the liver toxicity profile also, mica fungin is better tolerated than anidula fungin.
Right. So if I just point out, so amongst all the three echinocandins, actually anidula fungin is the most safer to use in any of the post-liver transplant settings. And of course, it's one of the very good drug of choice in critically unstable patients too. But if you have a choice from the cost-effective point of view, mica fungin plays a very good role because it does not require any loading dose. It's preferably a liver-safe drug. And of course, from the cost-effective, which I have just mentioned. So yes, Dr. Vaishali, as per your plan, we have definitely got the CVC change ASAP. And do we need to do the ophthalmological evaluation and a 2D echo? Though we have done in this case, the 2D echo was clear, TE was not performed, and the opthal evaluation was also normal. But I want to know your comments about how much routinely you screen the patients of candidemia.
So all patients of candidemia, I mean, this is auris, but otherwise also with candidemia, you must subject the patient to a retina exam, and 2D echo probably, if there is a persistent fungemia, then I would definitely do it. But retina exam should be a part of managing candidemia. TE, we routinely do only if the transthoracic shows positive finding, or there is persistent fungemia despite 2 antifungals, and when we want to then be sure that yes, we are not missing on the transthoracic, then we would go for a TE, but usually we stop at 2D, at a 2D echo, a transthoracic one.
Right. So Dr. Dalim, how about the practices over at your place? Are you routinely doing the ophthalmic examination?
No, but if the patient is conscious, then we'll go with the patient's ophthalmic symptoms. But in a patient who is on, say, ventilator or sedated, in whom you can assess basically the ocular symptoms, then we'll obviously go ahead and do the ophthalmic examinations.
I think it has an implication of the antifungal to be given. So it's essential to do the retina exam.
So we will be coming to, let's just hear from Dr. Pooja, the third panelist. So Dr. Pooja, practices at your place regarding the ophthalmic evaluation and echo.
Yes, we definitely get an
cardiac
ophthalmic
workup.
examination done in a patient who grows candida. Along with that, as rightly said, we also usually do a transthoracic echo rather than a TE. But definitely, ophthalmic examination is mandatory in these patients.
Okay, so just to point out that, of course, the ophthalmic examination is very mandatory. But again, the recent guidelines from the American Society of Ophthalmology has come, and a paper which just got published yesterday, which was a very good systematic review. It has shown that they have screened almost 15,000 patients of candidemia, and they found the overall cumulative incidence of ocular candidemia in 1.3% cases only. So if the patient is conscious enough, if they have no signs and symptoms suggestive of any kind of ocular involvement, there is no hard and fast recommendation to go ahead with the ophthalmological examination at a first place. But yes, if your things are permitting, go ahead, because it's always preferred to have, as it decides the duration of antifungals. And also coming to the choice of antifungals. Now going ahead, the 5th day of antidular fungin, the patient also developed the symptoms of persistent headache. Brain imaging came out to be normal, and eventually developed the mild heaviness.
Excuse me, Dr.
And blurring.
Neha, could you please just take care of the timing, please? Times already.
Yeah, just 5 minutes more. Yeah.
Yeah, thanks a lot.
So the ophthalmological examination was reconsidered, and if you see that there are 2 focal yellow retinal lesions in the center of the right retina and a macula. So differentials at this point, Dr. Dalim.
So differentials, of course, first in the list will be Candida retinitis, and CMV and toxoplasma we should also rule out, but most likely it will be Candida.
Right. Dr. Vaishali, would you like to add on to some list for the differentials?
Maybe infective endocarditis giving rise to emboli. I'm not sure. Probably.
Dr. Pooja, any other?
No, I think all the 4 have been discussed. I would also go with the Candida first, then CMV and toxoplasmosis. And rightly said, as infective endocarditis leading to embolic.
So as compared to the CMV retinitis, we have more bigger plaques like thing and the cotton wool spots in the Candida retinitis. So for our ophthalmologist, it was a clinical diagnosis, very well going into the favor of Candida retinitis. CMV viral load not detected in blood. However, we didn't perform the aqueous humor workup for the same. So what is the next line of management now? So as we were discussing in terms of the choices of the antifungals, do you need to change the choices of the antifungals looking at this picture now? So Dr. Dalim?
I think we'll go ahead with liposomal amphotericin B.
Okay. Any other specific reason for that? Because the patient is on antidular fungin as of now.
But on the antidular fungin, like I think the response depends on the clinical response. The patient is already on antidular fungin for around 4 days. And if there is clinical deterioration with the background of retinitis, liposomal amphotericin B should be considered, I think.
Right. So Dr. Vaishali, yes, your comments?
I think for the ophthalm presentation, you will have to give liposomal amphotericin B. Otherwise, if there was no ophthalmic presentation, then one could have considered adding because your M.I.C.E for voriconazole/isavuconazole is also very good. But because of the retinitis, the liposomal ampho-B will be the drug of choice.
So you're right. So voriconazole, though, have a very good ocular penetration and a neuro penetration, but in the liver transplant unit, with the drug interaction with the tax and all, everybody gets so apprehensive by using the voriconazole for the drug of choice. The next line come up with the liposomal amphotericin B. So any experiences with isavuconazole?
Yes, we have.
Either of the three. Yeah.
Have combined. We've recently, you are lucky this patient did not have renal dysfunction, but most of the time they'll end up in renal dysfunction with creatinines ranging between 2, 2.5, 3. And then liposomal amphotericin B can be, additional factor, though I know liposomal is less than the conventional. So we tend to choose to add isavuconazole these days. Well, a couple of cases, so I can't really say, but we've had a decent response. Just 2 cases, we added isavuconazole after the echinocandin.
Right. So alternative or salvage therapy, we can very well use the isavuconazole because good penetration, almost zero drug interaction, no renal, no liver modification, IV oral equal. So we can very well use isavuconazole as far as your cost and the other factors allow to use. So the other preventive measures, Dr. Dalim has already mentioned this, so I'll just skip this. So we need to very well take care of the infection prevention practices when Candida auris takes place. So not only in terms of hand hygiene and everything, we need to have a proper decolonization regimen for that patient, has to be isolated, has to have a chlorhexidine decolonization. So a quickly third case, I'll just wind up in another 3 minutes, quickly 10 seconds to each of them, and then we'll just wind up. So 59-year-old male with type 2 diabetes, HCV cirrhosis with the portal hypertension and a refractory ascites, almost a decompensated course with HE, SBP and HRS. And then eventually after 4 weeks, when every catastrophic storm got settled, he was taken for LDLT with the modified right lobe. The donor CMV positive, recipient negative. So with the appropriate triple immunosuppression started on day 1, we have already discussed, so I'll just skip this transplant prophylaxis part. So post-operative day 7, the patient developed high-grade fever spikes with chills, high-grade up to 101. CVP line was in C2 with no obvious redness and tenderness. Paired cultures, urine routine and culture sent. Considering no need of Foley's catheter, we were initially planned to remove as a potential focus. We need to change it. And the meropenem was started. With the continuous fever spikes, initially added ticoplanin, and then the blood cultures, first ones came negative, urine routine showed pus cells and culture negative, with a high procal of 7.43. Fever still persisting with the variable intensity, and the patient developed hypotension with the AKI with 1 to 2 liters of the oxygen requirement, and the lactates were increasing in trend. Now, antimicrobials then to upgraded to polymyxin B with the ongoing antimicrobials, and we upgraded it to the annulula fungin. All the possible workup was sent. CMV was also negative, though it's a very early time to bring up with the CMV load. And the another post-op abdominal drain, which was last potential focus to be thought of, it was also taken out, and all the lines got changed. So the repeat second blood culture showed the gram-negative bacilli. And with all the supportive sepsis management ongoing, the fever was still persistent on the combination therapy. So my question to Dr. Pooja, what will be the next step of management, or what are the choices of antimicrobials? Now that on the 3 days of Miro, Targo, polymyxin B, and then the annulula fungin, what will be the next step of management? What are the choices?
The blood culture is already showing GNB, so most likely it would be an E. coli or a Klebsiella, followed by Pseudomonas or Acinetobacter. So, and the patient has already received meropenem and polymyxin B, and on top of that, he is deteriorating. So my guess would be he is having some XTR or PDR organism. So I think we should go ahead with some with the CARBAR testing. If we can get the cultures, and we can escalate the antibiotics to azithromycin, avibactam. We should do that.
Right.
We can do that.
So
yes.
Dr. Vaishali, any difference of opinions?
So I think if this grown a GNB, then I would just get a BCID panel on it, and I would probably get the bug and the resistance mechanism. and that would give me a better choice of advancing the antibiotic therapy after polymyxin B.
So say suppose this JNB and what is your normal course in your hospital settings, that on top of that, what will be the next obvious choices?
It will be Zavicefta Aztreonam, of course, but it could be, as you know, it could be a Sternotophormonas also. So normally, if there's a growth, then we just subject it to BCID so that we get the identification quickly, the blood biofire, that is.
Yes, yes.
That guides us the antibiotic therapy, and within no time you'll be able to give the appropriate, because it gives the mechanism of resistance also, the BCID.
So Dr. Dalim, if we have to increase up to Zavicefta Aztreonam, do we need to keep up with the polymyxin, or can we just take it out? So we have actually escalated this patient also on Zavicefta Aztreonam in the modified doses. So do we still need to keep up with the cholesterol?
No, I think we can stop it.
Yeah, Dr.
Right.
Neha, I think we are running short of time.
Yeah. So the last question. So this patient, we eventually went up with the Carba-R, and it showed the BLA-OXA48 gene. So patient was on Zavicefta and Aztreonam. Now, any last question to all three, 10 seconds each. Any step next based on this report? Dr. Vishali?
Omit Aztreonam.
Right. Dr. Pooja, any different suggestions?
No, omit azithromycin.
So Aztreonam and cholesterol, we both will be omitting, and the patient will be only kept on Zavicefta. So these are the learning points. So I think in the paucity of time, we won't be getting another discussion on the same. So thank you so much for this enlightening discussion for me, myself, and also for the other audiences. And we know that every patient requires a customized antimicrobial approach. And let's just take a pledge to have as much of the prevention of antimicrobial resistance by choosing the right antimicrobial at the right time with the right dosage. Thank you.
Thank you.
Thank you. I think it was very nicely conducted by Neha, and we really learned from the other panelists as well. Thank you so much.
Thank you, Dr. Neha. Thank you, Dalim, Pooja, and Dr. Vishali. Thank you very much.
Thanks. Bye.
Thank you. Thank you all. Bye.
We'll move to next session, that is Ethicon sponsored industry sponsored lecture on bleeding matters. This is a pre-recorded session and by Mr. Vivek Iyer.
Hi, good evening, everyone. Let me start by saying congratulations for this third episode of the International Congress of AILBS. Let me also thank you for giving Johnson & Johnson and Ethicon this opportunity of presenting in front of you the burden of bleeding and the value of adjunctive hemostats. My name is Dr. Vivek Iyer, and I lead the professional education wing for the Ethicon group of franchises. Surgical bleeding is a burden, and the surgeons have unmet needs. One of the famous surgeons, Professor Atul Gawande, has quoted that surgery has essentially 4 big killers wherever it is done in the world: infection, bleeding, unsafe anesthesia, and what can only be called the unexpected. Disruptive bleeding prevents me from moving to the next procedure steps where efficiency is the key. This surgical bleeding as a burden adversely affects patient outcomes, hospital costs, and resources to the extent that up to 68% of cases in open procedures experience major uncontrolled bleeding events, causing complications related to surgical bleeding and increase in resource utilization, may also impact and cause high mortality rates. The reasons for these consequences, because the bleeding is not controlled, could be divided as clinical and economic. The clinical consequences being hemodynamic instability, reduced oxygen delivery to the tissues, hypovolemia, increased risk of organ failure, so on and so forth. Whereas the economic consequences that I mentioned could be due to a repeat need of surgical intervention, blood products requirement, continuous monitoring, increased procedure time and return to OR, and increased length of stay in the hospital for the patient. Keeping this in mind, all the bleeding situations could actually be categorized into 5 scenarios, which could be namely continuous oozing, a problematic oozing or a problematic bleeding, bleeding from difficult to access areas, a potential rebleeding risk, and areas which have high pressure vessel bleeding or arterial bleeding. Now, the surgical hemostasis methods that are there are used to control these types of bleeding during a procedure. So what is the role of surgical hemostasis? It helps in improving the outcome of the procedure by controlling bleeding, improves visibility, decreases operative time. Meticulous hemostasis, if done, is critical for use of adhesion prevention modalities. It in the end causes decreased morbidity and mortality, decreased post-operative drainage, fewer transmissions, and so on and so forth. In the end, it is required for optimizing the patient outcome after a procedure. In this current scenario, which is hepatobiliary surgery and hepatic transplant, there are various methods of surgical hemostasis which are used, namely the surgical methods like vascular clamping techniques, inflow occlusion, which includes the continuous Pringle maneuver after ischemic preconditioning, intermittent maneuver, total vascular occlusion, usage of dissection devices for transection of liver parenchyma, which includes classical methods like scalpel, finger fracture, clamp crushing, or use of specialized devices like the ultrasonic dissection, hydrojet dissection, electrocoagulation using argon coagulation, radiofrequency ablation, so on and so forth. There are also other methods or anesthesiological methods to control bleeding or cause surgical hemostasis, which could be maintaining a low central venous pressure by using volume contraction, phlebotomy, vasodilation, blood products, and use of pharmacologic agents like antifibrinolytics and recombinant factor 7A. Let's quickly see, in spite of doing all that, there is still some bleeding that happens. And in hepatic resection as a procedure, there are various stages, and different stages come across different reasons of bleeding and also ways to control it. For example, during dissection, the hemostasis is achieved by identification of efferent and afferent vessels, and the blood loss is relatively minor. Whereas in the next stage, which is transection of parenchyma, the blood loss is related to surgical techniques, the quality of the liver, and the central venous pressure. The bleeding here or hemostasis here could be achieved by various dissection devices, which we just spoke. And finally, the stage 3, which is checking of the resection surface. The bleeding could be from broad surface where the resection has happened. And this is the place where topical agents could be of use. These topical hemostatic agents have a role in reducing blood loss from the hepatic resection surface after partial liver resection. However, the surgical techniques play a more important role. Having said that, the continuous oozing bleeding or the continuous oozing type of bleeding is what we'll be talking about, and the solution of choice that Ethicon could offer. This bleeding experienced by the surgeon happens in many surgical types, and often the use of topical absorbable hemostats can be put to control it. A quick glimpse of some details about the types of bleeding that we spoke about and some solutions that could fit. Now, these are just examples of solutions based on what we have. There could be others available from other organizations. So for continuous oozing, what we have as an option is Surgicel family of absorbable hemostats. Now, these hemostats are typically prepared from oxidized, regenerated cellulose. And the best part is it is ready to use right out of the package. Because of its mechanism of action, it has a proven in vitro bactericidal action against some of the commonly known multi-resistant organisms, which also cause SSI. This is fully absorbable in 7 to 14 days. And again, because of its mechanism of action, it helps in controlling capillary, venous, and small arterial hemorrhage. Under these oxidized regenerated cellulose family, there are multiple products available, right from Surgicel Original, which was the first to arrive, to something which we just launched in the market called Surgicel Powder. Now, all these products have different features that could benefit specific scenarios, but all of them come from the same trusted source and the same trusted family of oxidized regenerated cellulose from Ethicon. Let's quickly talk about the Surgicel powder, which is the absorbable hemostat latest that we launched. It is specifically recommended for continuous oozing, which can delay the surgery and is frustrating, especially on large friable raw surfaces like the transected liver surface. This Surgicel powder has a penetrating action, is 52% faster to hemostasis than its predecessor, forms a more durable adherent clot, is proven in vitro bactericidal activity, and gives you more precise delivery control during application because of the device and the tip it comes with. A quick glimpse on how it acts: spreads across the surface, which can be done with the help of the device. The blood saturates the material, providing a surface for platelet adhesion. And the powder, the particles of the powder also sink in deep to go to the source of the bleeding on the surface. Works fast to stop bleeding because of its larger surface area that is there, and forms a durable clot that won't wash away and won't rebleed when irrigated. What are the target bleeding scenarios that we can look at for this surgical specialty? Are the hepatic resection procedures where exposed wide raw surfaces of liver with multiple bleeding sites that may not be amenable to suture or ligation. One study, which is retrospective of 32,000 patients who underwent reoperation following hepatectomy, continuous oozing bleeding was to blame in 59.7% of cases. Finally, just to remind you again that this is the latest in the family of the Surgicel products of topical absorbable, but carries the same experience and the same trust that is put on the other Surgicel family. The other product that is noteworthy in this family are the Surgicel fibrilla, which is Surgicel which can be peeled into layers and be placed on a larger surface, and the Surgicel unit, which is a strong construct of the oxidized regenerated cellulose and can be used to wrap an organ and then pass a suture through it so that the hemostat stays on the surface of the organism and provide the hemostatic mechanism that it is designed to do. With that, I would like to end this session by again thanking the organizers for giving us this opportunity to speak about Surgicel powder for the hepatobiliary surgery. Thank you so much.
Dr. Iyer, thank you so much for this nice presentation. Myself, Ashish, one of the team members. Just want to know, we have been using all those products. Hi, Minu, how are you doing?
Very well, sir. Thank you so much. It's so good to see you.
So we have been using all the product range in this portfolio from Ethicon, whether it's original Surgicel and Fibrillar most of the time. But lately we have started using this Surgicel powder, especially in our laparoscopic donor hepatectomy. And we're really happy with the result and the area it covers and the way it works and while we are there and looking under the camera. But any particular scenario you will recommend the Surgicel powder over the routine Surgicel? Because in open surgery we are not using it. So to be honest, and I think one of the limiting factor is the cost. But having said that, if I put the cost aside, any particular scenario where I still feel that Surgicel powder has a better control and coverage compared to the Surgicel?
Sure. Dr. Iyer, you want me to take this question?
Yes, please. You go first and then I'll add up if needed.
Sure. Thank you, sir. It's a very, very relevant question. And our answer to that is Surgicel powder is very particularly recommended for only broad surface continuous use. If you have access, it's an open surgery. You can use Surgicel original or Fibrilla. But if it's a very, very broad surface where you might have to use probably 2 or 3 layers of Surgicel original or Fibrilla, that's the time when we recommend Surgicel powder.
Exactly. That's why we thought so. So I think we are doing the right thing. We are using the surgical and or fibrillar in our open donor surgery. We have full access. We can control. We can see it, everything. But definitely in our laparoscopic surgery, we are more and more cases now. We are going for surgical powder. Thank you for that. Thank you.
Thank you.
Thank you so much.
All right, Dr. Iyer and Minu, we will close this session for now, and you guys have a good night. Thank you so much, and we'll join tomorrow again at 4 o'clock Indian Standard Time. Thank you.
Thank you so much. Thank you
for
the opportunity. Good night.
Thank you, sir.